morning once again. Uh, I'm Dr. Alkali Olachema. I'm an anesthesiologist from Nigeria for hospital. Good morning once again. Of the I'm Dr. Alkali Olachema. I'm an anesthesiologist from Nigeria for hospital. Good morning once again. Of the I'm Dr. Alkali Olachema. I'm an anesthesiologist from Nigeria for hospital. Good morning once again. Of the I'm Dr. Professions. We'll be discussing around this theme. Today we'll be discussing about how this safety can be
September 1st to 4th. All African Anesthesia Congress will be in Rwanda. So this is the great event ever. And this was, the reason we pushed for this conference was to test if we can, because we are under pressure of the whole world to say, are you ready? Will you make it, or can we postpone and take another country? We told them we will make it. Last year, the FIGO was hosted. The African part of FIGO was done in Rwanda, in Convention Center. So if our colleagues can do it, we also can do it, because it's not about them, it's about the country. So we take the challenge and we say, we'll organize the whole African Anesthesia Congress. This is more than 1,000 people who usually attend, and if the better we organize it, the more people we'll invite. But if we don't take it serious, people will not join. People will prefer to stay home and go to computer. But as people like to go to Rwanda, let us also make them come to Rwanda. And we are sure we'll make it. That's why we announced this. We start tweeting it and telling them we are ready. So next slide, please. So this meeting, when we talk about safety, it's about to fill into a gap. There is a gap for us to be safe. And for there is a gap. A gap is defined either by the country or by international standards. And there is what we call global anesthesia. It is a worldwide decision about where the world wants anesthesia to be. And Rwanda is part of this move in global anesthesia. So we want to see the gap toward this global anesthesia and how to close it as Rwanda. Next. So this is how the Lancet Commission of Global Surgery maps the gap of anesthesia in the world. And as you can see, the countries in red are where the anesthesia providers are less than even if they put non-physician and physician together, they are less than 5 per 100,000 population. In Rwanda, putting non-physician and physician together, we were less than 1 per provider per 100,000. So this is a big gap. So from this, next, there is key messages delivered by the Lancet Commission about 5 billion people who can't afford safe surgery. 143 million additional surgical procedures needed in low and middle income countries each year. There is 33 million worldwide population facing catastrophic expenditure, paying for surgery and anesthesia annually. And investing in surgery is affordable and saves and promotes economic growth. Surgery is an indivisible and indispensable part of healthcare. So on top of this message, because it's so wide, because many of the time as anesthetists, when they say surgery, we feel excluded. So what we do, we dig down and say, let us break down the word surgery to see where is anesthesia. There is this word on the internet saying, anesthesia is the unseen friend of the forgotten son of global surgery. So surgery is the forgotten son, and anesthesia is the unseen friend of his son. So we think, next, for anesthesia, next, if the global anesthesia said we need to achieve 5 per 100,000 anesthesiologists per 100,000 population in the country, the requirement, next, is showing that, another one, is showing that, come back. It's showing that Rwanda, to achieve 4 to 5 physician anesthetists per 100,000, must train up to 600 by 2030. Why I say physician? The study done worldwide make the exercises around anesthesiologists. If you hear about SAO, surgery, anesthesiologist, and obstetrician, 20 SAO is an indicator of global surgery. And the A, most of the studies is talking about anesthesiologists. So, it is somewhere impossible to train 600 anesthesiologists in Rwanda, as it is impossible for the world to train 130,000 anesthesiologists in the world. It's impossible. We can't make it. So we have to add task sharing. This is another panel today. Task sharing. We need to be clever enough to define that we can't fill up the whole world of Rwanda with anesthesiologists. It is not possible. We have to share. There is a cadre who is doing more than 90% of the procedure, and they will keep doing up to 2030. So we need to invest and start defining the policy of task sharing, be it in anesthesia, in surgery, whatever. Task sharing must be well defined and well put in place. Next. So those are the indicators of global surgery for the universal coverage, health coverage. As you can see, the indicators are talking about safety, perioperative mortality rate, SAO density, which must be 20 per 100,000, accessibility to Bellwether Center, that is called accessibility, and Bellwether surgery per 100,000, volume of surgery. Those indicators used to be 6, but the catastrophic and the unexpected expenditure have been put in 1, which is called the financial risk protection. People should not be empowered or impoverished by undergoing surgery. People should not be paying the half of his salary to undergo surgery. This comes when there is not enough surgery, not enough centers. The private sector will take all and will make it very expensive. As anesthesiologists, I would like it to have more money, but as policymaker, you should protect your population. So we need to work on how to make surgery accessible and less costly. So that's why it is said that everyone should be able to access in 2 hours a surgical center. A study in Rwanda showed that we have enough infrastructure to be accessed in 2 hours. But the question is, what do those people access? Do they access an infrastructure, a building, or do they access the service? Which service? If someone in 2 hours can access to a consultation, it's good. But if you want surgery, can he access it in 2 hours? So that's why they define the Bellwether surgery. We will see it. So it must be 2 hours to access Bellwether surgery, Bellwether package. We will see it. Then the volume of surgery should be 5,000 per 100,000 population. Affordable, low cost. You know that in 2018, Rwanda signed the NSOP, the National Strategy for Surgery, Obstetric and Anesthesia. So those are the components of the NSOP we signed and we launched in 2018. Next. So about our country, we have, that is the pyramid of health system. We have 40 district hospitals, and we have provincials 4, and we have 4 referrals and 4 teaching. Though all the referral and teaching are called a referral. That's why they say 8, but it's 4 referrals and 4 teaching. So now, if we want to plan about anesthesia to be safe, how can we make it safe? Next. It means in the district hospital, patients should be able to undergo laparotomy, cesarean delivery, and treatment of open surgery, open fracture. Those are the 3 Bellwether operations. The basic Bellwether. A district hospital which can't provide laparotomy, safe cesarean, and safe open fracture treatment is not a Bellwether center. It is below a Bellwether. This is a must for a basic center. Then, as we are growing up, the provincial should do beyond the three, should do annual repair, contractual release, superficial, all those are beyond their weather. But you must first cover the basic. So now the anesthesiologist we train must be able to provide anesthesia for laparotomy, for cesarean delivery, and for treatment of open fracture. As basic, that is a must. Then, on top of that, can also navigate in others. So, by 2030, we must have a number of anesthesia providers in a district hospital in Mugonero, 6 or 7 of them, able to cover those basics, plus what the hospital can add on. That will be called the Bellwether Center. It will be safe because it has at least 6 to 7 NPS and maybe a physician anesthesiologist. Next. So now, the model as anesthesiologists we are thinking about for the next step. We can't wait until 2030 to declare that we can't make it. We didn't make it. We have to start planning ahead. How shall we achieve that safety? So we discussed about the model of hub and spoke. This is the model of healthcare we are discussing about. Is we should have a spoke, which is a district hospital, a Bellwether Center, with at least 2 operating theater, 1 physician anesthesiologist, and 7 NPS. So the spoke is the receiver of the service. The end user is called a spoke. The hub is the big center which help the spoke. So if we work on the hub and the spoke model, we can achieve. So it means we will have the spoke which is strong enough, the district hospital, the Bellwether Center, strong enough to provide Bellwether surgery, and the anesthesia team there must be able to cover at least 2 hours and provide while they are providing Bellwether surgery. So the surgeons are training for having district able to cover Bellwether. We should train also team to be able to cover Bellwether and anesthesia for Bellwether surgery morning, night, and weekends. That's why we say there should be at least 7 anesthesia providers so that they do the 45 hours per week and they can be there daily. They have right to stay home if they finish the night. They have right to leave. All those things must be catered for. If there are 7, see if one lady goes for maternity leave, others will cover, and so on and so forth. So now, if the spoke are like 7 around the hub, if the provincial hospital is an hub, the 7 districts will be around the provincial to refer to the province, not a district to refer to Kanombe. No, there must be a provincial which is strong enough to help the districts around. And the anesthesia team at the provincial must have strong anesthesia team than the one in the spoke. So that's why you see the spoke around the hub. So, and so on, and so you can show us the model. Next. If Rwanda can be covered like this, with strong provincial surrounded by spokes and referral hospitals in the corner as they are there, we can have very safe teaching hospital in charge of teaching. They are not these like tonight I had a message on anesthesia team where they had transfer at 7, 8 p.m. with just small cases, but disturbing the teaching hospital. So then you can't teach safely because you have to stay up to nights in the hospital because of a case which could have been managed at Kakiru, at Muima, but it comes to King Faisal and they start teaching. So that teacher who stayed over the night will not come tomorrow to teach because he stayed there for C-section. So if we can make such model of hub and spoke, then what will it require as number of providers? Next. Next. So if the 40 district hospitals can have 7 NPS and at least 1 anesthesiologist each, that is the number. The provincial hospital, if they can have 30 NPA and 5 anesthesiologists this is the number. The referral hospitals, this will be the number, and the teaching hospital, this can be the number. So if you calculate like that, even the 500, which is in the strategy, become less. That will be the motto, because we need some scholar who will be teaching, who will be doing policy makers. We end up with, next, we end up with this number, or this check. It will be 1,000 NPS and 150 PS. So if you see for the physician, the number is correct in the strategy. But for the NPS, the number is still low. What we are planning for is still low. We will need more than the 500. So that's why the whole effort of the country must be to invest on how to train safe NPS, and even 3 times the number we have now. The more we keep discussing meeting after meetings, the less safe we are going to unsafe surgery. By 2030, we will declare Rwanda didn't meet the SDGs in surgery because anesthesia was forgotten. So I try to scale up my language because the chair of the surgery is here, the chair of surgery is here, so I have to keep telling them, hey, don't leave us behind. We have to go together. Otherwise, you will reach there without standardization. You can't do operation. Please, wherever you get the grant, don't forget us. We are together. So next, how to close it? Next. So this is a table we did together in 2017 before launching the NSOP. So in 2017 we were there. So we planned that we should be increasing the number slowly. So we were planning to have 45 anesthesiologists in 2022, and 60 in 2025, and 100 in 2030. We can say where we are. In 2020, by November, we may have 45 physicians. 2020, next year, when we graduate this batch of those are the 40, we can have that number, even beyond. But our friend NPAs are still behind. We are leaving them behind. So there is no success without that friend. Because we will never cover that spoke. That's why in each meeting we do, we should think about our friend. Is he with us? You remember, for those who read the Bible, Joseph and Mary who left the church, they went and they forgot Jesus behind. Then they realized Jesus was not with them. Then they come and say, we look for you, you came to find you. He told them, I'm where you left me. If you leave me in the theater, you will find me in the theater and alone. But if we go together, we can multiply to find other NPAs so we can cover Monero and other district hospitals. So next. So if we consider all the drop-off, yesterday we discussed about the drop-off. There is a drop-off, drop-out, people are leaving the profession. So next we need to start thinking about, that's where the number of 20 came in. We have to recruit 20 anesthesiologists per year. Even beyond, because for 2 years we didn't recruit. So the university, we request to recruit beyond. Otherwise, we'll consider Kanexa. Even though I know Shema and HLH, they don't want to hear about Kanexa because the university should cover it. But if the university can't cover us, we will consider Kanexa. Because overall, the failure of Anesthesia will be upon our shoulders. So we need to cover this gap. For NPS, please, next. So we need at least per year 120 student NPS to reach that number. It seems big, but you will never cover thousands of them. You will never cover the spoke and the hub without recruiting a massive training, students for training. Otherwise, we are going for a failure and we'll start cooking up data. Instead of cooking data, let us recruit and train now. So for anesthesia, no. So for anesthesia, for physician, we are already failing because for 2 years, we recruit only 3. So the gap is huge, we need to catch up. For NPS, even the program is questioned Now people are not recruited, so we are also behind. We need means to fix those numbers. Next. So, this was the scope of practice we defined in 2015-16, which seems to be questioned now. But if we change this, it must be again official. Either we keep the nursing background only, so we phase out all the clinical officer, or if we consider the two, we keep the two pathways and continue to train people, because it was planned for, it was signed by the minister. At that time it was Minister Diane. Yeah. So if we stop it, it must be reconsidered and officially phase out and bring in another scope. Next. So we need a joint effort, Ministry of Health, university, professional bodies, to train people, to consider the hub and spoke. We train for that spoke. We train to make Burunda safe, with 7 NPS stable, with incentive to stay there. How can we make Murunda attractive for that anesthetist in Murunda? It is when we think about that nurse who is in Murunda. She has a land, she has an husband, and the uncle is there. If you give her training to a nurse anesthetist, and she goes back home, that one will stay longer than my young brother Joseph, who I know after finishing, even if you send him to Murunda, he will not stay. He will come back to Kigali. He's already a big man. So we need to think about the politics around anesthesia. People stay in the village because they feel like there is a family around. They have something which makes them busy. So why we are saying about nurse anesthetists, because those nurses in those villages, in those areas, are already stable. They are attracted to stay if they are trained than the young people from Kigali sent to work there. They will come after 1 year, come back and do another job. So that's why we think about training those A1 nurses who are already there working, train them for anesthesia and send them back, sponsored by the Ministry of Health. Those people will be more sustainable than the young people we are recruiting now. Next. So, let's take home message. They have spoke. In whatever planning we are doing, think about the spoke. The farthest district hospital, to make it a safe hub for bellwether with 6 to 7. If all the 40 districts are covered, then the provincial, then that's where the number should be extracted from. A clear pathway for physicians, for NPS, and to achieve a timely, affordable, safe anesthesia. So next, again, we are inviting you for this. We need your effort, we need, Godfrey, we need money. Bibram, we need money for this conference to open. So please, you are all welcome. Thank you very much. I can't stop without saying welcome to Dr. Musiu, stopped all his clinics to attend this conference, and Dr. Moga. Soon leave the microphone to the MC. Oh, Dean. Welcome, Dean. We are very happy that you found time for us. And we know today the panel will be very, very hot because there is good questions prepared for the all leaders of institutions. And we found some solutions through your speech and your answers.
Thank you, Professor. It's crucial. Let me tell you something. When I was an intern, the time when I realized that my job is contributing to the economy of the country, I was thinking that treating people, it's their interest, not their global interest. But I realized that when a patient is treated locally and get the service locally, we go back doing his job, contribute to the economy. That is what we are talking about, covering surgery. A patient may access surgery in 2 hours, safe surgery. Thank you, and we have to join our efforts to achieve this. Okay, I want to invite the Dean if she has something to tell us. Please welcome to give your remarks on this meeting. Thank you.
Thank you very much. I don't know where I can stand so that I can see everyone and everyone can see me. Good morning, everyone. All protocol observed. I'm sorry I'm late, but I thought I was not late. I was informed it's starting at 9:30. Yes, Professor Poland, that's what you told me. But it's a pleasure to be here. It's really a pleasure to meet a forum of professionals working towards safe healthcare in Rwanda, and especially in the field of anesthesia. I'm really glad that we have been able to have this workshop. I know we have been talking about this for the last, I think, 2-3 months with the team here in the Department of Non-Physician Anesthetists and with the anesthesiologists, and it's really a pleasure to see this taking shape. My apologies, I couldn't join you yesterday because I was out of country, but I was able to catch up virtually because it was recorded virtually. So mine is really short speech to thank everyone who contributed to getting this day happen, and also everyone who is contributing to make sure that we are providing safe anesthesia, and really to thank even the organizers to think of this theme of teamwork. It's really very important that we think of the patients more than our own interests, our self-interest. So when we think teamwork, we also think the interest of the patients more than the interest of our own small contributions. Because the patient, I see them as a whole, an individual needing different professions. So holistic care is really something that we should be working towards. So I'm really glad that non-physician and physician anesthetists are working together to make this happen. And I'm really hoping that this teamwork is really a genuine teamwork, not just a teamwork on the paper. Genuine and honest teamwork on the table and outside the table during the training of students. And also, maybe I have to stress that teamwork does not mean that you lose your identity, does not mean that you're becoming someone else, but it's working together to make the service that we provide better. So I'm really looking forward to very interesting discussions, like Prof. Polan said. It's going to be a hot discussion, so I'm looking forward to listening to these discussions and really having like an outcome that is going to help us on a long-term journey that we are undertaking. So thank you very much for your presence, thank you very much for your contribution, and have a very fruitful discussion today. Thank you.
Thank you, Dean. It's really very important to be like a multidisciplinary team. We have Dean, like the body who produce staff, and we are here as staff. It's very important to think together. You know, our professions has some risk, and we want to be safe. There is something that we can do That is why we invite a panel to discuss about liability insurance and safety in anesthesia. I know the liability insurance cross-cutting. It's a big concern to any profession, but especially medical professions. I would like to invite Dr. Lila, who should be the leader of the panel, the next panel. Dr. Lila is the vice chair of Red Health Professionals Council, and she's your therapist. Welcome, Dr. Lila.
Thank you so much, Doctor, for that welcome. Okay, thank you. The mic is still on. So I have to speak without a mic. Okay. Yeah. Thank you so much. Sorry about that. Thank you for the presentation, Professor Colette, that you made. Thank you to the Dean for that welcome remarks. Without taking further time, I'd like to welcome the panelists for this discussion. I'm sure it's going to be a very interesting discussion that we're going to have this morning because of the members of the panel here who are my seniors. Some of them are my leaders actually. So, like they have introduced me, my name is Leila Mkarima. I'm the Vice Chairperson of the Rwanda Light Health Professional Council. And today I'm going to be the moderator for this associated panel that is going to discuss about liability. Liability for medical healthcare workers, but specifically for this time around, it's going to be for anesthetists. I'll first invite Colonel Dr. Eugene Boga to the panel. Please come forward. And as he comes forward, I'll briefly talk about him. He's a obstetrics and gynecology specialist and the president of the Rwanda Society of Obstetricians and Gynecologists. He works at Rwanda Mission Hospital as a clinician, but also the division manager of clinical services. So he's actually my boss. Welcome on board, sir. Next, I'll invite Professor Amy Agare Musi. And as he comes forward, I'll talk about him as well. He's a consultant neurosurgeon working at RMH as well. And he was my lecturer. So, Prof, I remember those days when you used to come to us and tell us about the sac of Willis, the geniculate body. So we commonly knew him as the sac of Willis and the geniculate body. To be honest, I used to hate neuroanatomy. But because of the passion you had for when you were lecturing us, it made us really love it, and we used to see you as a guru. And now you are, so your passion for neurosurgery goes way back. So thank you so much for being with us today as well, Prof. You are welcome. Next, I welcome Mr. Shema from HRH. Welcome on board, sir. There's not so much I'll talk about Mr. Shema, just not to go off track, but I'll leave him to talk about himself later. Welcome on board, sir. I also welcome Professor Ole Bambuti. He's a consultant cardiac anesthesiologist working at King Faisal and a senior lecturer at the University of Rwanda, College of Medicine and Health Sciences, and he has published a few articles. So much as he's a clinician, he's also an academician. Welcome on board, sir. Looking at the panel, I think there's something missing, and you all agree with me. There's no gender balance. The gender balance is not really balanced. So I really like to welcome another lady from the audience, and I think that'll be someone from the Nursing Council, right? Do we have anyone from the Nursing Council? Welcome on board now. Forgive me for going off track, but I really had to make this panel a bit more balanced. Sorry about that, Alex. Of course, how can I forget Alex? Alex is a very vocal person and very influential in his area of practice, and he's a very important person to be on this panel. Really would like to hear his views, so welcome on board, Alex. He works at King Faisal, and he's an MTA. So, once again, please join me in welcoming our panelists today. This is going to be a very interesting panel, and members, we're really hoping to hear more from you, from your expertise, your experience in your different fields, which are complementary in nature. So please feel free to give us your views. We have at least 10 minutes for each, but I'll probably give more minutes to the Minister of Health representative, because he's the policy maker, I think, more than every other panelist, although they're all policy makers, but I think he's more into policy. So I think my first question would go to you. It's actually one question we're going to discuss about liability, and it's going to be discussed in line with today's celebration, which is the World Anesthesia Day, and the theme is towards safe anesthesia for each in Rwanda. So this also goes in line with the SDGs. No one should be left behind. But the main issue here is how do we work towards safe anesthesia when people are working freely and motivated without fear of the consequences. As we know, health has become a medical legal practice. So whatever you do, people are supposed to be really highly accountable. And anesthesia, we know it's very sensitive. I'll not say that it's very important, because every other health profession is equally important. But if you agree with me, surgery and anesthesia is very sensitive. If I reference to what someone said yesterday, I think it's Alex, that there can be minor surgery, but there's no minor anesthesia. I will not talk about that. Maybe the panel will discuss more about that. So, Mr. Shema, from the HRH Minister of Health. Your discussion about, you're going to briefly tell us about the standard and scope of practice for anesthesiologists or anesthetists, NPAs and non-NPAs, vis-a-vis the liability insurance. What's your take on that? Thank you, sir. You're welcome.
Thank you so much, moderator. This is a very tough question that you asked, but we know that we care about the liability insurances as well as the quality of healthcare provided. So first of all, I would like to talk more about the career development first of all. What we think on the development and really the quality of care that is being done at different sites, healthcare in Rwanda. So as you all aware, recently, I still say recently because it's just 1 year ago, where we wanted to work hard and change the healthcare professional education in Rwanda. From a 9 years background of the program, the country has decided to go for one strategy that includes all the priorities in the country so that you can develop a healthcare provider with quality, but knowing that the quality is not only on the time of production or teaching, but it goes as well to the site where health professionals practice. So for that, we have been able to work on the National Strategy for Health Professional Development, which is a 10 years plan that includes 37 priorities, 102 specialties, as well as the production of 6,380 health professionals after 10 years, so from 2020 to 2030. So among all those priorities, surgery has been taken as a big portion in the National Strategy for Health Professional Development. And for safety surgery, we included a sub-priority in the surgery anesthesia. So safe anesthesia is among the priorities, and we are aiming to develop, first of all, a team of lecturers going to train 8 subspecialties in anesthesiology, from pediatric anesthesiologists, cardiac, gyne, and local region. We are aiming as well the big link between the School of Medicine and Health Sciences, working on the strategy on the synergy with the School of Health Sciences producing MPAs. So as of today, as we speak, there is a team which is working on the assessment of the School of Medicine, including anesthesia, the production of good anesthesiologists, as well as their contribution to NPA. So for that, first of all, we not only care about the production, but we look at the quality as well. So for that, there are some interventions that are included in the National Strategy for Health Professional Development, which is to bring in the country all those specialists and PhDs and backup lecturers to come and reinforce the teaching at the University of Rome, as well as different teaching sites. For that, there is an intervention as well to send abroad some of our specialists and some of our NPAs to go for studies in different subspecialties and come to reinforce teaching well as the University of Rwanda School of Medicine and Pharmacy, as well as the School of Health Sciences. So all those are under the priority, and meantime we are aiming to develop more than 100 different partnerships with different institutions. And the institution where they practice surgery, where they can mentor our anesthetists, so that we can organize the rotations in those different sites for them to get more sense of quality of safe surgery, as well as get experience to come and teach our health professionals. So without limiting to that, there is a discussion that has started already in the Ministry of Health that we need to involve different key stakeholders, and the Ministry of Finance is among the key stakeholders to look at the liabilities. Liabilities, it's really hard to define key priorities. As of today, we speak about anesthesia, but if we bring up Oxen Gang, it will be another discussion. So for the Ministry of Health, who are overlooking of health of all health professional development, as of today, it's really hard to know where to start by providing liability insurance to any kind of health professionals. Either it should be a package that will be offered to all, either defining the priority is the kind of discussion that is undergoing as it requires budget. The budget that should be as well requested to the Ministry of Finance. So it has been a discussion that started in the Ministry of Health, that soon they're going to as well involve other stakeholders to see on the possibility to help. Otherwise, I cannot guarantee as of today that this is going to happen by next month. But what we care first of all is on the quality of teaching and quality of healthcare providers, and then this is where as well is on the table for discussion. I think in brief, this is what I have to say. We'll continue the discussion. Thank you.
Thank you. Yeah. Thank you so much, sir, for that great discussion. I picked out that you talked more about the quality of education, sending people abroad to train well, and correct me if I'm wrong, about the liability, I think, which is the big elephant in the room right now, that we're really so eager to know what is the way forward, how are we going to overcome that? Yes, we know there is a problem, financial issues, and how you're going to choose who gets what. But briefly coming to that, I'm not an expert in insurance stuff, but at least I know that you all know that if you go without insurance in your car, the police will stop you and they'll give you a fine. So I'm just wondering if we really matter, the car insurance really matters most, why wouldn't we think about insurance for healthcare workers? Because I think it equally matters, and maybe there should be police to go around and checking healthcare workers. Do you have insurance? Third-party insurance? Stuff like that. Anyway, I'm not going to pin you down for that. There's so many people on board. I'll go to Colonel Dr. Muga. What's your take on that, sir? You are a surgeon, you are a politician. I hope I won't depend on us for it. And you work with anesthetists most of the time. I'm sure you can't work without an anesthetist. So, what's your take on that in terms of liability insurance for healthcare workers and specifically for anesthetists?
So, thank you very much for giving the opportunity. And let me thank the organizers. First of all, happy birthday. It's been like 175th birthday, which is too long. and thank you for inviting me for this important discussion. So, before I talk about liability, we really value what anesthesiologists do for us. Because as you said, I'm an obstetrician, they are called, so we operate a lot. So we rely on them very much. And whenever I enter a theater, the first thing I do is to greet the anesthesiologist. And my intention is to make sure that I have the right pilot on board. Because I always tell them that anesthesia is like a pilot with a plane. So meaning that the difficult moment is takeoff and landing. The rest of the time, we are quiet. But during between landing and or taking off and landing, sometimes we can have very much issues, like in a plane. And the pilot will start straining. So it means all of us in that room, we are part of the passengers. And we rely on that person who's behind doing the whole thing. So we are happy when we take off nicely, and we are happy until we land nicely. And that's why all the time, most of these anesthetic machines, they have a system, alarm system. And I ask or I request or recommend all surgeons not always to focus on what you are doing in your abdomen, but also to focus on that pilot board is telling us. So it means that we should work as a team, as we said. Of course, there's so many things which must be prepared before even boarding the plane. So, or whenever, I see normally in Canon, the people, the pilots, they come for regular checks. So we also have to make sure that our patients, or our plane, our patients, they get some good checks. So that's what we call anesthetic assessment. So meaning that that's safe anesthesia. Safe anesthesia doesn't mean that we go to theater and we just give anesthesia. So we need to make sure that the patient is optimized. We used to fight many times with surgeons who sometimes they book patients without preparing their patients. So if you talk about liability, it's a very tricky dossier. I remember when I was medical counsel, that's about 10 or 11 years ago. That's when we started working on this document. And until today, it's still somewhere. So there's something which must be really look at it, because we need it very much. But don't think that this is going to cater for all mistakes we have made. According to the content of that document, unless that's changed, it will be very tough to get how do you call it? So it means, first of all, they should look at, is this happening by mistake? Or the doctor has something wrong he has done through the process. And in that process, if they find you guilty, so you'll be responsible of your mistake. So sometimes when you see a lot of noise in the media, everybody, the doctors, they start talking about this liability insurance. Yes, it will be there, but it will be screening to see who must be covered. So the first thing we need to do is to make sure that we have very competent people. So the training, as they are talking about here, so we must make sure that we raise the standard of care. So everything which must be done before surgery, before anesthesia be given, must be done. And not superficially. People are, oh, we are going to small operations. Small operations can become a nightmare. We have a recent example here. Just moving the steady and then the patients never recovered. So when you sit down, you go back, you start asking yourself, have we done everything correctly? Because that's where everything will start. Even that pain I'm talking about, if you don't have the fuel you want, when you get up there, you'll come down. So before talking about liability, and I'm not sure, as Sherman said, when this is going to be sorted out, because I think there's a lot of money involved in. So we need to make sure that we work on the quality of our staff, We are talking about numbers, as Dr. Pole was saying, but the quality is extremely important. They know what to do. So that's my take on this. Liability, yes, we need it, but we shouldn't think that this will come to sort out our mess, our mistake. We need to make sure that we become competitive as in other countries. I'm sure most of us will traveled. When someone is going to Awagi Wing, we see some documents they're bringing to us. Awagi Nahan was so it means that people they sit down and make sure that they don't leave any detail behind. We here, when we have issues, that's when we go back and say, oh, did you have ECG? This lady is 60 years old. In other practice, all these cases should have at least this kind of test. It means there's no complaints that are before. So my point is, let us have safe anesthesia, work with anesthesiologists because we are a team, we are the same plane, but make sure that the liability also, if we need more discussions with the professionals so that they understand where the issues are, so it's always possible for people they can discuss it. But standards must be up to top. Thank you.
Thank you so much, sir, for that discussion. I can see that everyone is coming back to the standard, and indeed, the main thing here is standing out is the standard and scope of anesthesia practice. So I agree with you, sir, that we have to raise the standards, very true. And again, I'll refer back to yesterday's discussion, and I'll just say, I'll paraphrase that the way we said, akayuruzo, kayumurura, meaning that the standards might not be so good, that's in terms of training, but Mr. Sherman here yesterday said that we should reduce akayuruzo, kabigato cyane, ariko so yes, make the standards really strict, but recruit more students. Yeah, so the standards here should be really of high quality. Probably that would be a discussion for the academicians. Right now we're still looking at liability or standards and scope of practice vis-a-vis liability. So if we have quality anesthetists, quality anesthesiologists, well-trained and everything, well-equipped, but we should again think about how are they protected. We all agree that people are getting more scared. Recently I've had one of the surgeons saying that nowadays you're going to theater but you're not sure you come out safe because you probably come out with contrast because of what you've done. So I think people are really getting a bit scared. Although it's not a good thing, you shouldn't go in theater thinking that you're going to come out handcuffed. You're supposed to think of or be accountable for what you're going to do. So again, I'll still come back on the liability issue. I think, I'm sorry it's a bit tough, but the panelists here, you still give us solutions and the way forward or recommendations on how that is going to be tackled so that by the end of the day, Professor Pole will have something to sell back to the professionals. Yeah, so you want to say something, sir?
Sure. I'm sorry to come back on this. I remember from my experience heading the community-based health insurance. Kuzamura haje kuzamo ikibazo cy'urugomo nabwo cyabaye ngombwa ko kigwa ku rwego rw'igihugu. Urugomo rwaterwaga n'uko bashobora kujya mu kabari bagakubita icyo kurya n'ubundi ubwishingizi no kwivuza yo kwivuza. Ku buryo byabaye ngombwa yuko wakoraga cyose niba bishakaga bashobora gukubita imodoka bakomeza televiziyo bakazana iyi uwo mabwiriza ariho ni uko hari budget hari degree yo kwangirika imodoka yawe igomba kuba ifite kugira ngo insurance ishyure ibindi byose urabyikora biri munsi y'ubuzima so bigatuma n'ubundi niba waba wishyuye iyo insurance ubwirinda gukora amakosa ikindi nacyo ni uko uzi ko muri accident aba ari accident ntawe uzi ikiri kuvuga ushobora no kukwitana nta muntu wakavarinda ubuzima so discussion rero kuri liability iracyakomeza kandi irakomeye kubera ko nk'uko navuze igira priority harimo budget harimo ndetse n'ikaza kongera kureba n'ikihe kibazo dufite muri quality of service z'ibiribwa ugasanga n'ubundi ibyinshi haracyari byinshi byo gukora ntabwo ubwoba abaganga bafite bwo kuba nagira ikibazo ari bubigira ingaruka cyane serivisi zibiri muri minisiteri y'ubuzima association councils zirengera inyungu z'umuganga cyane cyane tuzi ko iyo ikosa ryabaye ntabwo ari uko rihanirwa kuko ikosa medikali rishobora kubaho ikosa ry'uburangare naryo niryo rihanirwa ariko tugereranyije n'amakosa ahanwa murabizi neza ko bagerageza kureba koko ikosa ryabayeho ryagezweho n'uruhare n'umuntu cyangwa se n'uburangare nayo mpamvu focus na HRH ubwayo gushyirwaho rero kugira ngo ijye mu mizi y'ibibazo bihari muri quality of health care provided kandi twasanze ibibazo ari byinshi tuganira n'abaganga niyo mpamvu ubona ingufu zacu kuba nyinshi kugira ngo twigishe kugira ngo twekipe site kugira ngo dutange ubumenyi buhagije kugira ngo twirinde amakosa kuko iyo ikintu kimaze kuba ikosa waba ufite insurance kandi utayifite ntabwo ugarura cyane bya ku binyabiziga navuga ku rugero rwabo rwo muri mituweli ariko sindavuga ku bijyanye na cycling na anesthesia n'ibindi kuko ikosa ribaho iyo umuntu atamugaye uruhu aratakariza ubuzima so niyo mpamvu rero focus HRH imyigishirize imikorere noneho ikiganiro kigaharirwa politike bakiganire n'abatekinisiye kugira ngo tuganire mu mizi no kureba aho dushobora kugera.
I think again, like I'll just remind you that we're here to find solutions and recommendations on the way forward. Ikibazo tugomba kwigira hamwe twese kugira ngo tumenye n'iki cyakorwa tutirengagije ubukungu bw'igihugu, tutirengagije izo zindi implications ziriho, but in a way to formulate a package that is stimulating to the profession. And again, profession to be aware that they shouldn't compromise because they have this insurance, but just to know that, okay, we're being thought of in this aspect as well, and not just to be blamed. I think I'll give the floor to Professor Murphy. My pleasure. What's your take on that, sir? Standards and scope of practice vis-a-vis liability. Please briefly discuss with us on that.
Thank you very much, thank you very much, organizers, and also wish you a happy birthday. So maybe for the I saw the presentation when it came in, properly was making, and I saw a lot of information. What we need to do. The numbers, the gap that needs to be covered. Now when you look at that, if you look at the previous presentation on gap we need to fill. Then we come to the topic, liability. I've divided two words into liability and insurance. Dr. Goga said nicely, you will mundage. All we are focused on the pilot. Passengers really, telecommuters are chaotic. Passengers are subdued. I think commonly it is problems will come with if either the pilot didn't do the checklist properly, to check the checklist that they developed, or to identify mechanical problems that may be existed. Alikuwa acceleration kwenda kupunguza circuit. Those are things that are inevitable. So there are things that are inevitable, there are things that can be avoided. Now when we're looking at liability, avoidable or avoidable, the avoidable stuff, and then there are things that are not avoidable. So if there's a teacher processing, I think to assess the discussion I'm hearing about the money, yes, we can raise the quality, which is must happen. There are about to for example, they know. I do not accept the screen co-area citizens. So I must share. Who don't like the thing, you pay it the dials. Ariko, you do not be safety in the first place. Because safety we're talking about is about three things. One, the safety of the patient, which is not quite so that all of us look at it. But we must remember that also we need to have safety service. Now that also that's a panic situation which I don't think is healthy. We need to so I think we should look at that in that context because we can practice it for how long? For a long time. Even if you are kind of not whatever. Now you have to assess what is your context here. You have Java here to do practicing, to go. Because practicing is go. That in itself can become a source of the problem. Either you cow from doing the right thing, in a small thing, to avoid the procedure, some small thing. So I think the way I'm looking at it is we can raise quality, but we also the quality of the person. Maybe the issue of numbers also we should talk about it significantly, so that we not either a panic, what is the stress? Your level, the threshold to get burnout goes down. Why should I measure? I don't think in my mind, okay, what's going on, what's happening? Now, what we should avoid are the avoidables. So you can let your practice. Is accident as well. So accident yes, also careful. So for me, I'm encouraging people not to go into the panic mode. Even in Java, we are going to practice, we are going to have practice. Let's look at the safety of the patient, look at the safety of our colleagues. We take care of each other. za purize zimeze neza, socket zimeze neza, n'instruments zimeze neza. Ibyo byose nitubikora igabanya the risks. Izo risks na checklist. Ubu babizi natwe dusigaye dukora nk'abapilots. Buriya niho byatangiye. The safety checklist dusigaye dukoresha mu theater, ziriya zose tuzikurikije. Kuko ni ukuvuga ko iyo bakubaza abaza iyo bajya kwakira umurwayi bareba ibyo bintu byose yavugaga ya ECG n'iki n'iki. Now the problem is when we want to take shortcuts. Iyo dutangiye gufata shortcuts twajya mu bibazo kuko icyo gihe iyo wakoze checklist yawe neza iyo habaye cya kibazo bakaza bagasanga safety checklist tick ECG tick blood tick no coagulation problem tick. So in the end bizasanga ari cya kintu kiri unavoidable, most likely was safe. So that's the safety I'm talking about. Scale up with shortcuts. Now on the side of opposite, now if it is unavoidable, you are just check safety checklist. Okay, right. We are unavoidable, but we must not be unavoidable. Yeah? Birabisa no kugongwa n'undi muntu wakoze ibyo ugomba gukora byose. So umupolisi naza ku muhanda kureba bakugoza azasanga wowe you have everything, imodoka ikoze neza, ibyangombwa byose, ariko wakoze ukoze wagize accident. So ni ukuvuga ko ingaruka kuri wowe zizaba ari nke cyane. Now ubwo rero bikaba wa muntu ugenda afite insurance bya bintu usanga leta ishyiraho before the guarantee ngira ngo niyo agomba muri modoka ugomba iyo ugonzwe ugize accident wowe udafite umunani ubwo navuga ko ya insurance tuba tuvuga yaba imeze nk'iyo ko wowe uri safe ariko still ugize accident ukeneye bwa bwishingizi. Now bwa bwishingizi nabwo wenda ikintu navugaho is very important to have in Masani. I think it's not the only alpha and omega y'ibibazo byacu kubera ko nayo igira ibibazo ahubwo twize kugira indi discussion yo kuvuga ngo bashyizeho iriya insurance ubundi ahandi ugera bagira categorization ya abantu bakunda kureba different services bakunda kureba icyo gihe izo ngizo zikagira supplementary insurances. So nubwo urumva ntabwo twadiscuss na supplementary tutarabona na primary insurance ariko kuko tuzi ko iri expensive I think to fast track it ni ukuvuga ko leta yashaka the primary one noneho tukareba nanone high risk ubundi bazita high risk actually you grade risks different services niba uri mu gynecology uri higher than surgery. Plastic surgeons have higher because of doing cosmetics and those are positive. So when we are discussing insurance, yes, I think we can panic mode, panic. So in practice, when you practice safely, you need to be avoidable. It is the second point in the Quran. No, I would take a big burden to the ministry. You have to have a if you want a comprehensive one, you will talk. Insurance budget. The first step to cover this is what is affordable by government. Then to get a baseline. No, our service, ubundi nayo icharginga expensively to cater for the secondary students. So ibyo ni ibintu nabyo twaganiraho, ariko kugira ngo yewe as I said, take home, let us not panic. Ibintu bizagenda neza, we are improving our service. Let's observe the safety checklist. Maybe thank you.
Thank you so much, Prof. Take-home message, Mr. Mayu said, no panic mode, raise the standards, and go there knowing what you're going to do. All will be well. I think that's well noted. So before I give the audience to ask questions, allow me to give the chance to other three panelists to talk about now. You are the professionals. I'll get back to you at the National Council. Now the professionals, what's your take on that towards safe anesthesia? You are in the profession, you're into practice in your daily activities. What is the standard and scope of practice? What's your take on that? Prof, allow me to give to Alex first to make his comments briefly, and then you comment on that. Thanks, Alex.
Thank you so much, moderator. Thank you all panelists. I'll say today not very difficult after big men like Professor Musi, but I'll give my opinion. I'll not come back about on the standard, because all of us we know that if there is no standard, everything that we do will be bad, will be worse. So the first thing is to think about the standard and fight for that standard that we keep it, and what to do everything to be on the high standard. It is also very hard to sit with a politician like Shema, because I'm a technician. When you come back on the insurance, I think more on the professionals. A professor must say to do not panic. Yes, I do agree with you. You have to work daily, you have to go in our professions and do what you are supposed to do and do it correctly. But once again, I come back on professionals. Akonungoga said something real earlier, and Professor Musi. Byinshi cyangwa se ibyo bavuze, I say you look for high or ahantu hasa nk'aho hamaze gutera imbere cyane. When you say checklists, when you say monitors, when you say teamwork, communication, somehow mafashe cyangwa se nabonye biri ku rwego rwo ahantu nanone hamaze gutera imbere muri setingi zacu. Biraza gutuma ngaruka ku kintu kijyanye na insurance. 6 years ago, no, within the last 6 years, nari ndi muri executive committee around the professions course. I had to go to investigate for some practices. We found that more than 50% the incidents were not the professionals' fault. Sometimes there is ikibazo cya infrastructure, ibikoresho, uburyo hakwiye gutekerezwa uburyo standards dushaka mu kwigisha n'ibyo twiga, those standards zishyirwa no mu infrastructure n'ibikoresho abantu bakeneye kugira ngo babashe gukora umurimo wabo neza. Nigeze reka mbahe a short testimony. Hari ahantu habaye incident malpractice, an NPA yasinzirije abarwayi babiri at the same time in two different operating rooms. Why? That NPA was alone on duty. The surgeon, the medical doctor who were there, they were told, they forced her to walk. And she called the DG and insisted that she should do those operations. Havuye mu igihugu igihe cyo kumuvinga bava muri sare najya mu yindi, one patient died. No, ntabwo yapfuye kuko bari bagize toxi aza kugira brain death, aba transfer to another hospital, but nyuma y'igihe gitoya uwo murwayi nyuma y'igihe kinini amezi atandatu ari muri koma yaje. So iyo ugarutse ku kintu nk'icyo uhita wibaza ati yakotse bose akira akotse bose. How a medical doctor ashobora kubwira umuntu ngo sinziriza hano hariya ni spine bateye uragize ukontra? Where is the teamwork? Nihe hari gutekereza ku murwayi na aksida ziri bubone, kuko ubushobozi cyangwa se agaciro akanagaciro uko afatwa ni ukuvuga ngo niba naka yavuze ntibakuvuze. Dedeje ntabwo yagize icyo akavaringa ari umuntu mukuru ari hejuru agombaga kugira icyo akemura, but also the NPA was punished yarahanwe kuko yemerewe gufata decision yo kuvuga ngo no umurwayi rero uyu uwundi either mu transfer cyangwa ni muhamagara uwundi ave mu rugo azakora ikeza. It was not a military emergency. So icyo nshaka kugarukaho ni iki, turebe ni ibiki dukwiye gukosora, not only kuba umuntu bayikiye bigishije neza n'aba Professor Paul, ariko turebe personally policies zikurikizwa mu bitaro, ibikoresho abantu bafite. Ibyo rero nubwo Professor gusa avuze ngo abantu bakwiye kugira ubwoba, umuntu uri i Kigali uri muri Rwanda Military Hospital uyu munsi ntabwo uri buvuge ku bantu benshi, ndavuga kuri Anesthesia kuko nibyo tuvuga, ushobora kugira ikibazo nk'icy'abantu babigenzi, ushobora guhamagara ufite ikibazo bakaza bagatanga nafashwa n'umusore. Ariko tutekereze bona shema nk'uko Professor Paul yabivuze, umuntu uri kabaya n'undi muntu yahamagara hafi yamugira nyuma y'amasaha nawe atizeye ko so that's why nshaka kugaruka ku kintu cyitwa malpractice policy ikwiye kwigwaho igashyirwaho kandi igakorwa n'inzego kugira ngo abantu badatangira kugira ubwoba bwo gukora umwuga. Twahoze tuvuga ejo twahoze tugukunda abantu bava mu mwuga, that's one of them. Abantu bafite ubwoba ahantu bano bakorera byarabahamara uko umuntu asiga avuga ati ejo batazakumva. So iyo ntuza malpractice kubikora ariko ni ikintu bavuze liability insurance you have to look at priorities. Ntabwo uyu munsi ufate umusaza fana uriho ubyirinda n'umubyeyi n'umwana w'umuntu ngo umushyire, ntabwo gusuzugura imyuga, ariko umushyire kuri level imwe n'umuntu menshi ushaje So numva kucyita liability insurance muri tugaburira gatoya nk'umuto hari inama twigeze gukora the Ministry of Health Minecofin councils n'uhagarara n'abantu bari bahagarariye za insurances iyo nama yarangiye nta mwanzuro ufashwe mu buryo kwa muganga nta mwanzuro ufashwe kuri icyo baravuga if you say that anesthetists surgical gynecologists surgeons they are at high level high risk then their contribution should be bigger. So if you want that their contribution should be bigger. Are the salaries higher than other professionals? No. Icyo kintu cyasigaye as responsibility. Niba turi apolisi, n'ubu contribution zitanga tugomba gutanga menshi kurusha abandi. Then consider that in our salaries. So, murakoze nasabaga shema iki kintu cya priority mugitekerezeho nibura hagiye zimwe z'ibanze zose zitangiye ibyo dutekerezaho ubona ko ziri kuzana neza.
Murakoze cyane Alexis abafite ibitekerezo nanone muri make it's all about prioritizing who gets insurance, who are at high risk, and I think that's only fair. I think we can all agree on that, but I'll leave that to the floor to decide. Professor Pome, do you have something to add briefly? Thank you.
Okay. So just briefly, I think we are coming back to what we discussed yesterday. First of all, I'm thankful to see that our LSA has been honored. Our advice we are getting, thank God we are getting from the IS reform sessions. And we should have been one of the chair of the gynecology and obstetricians, who is well placed in the hospital, the chair of the London surgeons, the head of department, HRH, Rampa. So those are opinions that go ahead. And the physical ministry offered liability insurance in our and it should come from us to our victims. And I'm sure Shema Malikuzi if you take the results patterns, there are a good fashion in it's not big budget like in consideration. So we'll talk about three things. The issue Dr. Kenya to me, Nikubazwa, Imoko Kaliwa Kushia. Unaratara kushia Bushet, uza ni kizara bila Mungu ya ndiri. So, ili vitatuyawa in short periods, to compare na scope na standard ya kisisi. Jambo ni COVID, kamili ni kamerazi umuhanda, ya hata tunisikia gabu. COVID, bwa mbere government yicaye ivuga yuko abantu bemerewe kuva mu ntara imwe muri district ya mu yindi harimo n'abanesthesist. Inzira yongeye gusoma yellow paper yasohotse ikenera n'abanesthesist kugira uburenganzira bwo gutambuka district to another. Ese ni ubuntu cyangwa ni yari nuko bari bazi ko bafite endoscope yo kujya kwakira umuntu from Rwinkwavu Kirehe Kibungo bazamuka bajya kwakira. That was ni kubwira umuntu we know it's a standard ariko urebere kubikora kwanza nyaruka. So that was for me n'amaso ya chair of LSA how we red flag n'abarugu ni tubwira ko there is a problem abantu bari kujya in danger kuko hagira mu bafu. They should know that ibyo bakwemere gusimbuka gute. Ese wagiye nyuma y'izamu ya 24 hours ukasimbuka in district in 24 hours ukasimbuka in district, the day you will have an accident your permission to simbuka district ntabwo izakukaba wemerewe gusimbuka. You need to be careful in that. There is a shortage, you guys are covering for little money, but you need to be covered. Well, last time driver. Ngeze nishinga ticket 75,000. Ngira mdamu amafaranga yose next time mushobora gufata indege akiguma akaza kwinjira ndetse kandi ahamira munsi ngiye gufata aeroport risque abakata nyuma ya airport ya Goma ese ahisho niko nayo ni English donc okay ntabwo ninde so kusubira ya kuri beyond just reduce so reduce 64 hours. Don't give someone rendezvous. Ya Satan, can you then you will pay back. You pay the money. So give him 1 PM, then 100% from him in the door. You will reach. So that is another thing of anesthesia. We are pushed to cases. And nothing against that. You know that we work together. So this surgeon comes, he starts at 7, sometimes 8. If your eye is where are these good things? And who's a fresh? Then now fresh money. Where are you going to go? Easy time now, we get on standing kids. No, you guys, that's good. God is there. So that needs to be considered even scheduling number of people. It's already 7, you start at 7, it's 12 hours. You have to push again to get an emergency section. When the number is very small, talking in cases, speed up because the list is too long, we can't stop them because they're paying money to provide with surgical money, and you already said these are stopping the surgical money. So you guys please walk home. Your pressure, you end up into problems. And when the due is put in someone, it's a small, very small, please. Give something. Tanga tukatoya kuri kuna katoya kuri na colleagues speaking. So in your pressure, we need to know how to discuss about it, because at the end we are the one. Then when you see the state government, one for the surgeon, for the drivers, what are the fees when they started the government, they reduce the business. Umuntu yabikondewe bizungu ndio kaje digital akayakuja amerikati mapema kigai ama accident so government has partnership government so they align the business following standards and speed. If we can also copy William Camera and government in medical practice, it's not about the speed and the push we are putting behind those drivers. We need to also consider the time of checklist and follow time of licensing. The right license, do we provide good road for them? Because they first make good roads in Rwanda, then they put it in government. People have bad roads, I want to see my holes that are for accident. In many hospitals, we spend time in anesthesia, we have a suction machine. We have a endoscopic cord, lines. When you are working in such environments, accident in Rwanda. So we need to clear the roads, get the license, fuel the car, the way we are paying for the service, the way we are being paid. If we make those things clear in our road as workers, I think we will be just like those brothers. Drive safe.
Thank you so much, Prof. That recap. I think what's coming back again is the standards. Like Alex said as well, the standards should also reflect in the infrastructure. Standards should reflect holistically, not only on just one part. So look at the whole picture holistically and include standards everywhere. Checklists, training, licensure, CPDs. I know. My boss here is very big, is very passionate about quality care and education. So I think that also is really very important in order to provide safe and quality care. We need standards everywhere. Before thinking of liability and protection and all that, you need to fasten your belt really well so that you know that you're safe before you engage on everything. So briefly, I'll ask the representative of the nursing. I know you talked about anesthetists and surgeons, but somehow I think you left out the nurses, and you really work with them. You never leave them out. Correct me if I'm wrong. So that's why I called her on board. Madam, please share something towards safe anesthesia if you're in the theater, vis-a-vis the standards and scope of practice. Briefly, thank you. Questions, be prepared during your questions. Very soon, to recap this discussion.
Thank you so much for giving me the opportunity to I thank all the panelists for the points they've given us, and we've noted a lot of points to be put in our minds in order to give quality care to our patients. I understand we are all here just because of one person who is the center and the focus to all professionals, health professionals. Whatever we do in health profession without the teamwork, we cannot succeed. That's my main point on that. And whatever we meet as mistakes from what is called malpractice, to others who judge us, we should avoid blaming ourselves and keep being strong in this profession that God called us to do. In that context, as a representative of the Nursing Council, our main focus is to protect the public. Whatever we do, whatever we talk, we need to protect the public by giving good services as we are supposed to do. In malpractice, if you are accounted for that, it is zero tolerance in case of negligence of patient. So we shall not run away from that. Even we are given the insurance to cover that, but once you are found guilty for that, you will be answerable. In nursing, our center of focus is caring and hearing. So we are all called to care for these patients who do come to us, and we should give them quality services. For the anesthetists, as they've said all, we need to focus on bringing people or getting
Points that you made. Again, we're coming back to no panic, quality, and accountability. So if we are accountable and confident in what we have, then I think we're going to serve better without panic. And the rest, I think, shall fall into place one by one. Thank you so much. Please allow me, join me in thanking our panelists for all the discussions that we had. I think they are very, very interesting. They made key points, very good solutions and recommendations. So right now, I'm giving the floor the audience a chance to ask your questions, comments, clarifications to whoever panelists that you wish to ask. Welcome. We'll take, I think, a round of maybe 5 questions, which will be answered accordingly, and then I'll see the way forward.
I think presenters for the discussion done. My name is Safari. I'm working at Anesthesia Shirika as an anesthetist in PA. Ndashaka kuvuga kuri concern ebyiri. Ntekereza ko
turadisikasinga hamwe n'izindi nshuti abakoriki bakorana bambwira ikintu kimwe numva it's a big concern. Ijambo rimwe twaramenye ko abaganga bagira amafaranga menshi we have to share. We have to share. Ndetse mwitegure ko niya Kempaiso, niya Sehashirika, niya Kanombe, we have to put our office z'abavoka bazajya baza kureba ababarwayi bose bakomplayininga, then we can help them. Ayo makuru n'abandi kugira ngo biblage ariko nza gusanga nako bimeze kuko batangiye kwinstara mu office abo bavoka. Hari umuntu urwaye complaininga, so I can help you, you can get 10M, so you will give me 3M, so you go with your 7M. Ibyo bintu minisiteri ikwiye kubika gutyo bikazakomeza kandi birahari. Minisiteri y'ubutabera irimo irakangurira abaturage kwirinda imanza no bagerageza gukemura ibibazo mu bwumvikane from one side. On the other side, abavoka barimo barakangurira abarwayi kurega abaganga. Numva icyo kintu cyari gikwiye kuzicara kigatekerezwaho. Ntabwo turimo dukora motivation yo kubuza abantu kuzahabwa ubutabera igihe byabaye ngombwa, ariko nanone ntitwifuza kuzahora mu manza when it was not supposed to be. Cyane cyane ko twabonye ko bimaze kuregwa mu rukiko, ntabwo institution ikuburanira. Ushaka umuntu bakabuha ntukiburanira. Rero dukeneye ubufasha kuri icyo ngicyo. Icya kabiri, yes, reka nihute kirihuta cyane. Abanyamakuru bagenzi bacu dukorana, mu minsi ishize najyaga mbona kuri TV1 banyuzaho umubyeyi ukareba ugasanga habamo professionalism, bamukuramo imyenda biga kuri TV yerekana uburyo yabazwe nabi, umuntu akeneye kuvurwa. Iyo icyo kiganiro kikagera cy'umweru cyose umubyeyi yambaye ubusa. Ntekereza ko abanyamakuru bagenzi bacu bagomba kubamo professionalism, hakagira icyo minisiteri ikoraho n'icyo kigo kigize kuri televiziyo. Naranyuzaho niba umucisha ine avuga ko yaguye muri yagize pararizi. Iyo pararizi ikaba igomba kuvurwa n'ikintu bita physiotherapy yonyine, ngo imvune yarakize, igiti cyamuye ku ijosi, imvune yarakize, yabuze physio gusa kugira ngo akire. Ibyo ngibyo nkaba namva bitaba bikwiye kubigenda gutyo kugira ngo birebwe gutya gusa ntihagire ikintu minisiteri ikora. Murakoze.
Do we allow other questions? Five. The first thing icyarimwe bivuze gusubizwa. Please. Okay.
Because there is another front.
Okay. So the last. Okay, there were three people who raised their hand. Please be very brief, otherwise I'll cut you short. Uvuge ingingo ntutugire story nini cyane, please.
Okay, murakoze. Nitwa Gilbert Kumbuka, NPA Nyagatare. Ntabwo ari ikibazo, ni igitekerezo nshaka kwadusinga kuri Shema from Ministry of Health. Iyi liability cyangwa se assurance njye mbona bikwiye kujyana na political decision makers muri politics nk'uko Alex yabivuze. Nibyo Professor Nkusi na Dr. Boga badusabye kumaximiza standard, kwirinda ibintu byose biri available. Yes, it's right. Ariko dukwiye gutekereza abroad, aho tuba mu cyaro, kuko for example Nyagatare haba specialties ya gynecology, hari abagynecology. Niba hari aba specialties biyongera accordingly, ariko NPA ataratekerejweho, muri NPA umwe mu karere bafite ibitaro bimwe biragoye kuzamatsinda za standard. Ntekereza ko ba political makers bakwiye gukemura ibyo bibazo ariko bareba impande zombi nk'uko presentation twahereyeho ya Professor Kuvuga. Ariko rero igitekerezo cyanjye cyo kuvuga liability irebe n'izo parameters zo kuvuga ngo ese umuntu uri hariya uri exposure utaza gukurikiza standard bitewe na environment ihari turabikora kuko nuza kuyikurikiza ugendeye kuri standard ushobora gusanga byari avoidable ariko condition arimo zidafite.
Thank you very much. Uretse ku ntego
yego murakoze yitwa Manuel Sansi. Turabizi neza ko when you have young children or weak people, you need to protect them until they become strong. Nabazaga Shema ni ryari cyangwa ni ikihe cyizere yaduha ko NPA bashobora kuzajya babona education n'ibindi bibazo mwagiye mwumva bigakemuka binyuze muri bakuru babo, ndavuga ku rwego rwa education, binyuze muri bakuru babo bamaze gukura, kuko minisante umubyeyi wa bose imaze kurera anesthesiologist bamaze gukomera, bamaze kubukombe, ni ryari izabamanura kugira ngo batware ubumenyi bwabo muri ba bana bakiri batoya mu district hospitals kugira ngo dushobore kugera kuri za quality. Abakristo bemera yuko Imana yivuze biba yategeka bigakoreka. Muzabikora ryari kugira ngo twizeze bagenzi bacu ko noneho agahinda n'ibibazo bamaze iminsi bigiye gukemuka? Murakoze.
Murakoze cyane. Ibibazo byose ndabona bijya HRH. Icya nyuma uretse ku ntego
murakoze. Nitwa Dr. Jean Damascene, anesthesiologist ukora muri CHUK. Ndashimira Professor Paulin waduhaye presentation ye twitangira. Ndashimira na Pano uburyo yagiye addressinga iyi topic ya medical ya liability insurance na standard of anesthesia practice. Ikibazo cyangwa se comment nshaka gukora kuri anesthesia practice and liability insurance, wanahera kuri presentation Professor Yaduhaye atwereka uburyo by 2030 ari target yo kuba twarazamuye umubare wa anesthesiologist trained and non-physician anesthetist trained kugira ngo tubashe gutanga safer anesthesia. Ariko iyo turebye tugomba gutekereza ntabwo bihagije gusa kureba the number of product of trainees tuzaba dufite, ahubwo tugomba kureba na quality bazaba bafite icyo gihe kugira ngo ibi byose tuvuga byo bya incidents zibaho safety bigabanuke. Twizere yuko hazaba hari gutangwa safer anesthesia.
ikibazo
Ikibazo rero nari bukomeze nkagera no kuri ibi bya liability insurance na safety of the anesthesiologist and non-physician anesthesiologist muri practice ye. Turebe na context turimo ubu ngubu turimo turabona stent ziba cyangwa se niba ari malpractice zibaho, aho ukajya kubona ukabona anesthesia providers uburyo abaye treated, uburyo abaye treated biri mu bitera panic iri ubu ngubu. N'ubwo batubwira ati mureke panike ariko iyo byose ibiba turabibona ku buryo n'abandi bandi baba bari gukora baba bari kose ibi bimbayeho ngewe n'iki kiprofesha kugira ngo simbe nanjye nagerwaho n'ingaruka muri kariya yanjye. Rero nkaba mbona hakwiye kubaho turi kureba media uburyo ziri kwakurushinga incident ziba kwa muganga, zishobora kuba incident ziri wenda habaho malpractice cyangwa se ari icyo nshaka kuvuga aha ngaha ni uguproteja the patient ariko no guproteja provider providers ku buryo niba media umunyamakuru agiye hariya akumva amakuru mu burwayi cyangwa se ikintu cyabaye agahita agakora amakuru inkuru ishobora kuba yubakiye ku bintu biri byo cyangwa se bitari byo akayikubita hariya the general public ayumva izahita isamirejwe ifate gutyo. Niba ifata gutyo niba nubwo byaba amakuru yaba atari cyo ariko kugira ngo iyo image mbi itanzwe izongere gusibangana iyo the profession yongere igirirwa icyizere bizasaba imbaraga nyinshi igihe kirekire. Baravuga ngo akarenze mu bakarushyira ihamagara. Ni ukuvuga rero niba hatabayeho uburyo bwo guproteja gutangaza amakuru atariyo ku byabara kwa muganga cyangwa se n'amakuru agiye gutangazwa n'abanyamakuru akabanza kwigwaho mbere yo kujya mu binyamakuru cyangwa se umuntu ukoresha media ahita yihutira gutanga muri general public amakuru ko yishakiye. Ibyo bikwiye nabyo kuba control. Abagera ko minisante hagamijwe na shema hakwiye kujya mu buryo bwo kontrola abanyamakuru uburyo batangaza amakuru yo kwa muganga n'abarwayi kuko biri mu bitera imbarike by'ubuvuga ariko noneho koko nibyo kuranforsa safety of patients, safety no guproteja rero anesthesia providers. Murakoze.
gato mvuga ikintu, hari social media none abanyamakuru batarabumuka nibo bantu noneho baratera panic. Ushobora no kuza akagufotora agahita ubijyana ku rubuga kuri Twitter kandi ntabwo ari professional, ntagira body mugenga, nacyo ni ikindi kibazo. Ariko ntekereza ko Ministry of Health wenda kirazadufashamo. Kera yigeze kuba amabwiriza ko nta muntu winjira mu bitaro ngo uzanwe amakuru atanyuze kuri PR. Ni amabwiriza yari yasohowe na Dr. Kasi ati hari ibintu byinshi cyane sinzi wenda muraza ni ukugira ngo mbe clear kuri iki kintu. Murakoze.
Murakoze cyane kumva ibibazo byinshi byagiye kuri malpractice tugize numva good practices kandi murabizi neza yuko abanyamakuru n'abandi babizi inkuru mbi isakara mbere y'inkuru nziza. I wish iyo tuza kuba dufite health communication center ahangaha kuri pano kuko ni ikigo cyashyizweho kugira ngo gishinzwe gusakaza amakuru y'ibikorerwa muri health sector. So niho mbere kuko ibyiza bikorerwa kwa muganga bikorwa n'aba health professionals, nubwo institutions nyinshi zibitwitinga zikabivuga ariko ababyikiriza nibo bakeya. Iyo urebye malpractice imwe ishobora kuboneka imwe itarabana judged as malpractice mbere y'uko inakorerwa assessment kenshi iyo tubona atangiye gutera ubwoba numvise bavuga yuko mu kiganiro safari yagiranye n'abaroyazi ko bagiye gutangira gushira kabine hafi y'ibitaro n'ahandi. Nashatse kubizana no burage bati igisigaye ni ukubasinziriza ariko ikigaragara yuko abantu batangiye gukanguka no kumenya uburenganzira bwabo. Byabaye kampeni nini ikomeye ndabyibuka muri 2012 itangira kuyobora PBF performance based financing. Habayeho kampeni ikomeye yo gutanga uburenganzira ku bitaro, uburenganzira bw'abarwayi, uburenganzira. Ubu igihe kirageze abantu barakangutse bazi uburenganzira bwabo, ndetse hari n'ababagira inama zitari zo bagakurikirana ibitari byo. Igihe cyari kigeze kugira ngo health communication center ndetse n'abanyamategeko nabwo bashobore gukangurira abaganga ndetse n'ibiganiro kugira ngo turusheho natwe kumenya uburenganzira bwabo muri iki kiturengera. Ndumva rero ku bijyanye na professionalism mu banyamakuru, iki ntabwo ni message turi butange, ntacyo nakivugaho. Health communication center ni ikigo cyashyizweho na minisiteri y'ubuzima ikora muri RBC kugira ngo gishobore kudufasha muri icyo kintu. Icyo nakora ni ugutanga ubu butumwa kugira ngo babidufasheho. Ubuke bw'abaganga ndetse no gukora, numvisemo akabazo karimo kubahiriza standard. Yaba turi bake cyangwa turi benshi, standard zo kugura zo zigomba kubahirizwa, ntabwo twazicira, ahubwo ifoto zose ziri gukorwa kugira ngo hongerwe umubare wabo, hongerwe quality mu kwigishwa ndetse na quality mu gukora. Ndumva icyo kiganiro gisubiremo kuko twakiganiriyeho ejo igihe kinini, igihe Dr. yajoraga urugero rw'inshenga n'akayunguruzo, tuvuga yuko tugomba kubyongeramo kugira ngo dutange ibikoresho, dutange standard, dutange amahugurwa, ndetse tunatange n'ingendo zo kujya kwiga uburyo ahandi bikorwa. Turabizi ariko akenshi iyo ukoreye muri context imwe bigorana kugira ngo umenye ibikorwa ahandi, nk'uko bavuga akarere katagurutse bikamenya iyo bweze. Ku kibazo cya rero kubaza ni ryari abantu babimenyereye b'inzobere bazafasha abandi, ndumva ntitwakwirengagiza yuko kabone n'uko dufite bakeya ariko ubufatanye burahari mu bitaro n'aho gukorera. Non-physician anesthesis na anesthesia, ndumva iyo bageze aho bahurira twebwe nk'abarwayi tugenda buza abaganga kandi barakora. Icyo dushimangira ni ubufatanye aho batangira serivisi, kuko minisiteri inyujije muri HRH icyo yashyizeho ni ukugira ngo noneho tunongere ubwo bufatanye noneho mu kwigisha. Ibyo ndumva n'ejo twabiganiriyeho yuko nyuma y'inama hazongera kubaho indi noneho iganira ku myigishirize y'aba nurse anesthesists, aba non-physician anesthesists n'aba specialist anesthesists, kugira ngo tuganire uburyo tugendeye kuri teaching plan zabo twashaka gufatanya ku buryo abaganga bazajya bafatanya n'abanasi n'aba non-physician anesthesists mu kwigisha, ndetse nabasobanurira yuko tumaze kugira partnership zitandukanye aho dufite n'abantu bari ready kuza kubifasha mu kwigisha, yaba aba anesthetic specialist cyangwa se aba non-physician specialist. Mu biganiro twagize ejo twaganiriye n'uburyo twateza imbere aba non-physician anesthetists kugira ngo barusheho kwihugura ndetse no kurushaho kugira ubumenyi mu kwigisha, kugira ngo n'abake bafite bashobore kugarukirana bigisha. Tuganira ku bufatanye bw'abigisha bari kuri kaminuza y'u Rwanda, ari ariyo ishuri ryonyine kugeza ubu ryigisha aba anesthesist ndetse n'abari kwa muganga bo kugira ngo ba banyeshuri ejo twagize ubuhamya bw'abanyeshuri bari hano bari kwigishwa ibibazo bahura nabyo iyo bageze muri sitara kandi niho hantu bakagombye kumenyera no gukunda umwuga kurushaho ibyo baba babonye mu ishuri twaganiriye ku bibazo bafite tuganira n'uburyo tuzasubiza kuri ibi bibazo kandi uruhare runini ni twe tubifite. HRH ikora, minisiteri y'ubuzima icyo ikora ni ukongera ubushobozi, ni ugushaka ubushobozi, kongera ibikoresho, gushyiraho izo standard twaganiriyeho kugira ngo uyu mwuga ukorwe neza kandi ibibazo bibonekamo bibe bikeya. Bijyanye na supervision no gufasha ba bantu bakiri bakeya abantu physician anesthesist boherezwa hirya no hino bikaba ngombwa ko bakora bonyine, ndumva icyo nacyo ari ikintu tugomba gushyiramo ingufu ndetse dufatanyije na association na council kugira ngo supervision yabo mentorship yabo ikomeze kugira ngo naho bari bashobore gupracticinga bafite confidence batumva ko ari abantu batererana bari ibi ngibi bari guhangana n'abaganga kugira ngo bafatanye n'abaganga. Ndumva rero muri make nashoboye nanditse byinshi ngomba gutangamo ubutumwa yaba muri department ishinzwe clinical service cyangwa se ishinzwe planning ni byinshi bireba HRH. Ndumva inama nziza natanze tuzafata position murakoze.
I think Vincent will have something to say.
I just want to say some few things. First of all, thank very much for the information on the intention of lawyers. So, uzayishinga mbere ya Kanombe azahora n'ikibazo gikomeye. Tugiye gutangira gucekinga turebe, because that's not good intention. Ikindi cya kabiri, the world today is different from what was 15, 10 or 20 years ago. The white coat na tukiri imana. Kera tuzanwa na kamana gatoya. So people now they start waking up, they start looking, they start to want to hear things about the doctors. So icyo nifuza rero professionals, we need to sit and start analyzing ourselves. Tukibaza say, are we really providing high quality standard of care? If yes, so. If not, then why? Niyo tunga safe anesthesia today, are we providing safe anesthesia? Yes or no? What we need to provide safe anesthesia? If we don't have it, how can we get it? Your colleague from Yagatare, he has issues. Have you ever presented those issues to your our viewer? Kuko, your women mediocrity, then you become just revenue. And when we get problems, how's that in short? So, to know EOM standards are always yes. Expect problems. And when problems come, uzibona. Kuko babandi baturuka muri za councils baza bafite ibintu bagenderaho bakakubwira wowe ese kudafite machine ya anesthesia. Hari wasabye bari kwiye. So we should start now making a lot of noise. We don't like to sit in a position. You would have fit in okay, I'm not going to do it. Here example or a sin is our very which is not correct. I think the following morning they could have get another person who will be working with us. So if you have a believe me, have a terror is created when wow. So you give Brown or Marsh, Bamba Musa. Simple. So that's how the world is today. But for tomorrow's law, we're going to march naked. Tukiwa wanasema kwa mafoto. Abarua ya wachera, I have one example in Mumbai, who yaje kushaka wanya mapo. Atu kugedozo ya mila duka. Actually, that patient I investigated, and she was what? Nahuye n'ibibazo bitari iby'abaganga cyane ariko ni infrastructure n'iki n'ibitanda n'iki ariko contact y'abantu bakoranaga nawe they didn't handle this case very well kuko iyo ugiye umurwayi ngo uzagaruke itariki akaza yikokoye agashaka tike yawagera ngo apana uyu munsi nta uzagaruke akagenda bakari bagatatu baravuga okay let me go and look for someone who can speak for me aragenda indaya arayigaragaza ntabwo uzajya kubwira umuntu agufashe arakubwira ngo sasa bazamenya ikibazo cyawe gute gereka hahandi abandi bose bazabona bumve ko koko ni mukanya and all these people outside here they don't know medicine buriya wasiyashika bavuze bamaze imyaka niba y'itanu bafite ikintu kiri hanze gisohoka wowe na muganga ukicara ukibaza how does it happen ese nibyo ntabwo ariko sometimes when we investigate all things urasanga dufitemo some responsibility so let us go back and sit down and say niba twemera amafuti cyangwa mediocrity let us take responsibility ntawe utubuza ushyiraho pressure kuri ministry we are end users so the kuvuga ngo if I'm not happy to give anesthesia in Kiziguro you cannot force me to leave ndavuga ngo ibi utabima sinzabikora because this is a human being napfa ntabwo uzaza kumubwira ngo uriya muntu yamubwiye kubikora buri muntu wese aravuga is mature enough why do you accept so n'utwo gutureba and if we force them to improve things will improve ariko nakubwira ngo genda wiyaranje nawe ukavuga ngo okay I can try my best one it's okay successful second but the third time azazamo ikibazo so we need to look at ourselves as a team ntugire ubwoba bwa media ntabwo uzabihindura aho bigeze if you look at the Twitter today it's one of the offensive place people they share information ntabwo uzatuvugira ngo minisiteri zabuze bariya bantu bavuga actually ikindi tubuze ni education we don't educate the people iyo ubise amaradiyo yose hanze aha hari abaganga abandi tutazi bavuga ku bintu byose bavura babandi bajya bavuga ku maradiyo but the real doctors we are ni gake cyane ubu umuntu yagiye kwigisha abantu what's anesthesia ngira ngo wabere n'intuza y'ejo bundi maybe bonane n'ubusobanuro kuri contact bonaventure ariko maybe we should educate them bamenye ko ibyo dukora harimo na risk ntabwo turi imana hari ibyo ukora hari aho ugera bikagucika nta kundi babigenza ariko we keep so many times quiet tukagenda tukijura ubutatu ngo kubera minisiteri itabuza abaloyers itabuza abanyamakuru they need to be challenged kandi we are all want to do that so I think we should change our attitude.
I think afternoon we are having a session on teamwork. I know you are busy, but people want to hear more from you. So if you are not able to come back, please delegate even good. Thank you very much. We have a session on task sharing. So those brilliant great people here will come back at after lunch for another great session. Teamwork. It is wide. We made it open and wide so that we can again go deeply in discussion. How can we work in team? So I think that will help us to continue.
Thank you so much for these great discussions. I think it's really been great and wonderful insights for message that we got from here today, and we'll continue to hear from our guest panelists, specialists. If you wanted to say something, but please, 1 second, so that we release the panelists to go.
ubundi umupanelist ahanini nawe ufite ikibazo bakunda kubaza ariko ushaka kwibwirira Shema hari ibintu muri minisiteri muri polisi zikora bita ngo packages mu district hospital hari ibyo bemerewe kohereza za procedures imiti ibikoresho ibintu nk'ibyo please hari special cases cyangwa special professionals zipatikiye rwose icyo kintu bakagitekerezaho. Hari ibintu abamiseziste bo muri district bakenera bakabigura kuko ngo hopitale zabo zitemerewe kubigura, naho bashobora kujya gushaka muri kamerwa niba ariko tuyita, ugasanga ntibashobora kubibona kandi yakagombye kuba bifite kugira ngo babashe gukora akazi. Icyo kintu uzajya tuvuganira.
I think it's time to allow our panelists to go. I really thank you so very much. Please give them a round of applause.
Urakoze panelist, urakoze umuyobozi wa panel. Hari wenda ku kibazo Alex yarabajije, hari standard wenda wabaye leader wa standard wa safe anesthesia mu Rwanda. Standard mu bintu byanteye umujinya kugira ngo mbese nabaye ahantu bifitiyemo n'umujinya. Nageze mu bitaro bya Ruhengeri batanga general anesthesia without monitor. Yes, it was that. Yinjira navuze ngo iyi ni open the gate to jail. Bitanandika ibikenewe bidahari iki byose nta reka bamwe ikintu kitahabaga, ntabwo habaga defibrillator mu bitaro byose. Impamvu deje ntabwo ibyo bintu byose details ntazazi, ariko you are there kuba advocate w'abarwayi. Icyo kintu iyo spirit bahora bayitubwira muri anesthesia, you have to be advocate of profession, right? Ukaba good communicator, ukaba advocate. Buri ahantu hose nahuriraga na deje namwishyuraga, nawe akantu abonye ka opportunity yahakaha. Kugeza ubu ngubu theaters zose enye, iya gatanu ntabwo ikunda kuva cyane, iyo technology zifite monitors. Dufite ICU cyangwa ikora nka HDU, dushobora gutanga minimum mechanical ventilation ariko tukakora na monitoring. We have defibrillator no hari biburaho. Hari have a new machine, new anesthesia machine. That's good. Ariko dukeneye ko ijwi ryanyu namwe murizamuye. Mwe kubaye gusa nk'abantu bakora gusa, ntabwo abantu bazi ikintu. Niyo mpamvu babwira ngo ni minor surgery, uramfasha, you give a small dose of anesthesia. Ketamine, yes. Please, muhagarare muri umutekano w'abarwayi. Hanyuma Ministry of Health ndabizi ko it was a big battle. Now battle yatangiye tutaragera bikiri mu mushinga wo gukora iyi document. Ndibuka twaspendinze 2 hours network icika twoye tugashyiraho kugira ngo twemerane imiti. Bati imiti yanira hehe kubwira abantu ngo umunsi nagize iyo bita MH na malignant hyperthermia ni death, either a patient is resuscitated or die. Muduhu uyu muti ntabwo ni nko gutunga ikibuga kinini ariko bagira umuhirwe ntazagire gutera kirwanisha. That's fine, umutekano mufite yagize gutera kimurashisha ni uko imiti yashize. Ariko gake hari imiti imwe n'imwe biremeye wenda document izasohoka bagire essential. Hari imiti imwe n'imwe biremeye itarabagaho itaremerwaga nk'imiti essential, like nitrogen, like dantrolene, kujya pesa arimo mugira mwenye, like for local anesthesia, antidote for local anesthesia, intraliquid, yes, safety muhumure gake dukora advocacy, tuzafatanya turwanye intambara. No ku bakozi twebeye ko general anesthesia abantu bagomba gukora induction ari babiri. Nahoze bibwira abantu ntabwo kugamije amafaranga, ntabwo kugamije ikindi, ni umujinya natewe n'uko mbona nta safety ihari. Murakoze. Without delaying or taking time for other panelists, we'll invite Now the next panel is about capacity building and education in anesthesia. Will be the Dr. Etienne will be moderator or facilitator, and will be inviting the principal of cemeteries is not there. Have a dean. Okay. Okay, we have dean. We have okay. Probably may be inviting other panelists.
mwaramutseho yewe ndi informere kwicara simbishobora mvuga neza iyo mubaza iyi pano yacu igizwe na madamu dini na dini please madam step to the right igizwe na John Mugarura please welcome two students. HOD from anesthesiologists.
Program director.
Program director HOD. Dr. Françoise, please welcome. baduhaye taske ikomeye ariko ndatekereza ko tugiye kubisangira. Turatangira tubaza ibibazo hanyuma namwe muze kudufasha kumvikanisha capacity building in education. What can be the pitfalls? What are we doing today? What is the future of this profession? Tunababwiye ngo kaminuza ni pipiniyeri iturukamo abaprofesiyoneri bose bari hanze, kandi ntekereza ko ntibeshye. Ariko mbere yuko dutangira mfite akabazo gatoya ko kuri liability insurance kakomeje kumvika numva nakarekera aho ngaho, sinzi aho ngabaza, numvaga nshaka kukabaza fandi Eugene, ariko n'ibibazo mvuga agasubiza aze kutubwira. Nakunze intervention zabo bagiye bakoresha amagambo presi, ndagira ngo buri wese ayafata as a take home message. Tugitangirana na Professor Paulin na Sheva barimo tudiscussing ku ijambo ngo liability insurance or malpractice insurance. Ariko tumaze kumva ibyo wavuze, seems that there is no malpractice insurance, isn't it? Professor Mboga, correct it, Mosi, correct me if I'm wrong, yakoresheje ijambo unavoidable. Iryo jambo murumvaga agaciro kayo? Unavoidable. Bishatse kuvuga ko iyo waza kureba ugasanga ibyago wagize byari avoidable, ya insurance dushaka ntabwo izaba. Indi take home message bavuze ngo hari icyo bita malpractice, abona quality standards. Ikintu uvuye mu mutwe, what is malpractice? Which is your it's deviation from the standards. Then what is our role? Is to define our quality standards. The big gap is what are the key indicators for quality standards to make sure that in the case of incident, really we can check it as a good practice. Njye nibaza nk'umuntu agize ibyago polisi ikamuhamagara umuntu wamufunze wamufunze burya kubera muri practice cyangwa kubera unavoidable event that happened. Biragoye gusubiza icyo kibazo kuko ni ngombwa gufasha inkiko kudefininga what is my practice in your profession. Yawe kandi yakarese kuri Faisal hari process and procedures yawe kandi yakarese ubigenza kuri Faisal bigenda hari ikintu bavuza byajyaga biba kera gikora hari ikintu bavuzaga muri emergency byose bihagarara abantu bakwiruka bafite ABCD to follow niba guhamagara mu kwigenga. I think this can be in the category of malpractice. No, ikintu numvise kwa afande Eugene ni uko liability insurance ikintu kimuhigo ikibazo mfite kuko za incidents zirimo ziba kandi bamwe bakaba barimo kwiryozwa bihagaze bigenda umuntu yirwanaho bimeze bite muri iyi minsi igihe documentaries
uzabaze munsi yacu abantu bajya mu rukiko cyangwa se ibitaro yatsindwa arekareba muganga none wakoze icyo kibazo akaba uzakomeza kwishyura amafaranga. So ni ukuvuga ngo turacyari fragile sama n'ibitaro bishobora guprotektinga wowe nk'umukozi w'ibitaro. So izo kesi zirahari zaba zabagamo n'abamwinjira mu buzima bw'abantu akajya mu rukiko yatsindwa niba uzakomeza kwishyura ayo mafaranga. So ni ikibazo gikomeye cyane. So but hopefully tumaze kukivuga inshuro nyinshi cyane abaganga barabishaka zindi fora bagomba kuziganiraho tukareba aho byapfiriye impamvu tutava aho bigeze ariko we need it but we need it of course nk'uko bivuga ibi byose ntabwo ari malpractice ibi byose dukora hari accident nyinshi zibaho kuko ntabwo utazi ariko n'izindi abarwayi cyane abarwaza ikintu cya mbere ni uburanga yabuze mu bya bindi byose twavugaga bya quality of care ukajya kuba umuntu unamusobanuriye yamubwira complication ugaca mu byabo wawe w'inyuma kugenda you leave the family alone kugira ngo batangire bamenye what's going on. So icyo gihe rero nabo bashakisha amakuru baza kuyabona wenda from the porter cyangwa the cleaner bose ni abantu bo kwa muganga kuko bayatanga ayo makuru. So everyone is interpreted differently ariko abarwayi sometimes are not very complicated if you are close to them. Ibintu byabaye byose ukababwira ukabagaragaza nina na complications zabaye. So iyo rero niyo tugomba kwiga izo standard uvuga nitujya no mu rukiko kuko ibibazo zabaho we need to show the people do byose byarakurikijwe kuko bigomba gukora ariko iyo harimo gap then we'll be in trouble.
Ducunguje uburyo umwete I would like to invite our panelists and ask them to introduce themselves. So if you have a question, you know who you are addressing the question to. Okay? Please, with the due respect, introduce yourself.
Good morning again. Dean Rugeli, the Dean of the School of Health Sciences.
Thank you. I'm John Mugaruya. I'm Director of Teaching and Learning at the University of Rwanda College of Medicine.
Thank you so much. My name is Francis Miguel. I'm here as a representative of student of planning physician and anesthetist graduate.
Thank you. My person is now finishing my residency in anesthesiology. Thank you. I'm Françoise Eugene. I'm and I'm the head of Department of Anesthesia and Critical Care.
Thank you. We are expecting the principal of our college. She's on the way coming. She might be here anytime from now. So, the way of interacting with you people is just to exchange on certain points. The role of a university, we are contributing into capacity building, especially on the level of human resource development. We can't work alone because quality development in the health sector depends on different factors, including working with the different partners to make sure that the quality we are producing at the university is making impact in the community. So we develop human resource, but employment, retention, and making sure that they will improve the quality of care is beyond our scope. This is why we partner with the Ministry of Health and the other different partners to make sure that our aim of getting into safe anesthesia for each one is achieved. We can't achieve it alone. Now, our focus will be on education, and I have a question for you before you ask a question to us. My first question is for all of us, and you can answer it if you feel in a position to do so or willing to do so. But I'm inviting all of you to think about it. You will get time to answer it. Kuba waba muri kaminuza, icyo ni ikibazo cya mbere. Ni izihe nshingano wahuye nazo ugasanga utaraziteguriwe muri kaminuza? Icyo ni ikibazo cya mbere. Ikibazo cya kabiri, waguha amahirwe yo gusubira mu ishuri uyu munsi, waguha amahirwe yo gusubira mu ishuri uyu munsi, none uyu munsi bati nguhaye amahirwe yo gusubira mu ishuri, ni iki wumva wasaba ko cyigishwa wari utegereje utaboneye muri kaminuza? Ikibazo cya gatatu ari nacyo cyane, ntabwo nshaka ko muza kuvuga izina. Haba hari umwarimu wakwigishije ugenga imikorere yawe uyu munsi? Is there any instructor, lecturer, professor who inspired you and he's influencing your way of doing things today? Those are my 3 questions. Before you start to ask questions to the panelists, then I want you to think about it, and I will ask you to answer them later at the end of the discussion. Thank you. Now, the floor is yours. Do you have any question to people who are in charge of contributing to quality of education towards the impact in a community and making sure that we have a safe anesthesia for all Rwandans? The floor is yours. I'll be taking the mic to anyone who have a question to ask, and make sure that you address the question to a specific person. Or if you want to do what we call open thinking, then talk about it, and then we'll look for one who can address the question. Thank you. Any question?
Thank you very much, Dr. Ken. I'm Jules Dodi. I'm a physiologist, and I'm in charge of clinical education and research at CSUB, University Institute of Ghana. One of the challenges mentioned during the program presentation is the issue of quantity of MPA and anesthesiology, but
moment, if you see the number of students we already have in training sites, I mean hospitals, you'll find that the ratio students and patients, you have really many students compared to the number of patients we have. And one of the reasons is that most of students are located in teaching hospitals, and we have few teaching hospitals, which means that we expect to have really high number of students. And I would like to raise this issue and propose a suggestion that we can see how we could upgrade provincial district hospitals so that we can reduce the burden of having many students at the same time coming from public institutions or private institutions.
Thank you. Ntabwo cyari ikibazo, mufite amahirwe, cyari igitekerezo, ariko afite ikibazo, afite impungenge ko muboherereza abanyeshuri bagenda baruta ubushobozi bwo kubakira. Hanyuma akavuga ati ko ni mu bitaro byigisha ubanza ari twebwe mutagetinga habonetse n'abandi batwunganira ibintu byajya mu buryo. Ntabwo cyari ikibazo, ariko tuzaza kukigira ikibazo kugira ngo mugire icyo mukivuga. Ari ufite ikibazo cyangwa icyifuzo?
yagaragaje ko muri university hasigaye hari abanyeshuri basohoka noneho baca mu kaminuza na big particles nazo zikanyuramo, meaning badafite training ihagije cyangwa badafite quality training. So my question is, how do you plan to balance between producing highly qualified anesthetists without compromising on their quality, but how do you plan to produce more, since we know that there is a gap and there is pressure to produce more anesthetists? So how are you going to balance that? Produce highly qualified anesthetists without balancing, without compromising on the quality of the system?
Ikibazo cyanjye kibaza Dr. Françoise, tuvuga kuri education, ariko cyane cyane tukavuga abakiri muri kaminuza cyangwa mu buryo bakoreza stage. Ariko iyo kuko tuba tuvuga kuri NPA, dufite abari mu kazi already bakeneye gukora za refresher courses, ariko tukaba dufite ikibazo cy'uko abantu niba ari babiri uzabona umuntu wideplasa kugira ngo aze gukora za training zitandukanye, za seminari zitandukanye, ufite ubukumbire. Ikindi kandi nta wundi muntu bafite aho hafi ubarusha niva nibura ushobora kubigisha. Gusoma ndabizi umuntu ashobora kuba wajya kuri interineti ugasoma, ariko ibyo ntibihagije. Nk'abakuru bacu cyangwa se nk'abaturusha ubushobozi, ubumenyi, muradufasha iki kugira ngo abo bantu bari muri rural areas mu by'ukuri bakomeze kuba muri standard? Kuko umuntu wize akaba amaze imyaka 6, 7, 8, 9, 10, nta kindi kintu yigeze yongeraho, agikora bya bintu bya rutine. Nabyo ni ikintu dukwiye kubaza, nimuduhe n'iki kintu ugiye kudufasha n'abantu bari ku rwego rwo hejuru yacu. Murakoze.
So thank you. Now ifite ikibazo wenda byinda nabisubiza, ariko nambara yamufasha. Nyuma kera dukora exam y'abanyeshuri undergraduate. So twari dufite umuntu external examiner yabize certificate. So twakunda baza abanyeshuri batandukanye, ariko tugera kuri umwe biramunanira. Umuzungu arambwira bari wenda icyongereza cyane
knowledge yari kidogo sana. Naona mzungu arambwira ngo uyu wese exam. But this person can effectively kill a patient. So I remember that one. So wanga twade ani giye tujya mu bitaro ugasanga abantu baravuga ngo uriya harangize cyane. So how can we ensure yuko abantu basohotse muri iyo process yo kwigisha asohorwa abantu bashobora gutanga safe anesthesia? People are really qualified. Apana bya byo gutanga diploma abantu bagende bazigira kuri terrain oya. How can we make sure yuko we teach people and we are happy yuko these people basohotse bagiye gutanga safe anesthesia?
Thank you so much for raising the question. I think this is a very important question. Even yesterday we came back on this issue. Ni ikibazo gikomeye kuko abantu twese nibaza ko tukibona nubwo wenda abakirayitinga ari bake. Ndabaha urugero, muri Afurika tujya dukora mission zitwa outreach. Tukamanuka hariya ko muri izo district turimo tuvuga. So surprisingly iyo ugezeyo usanga hariyo umu-NP yabarotekinzeyo, uzi neza ko yabanyuze imbere y'abanyeshuri akora ibintu hafi ya byose neza, wagerayo ugasanga ntakibuka intubation, ntakibuka gufata rento, kubera ko he has been doing just spinal, which means spinals akora they are not safe anymore. Kuko once that baby agize high spine, she doesn't have someone to intubate her so that they can provide oxygen. So iyo niyo reality dufitemo. Ugasanga hariyo machine ya anesthesia, very new machine of anesthesia, they don't even know how to brush up free electricity. So that's the reality. I've seen it in my own eyes, with my own eyes. So harimo navuga ko harimo issues nyinshi aho ngaho turi buze tubonamo. Hari wa muntu uriyo wagiye kubera ko ari wenyine isolated, hanyuma arakora ibintu biri very limited, akaruzinga knowledge na skill, ibyo buri wese arabyumva easily. Hakaba hariyo resources in terms of materials zidakoreshwa kandi wenda ahandi bazikeneye bakazifite. Icyo ndumva mucyumva neza, si ngombwa ko njya gusobanura byinshi. So reka wenda njye ku cyo Alex yavuze, how can we help those people? Ndabaza kubanza kumubaza ikibazo nk'umuyobozi wa Rampa. Nibaza ko ikibazo ariko yakagombye kuba nk'umuyobozi agomba guhita anatekereza kuri solutions, kuko he's among the people who should be like the leading yuko haboneka solutions. Aha ngaha nibaza ko kuri schedule nabonye bari batumye aba NPS 15 abo dufitemo hano baturutse muri izo rero twese n'ibanga. Icyo ni icyo araza kunsubiza, kuko aha this is the starting point. Uriya muntu iyo agiye akaba isolated, he doesn't or she doesn't have any contact with the rest of the team, aho niho ibibazo bitangira. So we don't have to isolate ourselves. Niba hari meeting, niba hari conference, niho abantu bahungukira mu mutwe akamenya what is going on. Uko navuye mu ishuri bimeze gutya, ubu noneho bimeze gutya. Ese anesthesia igezeyo mu Rwanda cyangwa n'ahandi hose? Noneho hambere umuntu akungukirana. Noneho tujye kuvuga wenda ngo ku bijyanye na knowledge cyangwa na skills aba yajyanye hariya, ese how can we keep them
icyo ni ikibazo nibaza ko kuri level yanjye ntushinzwe postgraduate y'abanyeshuri b'abaganga reka muheshe ijambo ngo kirandeze ariko ntabwo kimeze kuko part of the team nibaza ko ari ikibazo kigomba kujya kuri level ya society zombi yaba iy'abaganga yaba iy'aba NPS kikigwa noneho abantu bakavuga bati ese twagikemura gute hari uko dushobora kuvuga tuti tuzakora training zihora z'abo bantu tukajya tubahamagara solutions ni nyinshi iyo abantu bicaye baganira ku kibazo byanze bikunze solutions ziraboneka zaba iz'ako kanya cyangwa iza long term cyangwa long term solutions ariko zizaboneka ahubwo nibaza ko ni ikibazo kigomba kujyamo society zombi byaba na ngombwa na Ministry of Health. I think na Ministry of Health igomba kuzamo kuko niba izo society zikeneye support Ministry of Health igomba kuba iya mbere kugira ngo idusapoti. So ntabwo ibintu byinshi rero numva aho ngaho birasaba ko twicara biragaragara ko ikibazo gihari ahubwo nitwicare dushaka ibisubizo kandi bizaboneka kandi turashoboye kuzabikira murakoze.
To summarize,
Okay.
summarize, kwiga mu ishuri ntabwo bihagije rekeraho, hakenewe continuous professional development. Learning, it's a lifelong process. Hari ikibazo ntabwo ari ikibazo cyari icyifuzo ariko kijya gusa n'icyaduka rero kugira ngo dira dufashe ubuza mute quality na quantity mu bitaro bya teaching hospital cyangwa mu recruitment abanyeshuri.
murakoze cyane sinzi ko ntibubone igisubizo kibyerekera ngo bibajije cyangwa babibajije cyangwa babitekereza ariko reka ngerageze reka mvuge ku ba non-physician anesthetists nibo bari muri school yanjye wenda statistics zo mu baganga sindazimenya neza hari wenda reka ntangirire ku mibare kugira ngo tuza n'ababyumva kimwe. Uno munsi mu mwaka wa mbere reka tuvuge dufite abanyeshuri hafi 40 muri mu wa kabiri ni uko, mu wa gatatu ni uko, mu wa kane ni uko. Muri department yose dufite abarimu navuga ko ari full time ni 5. Muri abo 5 harimo 3 baba tutorial assistant bakirangiza undergraduate. Murabyumva? Noneho ubwo urumva rero dufite noneho Ministry of Health itubwira ngo twongere umubare w'abo twigisha kandi abo ababigisha siko biyongera kuri icyo kigero ngira ngo already natsinzwe ntaranatangira gusubiza. So niyo mpamvu ntekereza ko no mu ntego y'uno munsi discussions z'uno munsi we have to think about this, about how we can go about it, how we can increase the quantity but increase also the quality, because I cannot say that we keep the quality because we probably don't have after everything that everyone has been talking about, after all the incidents that we've been discussing. Ntekereza ko dukeneye kuzamura the standard, the quality. Ariko noneho nkavuga ngo ntabwo ari Dr. Sereko cyangwa Thomas cyangwa Aline bazigisha b'abanyeshuri bose babigisha mu ishuri banabigisha mu bitaro 15-20 baboherejeho kuko wenda mumare n'impungenge ntabwo ari sashibwe yonyine twohereza kuri bitaro byinshi, ariko uko twohereza ku bitaro byinshi ni nako tuba dukeneye gufasha babandi bari mu bitaro nabo bari mu bigisha, kuko turavuga tuti tubohereje abanyeshuri mudufashe kubigisha kubera ko ari nabo baba bari cyane cyane kuri front baba bari more updated. Ariko noneho nk'uko mwahoze mubyumva nabo already bari overloaded. Niba ari umuntu umwe ufite cases 100 noneho ukamwohereza n'abanyeshuri ngo mbere y'uko udiringa na za cases banza wigisha n'abanyeshuri banjye urumva ko really ni burden ikomeye. Niyo mpamvu ntekereza ko we have to think of innovative ways of supporting these cadres. Niyo mpamvu ntekereza ko wenda solution, short term solution ubu ngubu ni partnerships nk'uko Shema yahoze abivuga. Dukeneye gupartneringa n'abantu n'ama institutions atandukanye, ariko noneho tunihereho yenda sinzi kongera baraza kumbwira ati tweho turuvalode, ariko no muri ya workload yacu tugerageze dushyiremo n'ingundi tugende dusapotinga naho bishoboka, noneho dushake na support yo hanze ariko twakoze twujuje ya hard workload.
Please welcome. Kuba ari hano birerekana agaciro aha inshingano ze. Wavuye muri rwinshi yari yahamagaweho ariko aje kudutega amatwi ngo aduhe n'icyizere. Please clap for her. Kuva mu nama z'ejo nabwiye abantu ko tutari batermometre gusa, rero nabatermoza. Iyo tuza kubaza ntitumubaza ibibazo ugomba kupropoza neza. Iyo wageze muri iyi nama uba utera imbere ageze mbere muri icyo bajyana ikibazo utera imbere, then we see how to deal with it. The next question was Tunga.
Thank you very much for the very good questions. Nabajijwe ibibazo bibiri na Mukabuzima ariko numvise ibibazo byose biri related. Ndagerageza ku ibisubizo ntanga kubikomatanya byose. Kugira ngo twibukiranye mu gutangira ko written concept iri complex, kandi kugira ngo igireho ntabwo ari it's not a one way traffic. nta na filozofi imwe wavuga ngo ugendera kugira ngo igireho. Mukabuzima yambajije mbishyize mu magambo yanjye navuga ngo how do you balance quality and quantity? Ni ikibazo gikomeye. Ahandi mu standards za medical education, health professions education, ubundi ntabwo ushobora kubona accreditation udafite ibitabo wigishirizamo. Igisubizo ngiye gutanga nagira ngo simbe philosophe ku buri wese nyumve, cyane cyane ishema ry'umutwe. Hari assumption y'uko ibitaro byo mu gihugu byose ari ibya kaminuza y'u Rwanda ibifiteho access, kuko ibitaro bya public hospitals, we are a public university. Ariko wajya kureba ugasanga rimwe na rimwe ibitaro wa mugari n'ibiri kubikenera kugira ngo utange quality training, ndetse wajya no kureba ugasanga n'ibitaro ubwabyo already biri understaffed, ndetse wajya no kureba ugasanga patient flow idasi ikibazo, ariko kandi ntabwo serivisi zitangwa ziri ku gipimo cyo hejuru cyane bitewe n'ibikoresho, bitewe na staffing. Ibyo rero bigahita directly compromisinga uko twigisha, ariko ibyo ntibivuze ko tudakwiye kwimprove again in the sector. Noneho kongera we are a public institution, therefore nitwe turi ku forefront yo gukemura ibibazo bihari. Niba minisante ivuze iti dukeneye NPAs benshi, abahari ntabwo murimo guhaza isoko, ubwo nitwe baba babwira. Iyo bavuze bati ntidufite abanasi benshi, nitwe baba babwira. Iyo bavuze bati ntidufite anesthesiologists benshi, nitwe baba babwira. So how do we balance, how do we strike a balance between the request for a sufficient number of healthcare providers and providing quality training for those that we graduate? It's a continuous war, ariko uko tubigenza nuko uko quality process dutangirira muri admission, turizinga standard kugira ngo turebe ko dufite the right candidates, kandi icyo ngira ngo tukigeraho. Icyo nishinja wenda mbabarire nkoresha umwanya mwinshi ho gatoya, icyo nishinja nuko hari igihe dufata abanyeshuri beza cyane ariko ntituba transformingemo necessarily high quality professionals kubera izo variables navuze. Abarimu bake, facilities nkeya, nazo zitari kugira ngo zigere icyo dukeneye gukora. Icyo tugerageza gukora rero ubu ngubu ni iki, nubwo tutaragera iyo tujya. We believe learning is not a one man's business, learning and teaching. So tugerageza gukora synergy hagati yacu, abarimu n'ibitaro. Are proficient, are very competent kugira ngo yinjire muri pool ya professionals, ariko yanyota tugerageza kumurima we kuba arayiga, tubirivinga ko ikwiye gutuma agira proficiency. So feeding mu cya Alex na Françoise twasabye councils schools zose wacu ni CPD providers. So turasaba ahubwo professional societies and councils ko mukomeza gufatanya natwe gutegura ayo mahugurwa. Turabikora ariko ntituragira icyo nka Center for Mental Health mu mahugurwa natwe iwacu n'iwacu mu miti yanjye ubushize duherutse guhura n'abakora akazi ka laboratory mu bitaro, sharing standards, sharing inyigisho turabikora ntituragira iyo tugiye, ariko iyo niyo ntambwe tugenda dutera. How do we reach out to professionals? Iyo dufatanyije mu raising a standard ya practitioners bidufasha natwe kugira ngo quality yacu izamuke uko mu twigishiriza. Ndumva byose nsa n'uwagerageje kubihuza, ariko nanone mbibutse ko n'icyifuzo cyanjye ubwo mfite mikoro, twebwe turi nk'uruganda producinga abantu kugira ngo uruganda rukorere agomba kuba inputs. Hari abanyeshuri, hari abarimu, dufite role bashaka, ariko nta role dufite kwita. So please Ministry of Health mudufashe. Iyo ugiye kureba ubwo mutubaza ngo quality quantity, iyo ugiye yatangiye medical school ishobora kurenza abanyeshuri 40, abo ukayatangiye medical school nizo nishobora kurenza 35. Kubera iki? Kubera ko quality irahenda. Niba ushaka kugira ngo matching quality with quantity, ongera na inputs, kandi ntabwo twebwe twashobora kongera inputs twebwe dukeneye contribution ya partners bose. Murakoze.
Turakomereza ku kibazo nabajije, ndifuza ko gisubizwa n'abaganga babiri, umwe we anesthesiologist undi undi muganga, hanyuma ikindi kize kuba undi utari umuganga. Ikibazo nabajije ni cya kindi ngo uvuye muri kaminuza ni iki wasanze mu nshingano utigeze utegurwa muri kaminuza ushaka kugisubiza, ariko umuganga uri anesthesiologist. Okay, go ahead.
wambabariye ataravuga ko hari ikintu ngo yavuze nibagiwe. Nshaka kuvuga mu munota umwe icya interview yagiyemo recruiting abana muri undergraduate, umwana wayobewe icyongereza akaberwa igifaransa akaberwa ikinyarwanda, cyajyanye na cya kintu avuga ko quality ari ikintu kigara abantu benshi ba contributing. Nabivuzeho hejuru, tugira ibyago yuko dusuzumwa kuri output itari yacu. Ni ukuvuga twakira umunyeshuri umaze imyaka 12 yiga, simvuze ko nta roro dufite. Iyo tumwakiriye tugomba gukora uko bishoboka kose tukabridginga na gap yazanye, ariko nanone hari abandi dukwiye gufatanya kugira ngo aze uba n'imitekerereze iri hasi biragoye. So tugiye gufatanya n'abandi kugira ngo wa muntu uva hasi aze nibura ari umuntu dushobora gufata tukamugira icyo dusabwa kumugira cyo. So iyo si roro yacu, ariko wenda twatanga ibitekerezo.
Murakoze. Nitwa Jackson Kwizera, ndi anesthesiologist Kibogora. Yabajije ikibazo cyiza cyane ati kuva wava mu training from school, extra duties ubona ubazwa utigeze uba trained about ni nabyo byinshi ahubwo, rather than anesthesia have to provide. First, aho nkorera usanga ntegekwa kubanza nkajya kuvugana n'umuyobozi kugira ngo umuti uboneke during. Second, sometimes I do transfers zitari ukuvuga physical taking a patient from one point to another point, but the way you need to deal with minds of people that you didn't train about, or kubwira director general w'ibitaro mubwira ngo uyu munasi arabasha gutransporting uyu murwayi. Iyo ni transfer of knowledge that you need to just transfer. That's about education. Third, you need to meet maybe the mayor of the district and then discuss about health. Fourth, I was involved in essential drug list training. The workshop nasanze sometimes ukenera kuba warize psychology, politics and everything like kugira ngo bashe kubwira mayor nabo bakorana na hospital uburyo uyu muti ukenewe nubwo uyu murwayi atabasha kubona ko nawe ugura ubwe. Ni byinshi cyane ariko waba utwaye
ndashaka n'umuganga utari anesthesiologist. Hari ikintu waba warageze mu kazi ugasanga baguha inshingano muri medical school.
It's very interesting. Your question, it was sort of a rhetorical question. Kurusha uko washakaga ibisubizo. Kuko nawe urabizi. Twize kuvura nkatwe eventually tuza kwiga kubaga. Kamere kuri jye nk'umunyarasajoni. Ntawigize kunyigisha uko nzakora curriculum, ko nzakora nzigisha, ko nzagira gute. Ngeze ku ground, you want to know my story? Nageze ku airport. Remember I think it was like a 5th. Magera saa 9, saa 12 njya kwa muganga. Hari umuntu nari mperekeje nka saa 3. I think I met Dr. Ngoga nari mushyiri mugana ko umurwayi. Abayobozi b'ibitaro nkubitana nabo bati Dr. Ngoga najyana umurwayi ntiyakurigaza araza kubisotinga out. Come. Tell us list ibyo ukeneye. Urumva? Ntabwo uramara amasaha ane mu gihugu. So I have to make a list that I had never made in my life. Yeah, equipment nkeneye. So you make a list of equipment. Urabazwa na specification kandi you are even still struggling to know the names. Kubundi wategaga intoki bakaguhereza ukabaga, you know, like this. Then suddenly you have to make a list, you have to make specification, you have to look for the cost. So that's baptism. Uchagera utaramara n'amasaha 6 mu gihugu. So ibyo tubazwa abari byinshi cyane kurusha ibyo tuba twigishijwe. Ahubwo I think maybe kuko turiho to discussing issues education. Kuko na cost burya ntago tujya tubwira nk'abaganga twirinda kumenya the cost of things we are using. Ubundi professional it is good ko uba wanga utaza gutandukanya abarwayi according to their abilities. Wowe urebe handling of disease. Ariko reality ugasanga nyine niba ikintu kigura miliyoni 5 umurwayi we ntafite n'3 nibyo Jackson yavugaga. So ibyo byose ntago tuba twarabyize ahubwo ngira ngo ariko nabonye kuri kaminuza bisa naho haraka element muri postgraduate twashyizemo ko kwigisha abantu ibintu by'amafaranga niki. So it's good kubishyiramo kugira ngo bamenye niba nambara gloves ubundi wambara glove and a small thing you throw it ugashyira hindi ariko the cost of that glove at the end when this patient is going out bizajyaho. So economizing ibintu burya nicyo gituma tutabizi cyane kubera ko tuba twaragiye muri professionalism tukirinda kumenya the cost of things kugira ngo urumva uriura protecting umuntu from judging patients according to their pockets. Ariko eventually you're going to do it anyway. You nugera mu field. So maybe we should teach people in an innovative way of knowing kugira ngo na wundi wenda uyu nguyu aba yiha kwishyura uyu, kuko eventually that's what we learn. Nk'ubu ngubu usanga ndiho nsabira abarwayi niba nshaka kumubaga for example umugongo nkabona ntabwo ashoboye, nkabona amaze gukorera abarwayi 15 muri ya company, ariko wowe ko dukoresheje consumables zawe cyane, why don't you help this patient who doesn't have, ukazamushyira kuri costs z'uyu nguyu ukazazishyira muri giving back to community. Urumva izo skills ntabwo nazizi, ariko kubera experience niho ngiye ngira, I'm learning how to help patients using the things that I actually ugenda acquiring. So I think now we can't cover everything. We can't cover everything, but some of the things we should start putting them there, tukigisha abantu ko badakwiye kureba umurwayi as a source of money gusa kugira ngo yishyure ibintu yakoresheje, ariko nanone dukwiye kumenya uriya umukene ashobora kwishyura uyu nguyu umukene kandi bitabaye directly implicated. So nibyo ngibyo umuntu ni byinshi cyane twiga nka kimwe cya gatatu nangwa se cya gatanu cy'ibyo tuzakora, so dukwiye kubizamura bikagera nka hafi. Murakoze.
Reka twumve muri nasi ari ikintu bagutegeka uzaza ugomba gukora.
Murakoze. Muri nursing cyangwa muri midwifery hari ibintu usangamo ahubwo ukayoberwa niba ibyo wize n'ibyo ugiye gukora bigira aho bihurira. Ntabwo wigeze wigishwa yuko ushobora gukorera umuntu ibyiza akakwitura kugukubita cyangwa kugutuka, ugashobora kubalansinga kuko umuntu aremwe bumwe n'ubwundi, nawe ushobora kurakara ukaba wariactinga in another way, ariko ukabona wenda wiri gukorera umuntu ibintu byiza kakarangiza agukubise cyangwa akanakuvuna, kandi nawe wiyubashye ufite aho ukomoka n'aho uturuka. Na His Excellency yigeze abivuga ati kuvuga ngo ndi mwene runaka, ndi mwene nde, who is not mwene runaka. So ibyo nabyo ni ibintu umuntu atigeze yiga kandi bikamugora kubyakira. Ikindi cya kabiri ngiye kingora cyane cyane muri management, hari abayobozi baba bari hejuru yawe nk'uko murimo kubivuga, ugasanga turimo turitana nka ba mwana ukuntu muri profession, muri leadership. Ugasanga wenda abarwayi baraje nta bitanda pe bihari, umuyobozi akubwira ati kora uko ushoboye abo barwayi babone aho bajya, kandi arabizi ko ibyo bitanda bitahari byanabuze pe. N'abarwayi nabo ntibari bureke kuza, ntibababwire ngo ntimuze, kandi na wa munyeshuri waje urashaka kumwigisha ko akora neza, ko abarwayi batemerewe kuvurirwa mu ntebe cyangwa hasi. Ibyo nabyo ukavuga se ibi harya nigeze niga uburyo nabyitwaramo, ndubaka inzu, ndashaka ibyo nabyo nirindi hurizo. Ikindi nacyo bavuze ku bijyanye n'abanyeshuri bagomba gusohoka bafite quality, hari ibyo kaminuza isabwa gukora, nanone na minisante hakagira ibyo isaba kaminuza gukora, noneho na kanso zigasabwa ibindi, nanone ugasanga wayobewe uburyo wabikemura. Kaminuza barayibwira ati turashaka abanyeshuri 120 ku mwaka, minisante ikavuga iti turashaka abantu bafite quality services. Mujya mwumva muri nursing basakuza muri kanso bati kuki abanyeshuri batsinzwe ibizami bya kanso intambara zikarota. Kanso igategekwa yuko igomba kugira inyoroshyo kugira ngo abanyeshuri basohoka ari benshi. Hari n'igihe badutegeka yuko abanyeshuri baraturega tukajya kuburana, bakadutegeka ngo murebe uko mubigenza mubongerere amanota basohoke. Babantu umuraba deliberation ariko isohoye wa muntu no kutubwira ngo ntace mu kayunguruzo, kandi ni ministeri irabidusabye, kandi nagera kuri ground umuyobozi ati aba bantu banyuze hehe kugira ngo bagere hano. Ibyo bintu ntabwo byoroshye. Murakoze.
Ikindi kibazo rero nabajije kirasubizwa n'umuntu from a distance kugira ngo ducunguze uburyo umwete. Nari nabajije ngo baguha amahirwe yo gusubira muri kaminuza none aha ngaha, ni iki wumva wakwifuza ko bakwigisha?
umuvolontaire.
numva ntagiye kure banyigisha quality improvement ko nabonye kuba muri routine icyo kibazo dufite. Murakoze.
Hari ikindi kibazo cya gatatu ariko kugira ngo nyine saving time, hari ikibazo ngiye kubaza abanyeshuri, ntabwo ukiri umunyeshuri sibyo, ariko ikirenge ndagira ngo mbabaze, ni iki mwaje mushaka muri kaminuza na n'umu gitegereje? Ni iki mwaje mushaka muri kaminuza na n'umu gitegereje? Nyuma y'ibyo turaha ijambo principal.
Murakoze. Kimwe mu bintu navuga twaje muri kaminuza ariko n'ubu tugitegereje, byinshi mu byo twagasabye wenda numvise nkurikije inama y'ejo uko yavuze, numvise biporomayisinga, harimo kongera imikoranire hagati ya kaminuza n'ibitaro ku buryo ugera kuri site ugasanga mbese urabona umuntu wagukorera follow up cyangwa se internship yawe ukayikora, hari umuntu kuri site ugusupervisa akavuga ati bimeze bite. Gusa kimwe mu byo tugitegereje, ntabwo muri clinical placement tuba tumeze neza ku buryo bw'imibereho rusange. Usanga nk'abanyeshuri ba mbere bo muri CMHS hari amafaranga bafasha muri stage bagenerwaga, ariko ubu twaye ntabwo tuba tuyafite. Kandi
how does it affect your education? Ndashaka ikintu waje utegereje mu rwego rw'ubumenyi, na n'ubu ukavuga uti ndashaka byose narabibonye, cyangwa hari ibyo uri mu wakangahe?
Ndi mu mwaka wa 4.
Uri hafi kurangiza?
Yego.
Ni ikihe mu rwego rw'ubumenyi waje utegereje uvuga uti na n'ubu ndacyagitegereje, cyangwa uti byose narabibonye mu rwego rw'ubumenyi?
Ibyo na expectingaga narabibonye, ariko nyine ibyo bijyanye n'imibereho nibyo bigiraho bidindiza hamwe, kuko ntabwo waba uri muri clinical placement ariko yego yafekta practice dukora.
Yego. Urangije kaminuza ibyo waje ubitegerejemo byose umva bifite?
Murakoze. Navuga ko ibyo naje ntegereje mbifite. Personally, when I joined the program, I was curious. I wanted to know more about anesthesia. Nyuma nza kubibona ibyo naje ntegereje, ariko mbuze nko mu mwanya w'umunyeshuri ukiri mu resident ukiri mu ishuri, hari ibyo nifuza ko byahinduka cyangwa se byaba improved kugira ngo abone azamuke neza cyane kurushaho. Muri byo navuga nka recruitment. We need increase the number of residents who join the program by making strong program with organized curriculum. Then people out there bakaba interested to know about anesthesia because they don't know anything about anesthesia. And then to make the balance, kakayunguruzo twahoze tuvuga, it has to be kept tight even at the beginning of the program. And then to be kept around during the training kugira ngo tubone a good product of anesthesia providers, kuko in order to have a safe anesthesia it goes with education of anesthesia providers. Another thing is to increase the number of local staffs, because residents are taught by local staffs but they are really few. In case they are there, they are overcharged, supervising like 4 or 5 operating rooms at a time. This is very difficult to supervise directly the residents. So they also need to be motivated and facilitated, those who are interested in teaching. Another thing about education is, of course, to keep organized curriculum and teaching, but to respect academic days of students, because many times students miss the academic days because they are considered like manpowers of the hospitals. Yes, it is good to be manpowers, but because it increases the experience, exposure, and self-confidence of residents, but they have to respect the academic days of residents in order to increase their knowledge to go within the hospitals. Thank you so much.
Murakoze. Ibibazo nabajije deliberément kugira ngo dufidinge umunsi w'ejo. Ejo abantu bagiye mu magroupe hanyuma bakavuga ngo bazareviewinga programu bashyiremo ABCD. Imbere yaho rero nabanje kubabwira ko ibi gutestinga quality of a beer, you don't have to go to the factory. Ugomba kujya mubaze mwa yanze gukota ariko sha iyi nzoga mwa mwumva imeze. Hanyuma uko nabitegerezo kureba niba ntabikubita hasi nimumva kimeze nk'igishanga ibintu nk'ibyo. mwiyumviye yuko abantu baranga ntabwo ari ababonetse bose, iyo bageze ku isoko ry'umurimo basanga hari ibintu bibategereje batigeze kandi batigeze bategurira. hari igihe bavuze ngo mbo bashyiramo quality improvement, donc barangiza hano bategerejwe as a managers, they have a managerial position and the leadership. Some are supposed to do research n'ibindi byinshi. Hanyuma ya nkoko na brochette tukongera quantity, ariko our colleagues bagakomplaininga ngo abantu ni benshi. Now what will happen to the quality, I don't know. Now the floor is not mine. How CMHS address those complex issues to contribute to capacity building in education, especially the focus is in anesthesia. The floor is yours, madam.
Mwiriwe. Murakoze. Iyi nama rwose ndagira ngo twarayitegereje. Tumaze iminsi tuganira na association y'abaganga, anesthesist n'aba non physicians. Mu by'ukuri byari bikenewe na HRH yuko tuganira, ariko noneho tari gusa bakora umwuga wa anesthesi, noneho n'abandi. Reka mbanze mvuge yuko ikintu cyo gukorana teamwork kirakenewe cyane, na nicyo gituma dushima abantu batekereje, ndavuga association of anesthesists, ikaba ari abaganga, ikaba aba non physicians batari abaganga ariko bakora umwuga wa anesthesi, baduhuje uyu munsi. Nako kuva ejo muganira, ejo ndagogewe personnellement nashoboye kuza, ariko DTL yaraje, Dean sinzi niba ashoboye kuza, na Dean wa medicine nuko afite kandi kazi, ariko nawe yari kuza, sinzi niba ejo yaraje. HRH barahari kuva ejo. So mwarakoze. Ndabona hano dufite aba surgeons, dufite aba gynecologists, dufite n'abandi. Mwarakoze. Icyo kiragaragaza yuko mwatekereje kuri teamwork, mwatekereje yuko mudashobora gukora mwe mwenyine, mukeneye yuko mukorana n'abandi, mureba umurwayi ngo ufite ikibazo kimwe azanye ku muganga we n'umwe, ariko ugasanga afite ibindi bibazo byinshi bishobora kuba bifashwa n'abandi bantu bo muri team. Noneho tugiye kureba cya capacity building, na nicyo wenda twakomeje tuganira, abagenzi banjye bakomeje bazana quality, ariko na quality irajyana na capacity building. Capacity building rero mushaka ko tuganira, sinzi niba mwatekereje kuri capacity building gusa muri training, ko twege turi muri training, sibyo? Ako noneho tugomba no gutekereza kuri capacity building. Na numvishe abarangije bari mu kazi bakomeza bavuga ibibazo bafite. Haje n'ikintu cyo kuvuga ngo ntago dufite abantu bahagije kugira ngo dutange iyo quality care dukeneye. Ariko rero reka tubanze muri training, sibyo? Wenda muraza kumbaza ngo murimo muratekereza gukora iki. Ibibazo byo turabifite, abantu ntago bahagije. Ese ni izihe strategies murimo muraganiraho kugira ngo muzagira abantu bahagije muri training, mu building capacity, ku buryo iyo quality numvisha abagenzi bange babaganirije bakomeje namwe mwagiye muzana ibitekerezo ni gute. Reka wenda dusubire inyuma tuganire ukuntu cyane cyane programme nabonye itangira nagizemo wona n'uruhare ko nari ndi muri kahashe. Ni programme ya non physician. Mu by'ukuri yatangiye ari programme ikenewe cyane n'izindi programme na nursing kubera ibibazo tuba dufite icyo gihe. Nibuka abarimu tuba dufite bavaga hanze, ariko noneho n'abandi tuba dufite mu Rwanda batafite na niveau twavuga yuko twishimiye. Niyo gituma twatangiye twigisha A1. Icyo gihe nibuka muri 1999 twasohoye kohoti ya mbere. Noneho uburyo programme yagiye kura, uburyo twagiye dukomeza dusohora, ndagira ngo ni John na Sere kwa bikomeje bakomeza bavuga review. Abanyeshuri twinjizaga muri programme icyo gihe hatangiye abafite background ya nursing, haza kuza kuri programme zose yuko dufata abari muri sciences. Noneho aza kugaragara yuko muri anesthesia hakenewe abantu bafite skills za nursing. Tuza gukora iyo review bakomeje bavuga abagenzi bange, dushiramo imyaka 2 ya nursing skills. Ibyo byose twakoraga ntago tongeraga umubare bigaragara yuko dufite abantu bahagije bigisha. Ibyo systeme kuva muri cash nuko twafataga abantu bafite amanota meza bakajoininga program. Noneho nda kintu cyari gihari kigaragaza yuko abo bantu binjiye tugomba no kugerageza ku buryo bajya hanze bakiga. Abo bantu nababyo ko twakomeje tuzana bava hanze ba experts, navuga ba expatriates cyangwa ba experts muri domaine tudafite bahagije mu Rwanda, ku buryo tugenda tubasimbura. Abanyarwanda barangije turabafashe nka batitora assistant, bakomeje ari batitora assistant, benshi baje banadevia bajya mu bindi. Icyo ni ikibazo. Navuga ko aho ngaho ntago twagerageje gutekereza kuri capacity building yo kwigisha. Noneho haza kuza programme ya critical care. Twari tutaratangira bachelor degree neza, dufite ikintu bita bridging. Benshi bashobora kugira mahirwe yo kujya muri critical care, ariko critical care yari muri nursing, muri programme ya nursing. Ayo navuga ko yari amahirwe ko bari bo wabonaga bafite ubumenyi buhagije bo kwigisha muri bachelor degree ari A0. So icyo cyaradufashije no gutekereza ku iyo programme navuze ifite imyaka 2 ya nursing iri A0, ako no gukomeza bridging yasohoye abantu benshi. Navuga yuko ntago gose ari ikintu kibi twakoze gutangira bridging cyangwa A0. Twaragerageje turavuga ngo tukaba tutafite abantu bahagije, tukaba tutaragira we n'ubushobozi bo kuvuga ngo tufite abantu pool y'abantu bahagije bagiye kwiga hanze bagaruka bafite ubumenyi buhagije muri anesthesia, ku buryo to sustaining programme nziza dufite bachelor degree ikaba ari bridging, ikaba yongiyo ya itangira n'imyaka 2 ya nursing bachelor degree, ko na bridging ni bachelor degree. Twarakoze twasowe n'abantu benshi kuva dutangira muri 1996. Kohoti ya mbere navuze ko twasohoye 1999. Kandi murabizi yuko abantu twigishije nta yindi programme mu Rwanda yigisha anesthesist, non physicians, ni programme gusa yatangiranye natwe muri kahashe. Mwihamashi. None ubu rero turimo turatekereza ibindi tudafite capacity ihagije, turimo turatekereza masters bose tumaze iminsi tubiganira, ariko ntabwo twatekereza masters, ndacyari muri capacity building y'aba non-physician, ntabwo twahita dutekereza cyangwa gutangira masters no kurangiza program tukayijyana ahantu tutafite abantu bayigishamo. Ibyo rero turasaba HRH, turasaba minisante yuko badufasha. Suggestion twatanga, wenda na bagenzi banjye baraza kumfasha, nuko wenda abo bantu bacu dufite ubu twabuildings, wenda tutabuildings ku buryo buhagije kandi bushimishije, nuko tugira abantu bajya kwiga hanze bakagaruka bafite masters, bakanazatekereza gukora PhD. Ibyo rwose ni icyifuzo, tukamenya noneho gutangira iyo porogaramu. Ariko hari n'ubundi buryo, ari uburyo twavuga ngo turayitangiye tukiha myaka 5, nako turashaka ubufasha. Wenda muraza kuvuga se ubufasha ntabwo bwava muri kaminuza y'u Rwanda, no gufatanya ni twebwe na minisante na HRH tugafatanya, cyangwa n'abandi ba partners twabona, tugashaka abantu bava hanze. Navuze ko muri kashi nuko twashoboye gutangira programme ya anesthesia, nibaza na anesthesia y'abaganga nuko byagenze, abantu bava hanze, tukagira abantu dukura hanze, bizaba bihenze ariko bizahenda, tuzi icyo dushaka. Icyo dushaka niyo quality John yavuze yo muri training, ariko na quality yo muri service dutanga. Wenda biranashoboka yuko tugira partnership na university tuzi cyangwa tugiye gushakisha, tukabona abo bantu baza kudufasha mu myaka runaka, mu buryo abantu bacu wenda bagarutse tugenda dusimbura abo aba expatriate baza duhenda. Wenda mu buryo bwo kubivuga, wanasanga itazahenda cyane ko tumvikanye na university zo hanze dukorana cyangwa tuzatangira gukorana, wasanga abantu bajya baza tugasharinga cost. Wenda bibaho, ari university tugirana amasezerano, ugasanga bitaduhenze cyane. So reka mbivuge mu buryo bubiri, ni ukuvuga ngo tutrainiza abacu baragiye, tuyihaye nk'imyaka 5, tubonye abantu bavuye hanze mu ba partners bacu, university tumvikanye nabo, cyangwa abantu duhaye akazi baraje n'aba experts mu iyo domaine, baradufashije gutangira iyo masters, kubera iyo masters irakenewe. Tukeneye umuntu ufite ubumenyi buhagije, tukeneye umuntu umuspecialist muri anesthesia. Icyo turimo turatekereza nuko uwo muntu azaba afite background ya nursing. Reka nsubire mvuge yuko mu kureviewinga programme yacu iri ya bachelor degree, twasanze ari ngombwa yuko anesthesist, non-physician anesthesist aba afite ubumenyi muri nursing buhagije, hanyuma tukongeraho ubumenyi bwa anesthesia. So uwo mu specialist rero arakenewe kubera iki? Ubu mu gihugu turimo turatekereza kugira specialized care, tertiary specialized care. Uwo muganga ikibazo kiri mu baganga nacyo ndaza kukivuga, Paul araza kumfasha ko nawo ari bibazo by'abantu bakeya. Uwo muganga w'umu specialist uzakora muri iyo specialized care azakorana nande? Akeneye gukorana n'umunasi wize iyo anesthesia, ufite ubumenyi buhagije ku buryo dutanga iyo specialized care kuri quality ikenewe. Noneho ikindi tugomba kureba dutekereza ibyo byose, nuko tutagomba gukora ibyacu gusa ari context y'u Rwanda. Ibyo byose navuze ni context y'u Rwanda kuva dutangira program. Hako noneho na kandi irakenewe niyo tugomba kureba mbere yo kureba ahandi. None ariko ntabwo turimo turigisha umuntu uzakorana mu Rwanda gusa. Turimo turigisha n'umuntu ushobora kujya n'ahandi agakora cyangwa akiga. Tugomba rero ku benchmarkinga muri region na kwisi. Ikindi dukeneye ni standards. John yavuze cyane kuri quality. Professional standards zirakenewe. Noneho mu kureba standards tugomba no kugira definition neza isobanutse ya roles and responsibilities z'uwo muntu. Uwo muntu scope ya practice ye ibyo agomba gukora ni ibiki. Ko tumuvuze ngo ni specialiste azakora iki. Haje rero abaganga. Azakorana gute n'aba physicians. Bazakorana gute muri team. Kwanza aba anesthesist, aba doctors azakorana nabo gute. Ko niwo muntu wa mbere mugenzi we nibo baduhuje hano uyu munsi. Roles z'uwo muntu ufite masters n'uwo muganga biratandukanye he. Scope of practice biratandukanye he. Standards, professional standards ziradufasha kudefinisa ibyo bintu no ku benchmarkinga muri region tutareba gusa context yacu mu Rwanda. Ngiye nafasha kubaganga cyane nabonye na Dr. Gilles ari hano n'abandi abaganga nabo abanesthetist ni bake cyane. Ikaba no mu barimu ko turacyari muri training ni bake cyane. Abaganga ndavuga yuko cyane bo barana traininga banavura. Kandi no munasi uwo munasi anesthesist nawe turashaka yuko aziga gutyo akiga ari muri service kugira ngo skills tumushakaho zibe cyane clinical skills rather than kuba ari mu researcher ukuntu izindi masters wenda ziba zitewe bitangira mu research bitangira kuri masters bikazamuka kuri PhD. Ni bake cyane. So nabo tugomba gutekereza. Ese mu baganga bo dukeneye yuko mbere yuko wenda program yorahari yo gufama aba specialist. Ese dukeneye kuzana abandi bantu badufasha ntabyo tugomba kubyiga. Kubo amahirwe dufite nuko dufite program. Ntago bizakenerwa yuko bajya handi kugira ngo bagire ubumenyi buhagije. Ese abaganga numvise Dr. Vuga Rosa yuko bikenewe yuko muri recruitment y'abaganga baza kwiga anesthesia ari ikintu tugomba gukora. Ni igiki ku creating awareness se yabivuze. Yes, wenda abantu batinya anesthesia simbizi. Ari awareness ihagije twari twakora dufatanyije na HRH dufatanyije na association ndago mbizi. Ese turibaza kubera iki batinya kuza muri anesthesia bakajya muri surgery cyangwa mu yindi program. Nabyo tugomba kubyibaza. So agomba kuba needs assessment ihagije yo kumenya ibibazo dufite kubera iki abantu bataza kwiga anesthesia. Noneho niba tuzakenera kongera umubare w'abanyeshuri tufite ubushobozi navuze yuko tutafite abarimu bahagije. Nabyo bizagaragara muri iyo needs assessment ariko birakenewe kumenya bihagije uko tugomba kuzamura programme yacu. Kwigisha navuze ko abaganga cyane biga banakora ni in service program dufite. Kwigisha ikaba ari banani physician ntabwo ari kwigisha gusa twebwe infrastructure yacu turebe simulation lab n'ibiki. Ese hospitals zacu ziri tayari? Ese ko University y'u Rwanda ntabwo ariyo zareba ibyo bigomba dushobora gufatanya? Yes. Ese hospital zacu ziri tayari? Zifite ibikoresho bihagije? Nabyo tugomba kubireba muri needs assessment. Zifite abantu dufatanya nabo kwigisha? Abantu bacu abarimu bacu bose ntago bicara kuri college, ntago bafite offices, bicara muri hospitals. Ese hano bakorera unakumva abarimu bidoga bakora mu bitaro? Ese ahantu bakorera harahagije? Ese ahantu haba discussions ko twavuze ko ari kwigisha yo ahantu haba izo discussions igiye umunyeshuri atari ku murwayi hameze hate? Ese hari equipe? So capacity ya training ntago navuga yuko twarangiza kwiganira uyu munsi, ari byo tugomba gukora. Wenda bizaduhagurusa kindi gihe tukaza hano tukongera tukabiganira, ariko bikakenerwa yuko twega abayobozi tube duhari. Ndasaba yuko recommendations ziza kuva mu inama tuzigeza ku bayobozi bacu, kabara abayobozi ba kaminuza, abayobozi ba minisante, HRH, tukareba cyo gukora ko ntabwo twavuga quality workforce muri domaine zose zo kwigisha abaganga. Workforce irakenewe cyane kandi itangira muri training. Ntabwo ndina muri capacity building ya in service, iyo ngiyo niyo muri minisante, ariko igihe capacity building yo muri training idahagije, tutafite icyo tugikora, tugakomeza tuvuga ibibazo, dufite ibibazo by'abarimu, tugiye gutangira programme runaka, turakora iki, tukomeza. Igihe tutarebye muri training ibibazo bihari, capacity building itabaye prepared, itabaye well looked at, ikategurwa neza, ntabwo capacity building yo muri in service yakorwa neza. So nitwe tu producer, nitwe dutanga abantu, nitwe tugomba kugira abo barimo bahagije bigisha abo bantu, noneho hospitals zikaba zifite abantu bahagije, bafite n'ubumenyi buhagije, bafite ni skills zihagije ku buryo to deliveringa quality care ihagije. Tureba umurwayi nguje ufite ikibazo, ariko ugomba icyo kibazo kigomba kuba kirebwa n'abantu basangiye ubuganga. Ari ikintu bavuze ngomba kurangizaho, hano ari ikintu umuntu yavuze kireba wenda na psychology mu bibazo bagenda bahura nabyo. Ubu wenda ikintu umuntu yavuga, ureba uwo murwayi, wowe mu anesthesist, ura n'umu surgeon, ura n'umu munasi, ura n'undi, ikintu cya psychology kirakenewe apana gusa ku bantu bari in service, ariko natwe kigomba kuza muri training ku buryo dufasha abo twigisha bakamenya, cyane cyane muri anesthesia ndagira arimo bibazo. Nakomeje mbaza Professor Paulin kubera iki duhura n'ibibazo by'abanyeshuri bafite mental health problems muri anesthesia compared to other programs. So nacyo tugomba kugitekerezaho tukareba nibyo ntabwo ari nibyo nuko bimeze, tukareba kuntu duha imbaraga psychology cyangwa counseling muri training, ariko noneho tugafasha no mu bantu bari muri in service ku buryo twareba ku kintu cya counseling cyangwa psychology and knowledge. Cyaza muri pre-service training cyangwa muri in service, cyaza muri CPD ku buryo tusubiza ibyo bibazo. ikintu cya leadership na management nacyo turaza kukireba niba tudafite bihagije muri curriculum twabishiramo ko ntago muri gusa abaganga mu murangiza babaha ku managing hospital cyangwa cyangwa department birakenewe nabyo twabirebaho tukareba kuntu twakongera ubwo bumenyi muri curriculum yacu. Murakoze cyane.
So ndabizi ko principal yambwiye ngo ashobora kugira n'ikihe kibazo afite indi nama mbere yuko agenda ko ari inshinga ari task ariko tusaba bashaka nanjye mite nsubiza turebe niba ibyo ndi gusubiza bigiye muri line ya college kuko ngewe iyi nama nyifata nka high level meeting kandi ikintu CMHS yemeye inakanagia room ni kuvuga ngo izadefendwa neza kuri HRH niyo line tucyamo kugira ngo HRH twakire nayo. So cyambere ni kuri education ejo twagerageje kukalma abagenzi bacu kuvuga ngo nago twakomeza gusaba HRH kusupportinga medicine kandi tukabarekera umutwaro wo kurekrita nanone hanze abantu bako traininga NPS byaba ari kwikunda. Difference yo ku traininga umuganga mu resident no ku traininga muri NPA nayo mbona niba nshobora ku traininga mu resident myaki abe anesthesiologist simbona icyo tubuze nk'abaganga ba anesthesist ku traininga mu NPA kumugira bachelor of anesthesia cyangwa masters of anesthesia keretse avuti kindi iyindi kada ya anesthesia yavuga ngo twebwe nago twa traininga n'abaganga ko ibyacu biratandukanye n'ibyanyu aho nitubimenya tumenya ko nago twese turi mu kinya kimwe ariko niba turi mu kinya kimwe tutanga ku murwayi umwe ari nurse anesthetist undi akaba anesthesiologist ikinya tutanga niba ari kimwe gishobora gutandukana ama level ni kuvuga ngo umuntu ugeze kuri level yo hejuru ya traininga undi muri level yo hasi niga kugira license A B C D umuntu ugeze kutwara kiya kikamyo kinini cyane ntago yabura ku traininga umuntu uri ku gari cyangwa kuri moto wenda moto ariko kuri voiture ntago byamunanira kuko mbere kugera kuri kamyo wabanje kucya kuri A voiture ingi bisi n'ibiki. So kwebwe mu izina rya RSA twabwiye HRH yuko ntago tushaka ku debriya tu traininga mu kwidebriya mutwemerere fellowship abo ba fellow muzarekrita bazahita bajya muri courses niyo ku traininga n'aba resident n'aba LPS ntago byaba ari incentive y'ayandi mafaranga mubongerera kugira ngo babe barimo izaba mu barekrita ngaba fellow n'ubundi bagiye kwiga niba ari pediatric niba ari obstetric anesthesia niba ari local regional muri mission yo kuba fellow arimo na mission ya education niyo mpamvu fellowship zacu zifite component ya E kuri à la fin tuyita police, P pediatric, O obstetric, L local regional, I ICU, C cardiothoracic, E education. Umuntu fellow wose uzakora fellowship mu Rwanda azaba ari trained kuba educator. So nikuvuga ngo mugiye ari no gufata course yo kuba educator azaba ari umuntu wigisha afite mandatory agomba kwigisha. Muri charge ziwe John azamwigisha kwigisha ajye kwigisha NPS kuko ibintu bigisha ariya ntago byamunanira niba atanga ikinya nk'umuganga. So we can assure you yuko capacity building abari bazigisha ba NPA kuri bachelor no kuri masters bari mu rugaga rwa RSA bazaba bafite mandate yo kwigisha iri well aligned HRH mandate zaba nk'aba fellow. Natwe abaganga dusanzwe tuhari bisaba yuko college definisa ukuntu ushobora muri workload yawe arimo no kusimbuka le mur ya school of medicine no kujya kuyindi mur so tukabikora ni ikintu tukunda kuganira muri workload no kwikalkira bera tunaniye rimwe na rimwe kubera kunanirwa kumenya workload igenda gute. So icyo ni cyambere. So kirahari ntabwo tuzasaba yuko mwishura amafaranga kuzana umunya Sudan cyangwa umunya Ethiopia
keretse amafaranga ahari menshi wenda Shema indemajezo y'amafaranga arashaka kuyatanga nta kibazo ntabwo twamubuza ariko turahari. Icyo ni cyambere. Sinzi niba iyo ndi kuvuga RSA yavuga ngo no, Françoise wavuga ngo no ko iyo na Gilles arahari niwe auditeur wa nani yacu, so araturebera kandi iyo ndi kuvuga ndi kuvuga mu izina rya RSA. So ngirango nicyo kikomeye muri education wamavuze, kandi insurance yacu irahari yo kwigisha, kandi iyo program ya masters yes yejo ari ibyo yatubwiye turi kumwe na Etienne, kandi tubigarutseho nawe urabivuga. Masters ishobora kwemerwa ariko igendereye kuri needs z'igihugu. Ni kuvuga ngo ntago mu training aba masters 30 cyarimo arimo implication ya salary n'ibiki yatusabye, aravuga ngo murebe need abo muza traininga na aba trainer, mufata abantu bari knowledgeable, capable to be trainers, nibo bazatangiza masters, babe trained, equipped as trainers, bazabe basustaininga iyo program for the future. So iyo turakemeranyije ntabwo tuzatangira abantu benshi cyane, ni bakeya beza bazaba barimu, bazaba program coordinator b'iyo program iri shasha mu Rwanda. So niba kira tukemeranyije na RSA ikatanga commitment yayo, ndumva nta mpungenge tuwagira yo gutangiza iyi program.
Urakoze Professor Paulin. Mfite ikibazo kuri Mugarura. Harya NPA department ya NPAs iri under medical school?
Urashaka oya cyangwa yego cyangwa
oya cyangwa yego
cyangwa nongereho?
Oya nako konyine nje kubaza gusa hanyuma then we can continue.
Oya nyemerera na nongereho.
Please continue.
Ni oya, ariko nagira ngo what matters most is not the house or the room where people sleep. Ntabwo department ni inzu, ishobora kuba house tahariho hose, ariko ngi gitekerezo nakifuza gutanga nuko tureba aho dushaka kujya, hanyuma noneho nyuma tukareba how we are going to get there. Ngiye nagatanze igitekerezo cyo kutwita cyane kuri interprofessional collaboration. Ibyo paravuga nibyo, bafite skills, ni byiza ko bofarinze their hand to train, ariko nge ntabwo najya inama yuko duteramo umusimari. Of course ntabwo nta bandi bazabigisha batari mwebwe, ariko nimureke program ibe designed tureba abakenewe abaribo. Wowe uri muri core group y'abazabigisha, ashobora gusanga ari wowe gusa cyangwa hari nundi. So ngewe nakagiye inama yuko tubifata tubakiriza amaboko yombi nk'abagiye kuzacontributinga, ariko ntiduteremo umusimari. Wenda ushobora kuvuga bati muzazane na engineer hari icyo azatanga, muzazane na n'umuntu wigisha gucuruza nawe hari icyo azatanga, ariko icyumvikana cyo muri core resource. Nge nicyo navuga.
Reka ngire cyo nongera. Urakoze. Murakoze. Ari kintu navuze, ikintu cyo ku defining roles and responsibilities of the profession. Yego ibyo Paul avuze ni byiza, kandi wenda kintu navuze nuko kuva program itangire y'abanani physician nuko abaganga bagizemo uruhare rukomeye. Navuga abaganga ba anesthesist rukomeye, nibo bigishanaga na bakeya bavaga hanze. Abanani physician twashoboye kuba dufite n'abandi bagiye barangiza babafatanga batitora assistant. Ariko ikintu cyo kuvuga ngo ngewe ibyo ngora ni ibi ngibi, responsibility zanjye nibi nisi kirakenewe. So niba muri masters yongeye abanani physician bizagaragara yuko skills zose zizatanga, competences zose zizatanga, roles na responsibilities zabo bantu sinzi niba zizajya zisa n'abaganga. Ndagira ngo oya ntago bisa. Uwo ngo azaba afite ibyo akora, niyo azaba afite ikora mu byo akora, azaba akeneye abandi bantu bamwigisha batari gusa abaganga. So nicyo gituma navuze
tugize abantu bacu bari muri training ubu ngubu bagenda bakiga, nibaza yuko iyo masters tutazayitangira ngo nitobe ba mbere tuyitangira ku isi cyangwa muri ryo irahari. Mu kuganira n'aba Dr. Etienne n'abandi n'abagenzi be baravuga ko ihari, kandi navuze yuko ukenewe kubera turimo turagenda turazamura kuva nyine tuba imbaraga cyane muri tertiary care, muri specialized care. So nicyo nakongeraho kucyo John yavuze.
Murakoze.
Ariko gutangira program nejo twakwicara tukarangiza program. Murakoze.
Thank you. Hari ikibazo bavuze cy'abanyeshuri bakeya bo muri medicine biga anesthesia. Nakiteguye mbanza kubaza ngo ese muri mwebwe hari umwarimu mwigeze mubona arabinsipira ku buryo muri iyi minsi mubaho nk'uko yababagaho mu rwego rw'imikorere cyangwa rwo kwigisha? Arahari? Aba hari, ça c'est sûr. Nk'igifaransa mvuga accent na intonation na geste zikura kuri dogiteri. Nakura kuravuga igifaransa mumva nagira accent nk'iyi. Uzumva niyavuga ikinyarwanda nkumva mvuze nkawe byabarishe. Kuki abanyeshuri bataza muri anesthesia batiyandikisha muri programme anesthesiologist? Aho niba batinya imibereho y'abagenzi babo, abaganga babayeho neza muri anesthesia. Noneho aba bareberaho batavuga ati ejo nababwiye umuntu waje kwiyandikisha muri chirurgie yabona muganga chirurgie mukuru muri akaryama ku ntebe agatendeka amaguru ategereje indi case hari muri CH. Umuhungu arabireba twicaranye hari ubu ngubu ngo ndiga ngo nzabere nkuri apo bivuye. Abaganga babayeho neza. Aho nyine bari source ya motivation. Icyo ni ikibazo cyo kwibaza. Hakorwa iki kugira ngo baze? Nta kisubizo mfite. Ubwo medical school izareba ukuntu bigenze. Cyangwa se na minisante. Hashobora kuba ari factor iba demotiva. Wenda bona bakuru babo batabayeho neza. Birashoboka. Hari ikindi kibazo abaganga ejo bavuze, bavuga yuko babakoresha babahoza ku kazi ntibatuma bajya kwiga. Yanabisubiyemo. Sibyo? Ibyo bizakemurwa muri departement. Kuki babakoresha gutya? Ariko twebwe shaho reka mubwiye. Umuntu bamuserivye amata, umwana ukunda kuyemo cyane aravuga ati tubateye amata atangiye gushara nge ntabwo nyama. Hanyuma umwana utabona n'amake abona bayasubije ati ngewe ndayamo kugira ngo wabone yatwaye agira attention yagarure wa wundi bashaka yinywere. Uzi ukuntu twifuza abantu bacu ko bafata bakaba mu imbere bakiga by doing.
Ariko byanaterwa
twebwe turakompreninga ngo exposure ntabwo ihagije. Ariko ntimunyumve nabi, ntabwo nshyigikiye ko ababigisha babiba igihe cyo kubaha teori kuko niba cyarateganyijwe bagombye kubarekura. Ubwo si cyo cyakemurwa nani? Ntabwo ari pole kana ngo si ubohereza, ntabwo ari chef department. Ubwo ibyo nibikorwa no mu bitaro. Bana mu bitaro mujye mubabarira abanyeshuri bagiye kwiga. Ngo bakuvura abarwayi. Kizakemurwa na system. Icyo mvanye mu byo twumvise kugeza ubu nuko capacity building ntago ari umuntu ntago ari institution imwe yayikora. Ni twese hamwe. Ntabwo nzi icyo muvana imwonye ziga ko uyu munsi, ariko hari gihe ari medical director ugiye kubona ko abanyeshuri b'igihugu bose baje mu bitari wawe hari guhakurikiraho. Muzi uko bigenda, twandika amabaruwa bakadutuma kuzana ibikoresho bakanabirukana ngo ni benshi. Hari ibyo Mugarura yavuze ngo basiyuminga ko ibitaro byose biri mu Rwanda ari ibya kaminuza, kandi si byo. Hari ibyo ugomba kuzuza kugira ngo ujyemo, harimo no kuzana ibikoresho. Njya nibaza hari igihe twese ntabwo turi aba minisantera, siko bimeze. budget y'ibikoresho tumwa kaminuza mwagiye muyishyira mu bitaro abanyeshuri bakayisangayo. Ibyo bintu byashoboka ngo ntabwo yazanye iki n'iki bati subirayo. Ubwo HOD yabagize ingorane araza akabati ndabigenza ase ninjye watinze kubya hakiri kare ese akaza ubwo akajya kwa dini akavuga ati pfuyi kavuyo kabi wanyu. Ubwo baba biyaranje kubitagira kwa principal uko kiba icyaha gikomeye. Ni ukuri twe donc capacity building nta muntu wayikora wenyine, turakereranye twebwe. Iyo budget mwashatse ukuntu muyijyana ikajya mu bitaro abanyeshuri bakayisangayo hanyuma icyo kintu kigakemuka. Ndashimira ibitaro ko bisaba kuko amahoro wawe uko ubonetse wese ashobora kuzikinga mu kiza akaza yita umunyeshuri akicara mu kumva kuziba. Ni byiza ko baza berekana ko gukora abanyeshuri amahoro yo ni ngombwa, ariko ibikoresho ndishara mu biranya mu ukase mu kabya none turi uzi kugira ngo uzagure gazo kujyana mu bitaro binyura muri tende. Iyo ukerewe itariki imwe abanyeshuri ntabwo bazajya bureme kagaruka muri department. Capacity building rero ni iyacu twese turakeneranye kugira ngo ibyo bintu it's a process. Abantu nabajije ikibazo ni ese usubiye mu ishuri urumva wakwiga iki cyangwa hari inshingano wagwa ukabona utarazize. Ikivuyemo nuko ni byinshi abantu baba bategerejweho kandi bitari covered muri za program. Hari bishobora kuba integre muri za program ariko byose ntibyajyamo. Bishatse kuvuga ko ama association tubamo dukwiye guhozaho dukora refresher courses cyangwa CPDs. Ibyo ntabwo kaminuza yakwicara ngo ibikore yonyine, ntabwo yabishobora. Hanyuma uruhare rwa minisante ni uruhe? Ubwo ni ukugidufasha nyine, ariko CPDs ntizikabere muri hoteli namwe murabyumva gusa mwebwe ni mu byumva. Burakira cyayi uteke iwanyu kikaba kiguze nk'amafaranga nka 500, urabura dushobora kuba turi mu kimura bitanu. CPD niramuka ibaye muri abantu badaheze ariko zihorewe. Nakibaje nzi neza ko barimo bategeka kuba managers. Muzi ikintu guho kukoze kote muri mwe hari abantu bajye bakote abakoze umwaka ushize mubona ingorane zizamo. Mubona ingorane ziza mu gukota umukozi ko mu praising kubera ko ntabigeze bikwigisha. Uricara ukavuga uti kira givono tunushize cyandebye nabi wagira zero gaho ukavuga uti urari inshuti yanjye reka tumureka agende. Urazira iki? Urazira wowe ubwawe kubyo ntabigeze bikubwira n'inkurikizi bifite. Hanyuma nta nubwo uzi ko gukota umukozi nabi hari inkurikizi bigira kuri we nawe zakugera mutsa kuri zakerekana ko ibyo ubeshyira ari ibinyoma nta byigeze bibaho. Ibyo rero birakenewe. Abantu biga masters bose bagombye kujya bongeramo isomo rijyanye na management na leadership. Iyi nama ntago ari yo guciteka niko ntekereza. Iyi nama niyo kujya inama tukareba ibipfa n'ibikira hanyuma dufatanyije tukazareba uburyo twa contributing to capacity building from all corners of our professions. Nubwo ari twe twenyine bigira no ku bandi bose. Anesthetist wateye ikinyanabi, he is accountable to the patient, to the surgeon, to the hospital in general. The same applies to gynecologist cyangwa se ni surgeon. Utwumva concern dufite akakubwira ati byanga bikunda hari ugeze kuvuga ngo warabwe mu nazira zo barwa ibisare ngo hanyuma ubwo makosa na yandi ntabwo nzi nyira amakosa nta nubwo se mu gucurwa ariko biragoye kuvuga ngo nyira amakosa none neza ati genera bivuze ko umurwayi yaragiye gupfa ati twebwe twari twatangiye amabwiriza avuga ngo ayo mabwiriza agomba kugaruka muri standard twabuze tuvuga ariko ntabwo ari za kaminuza. Kaminuza ifite ingaruka. Nubwo turimo dukora ni byiza cyane gukora nta muntu ushobora guhagarara wenyine. Standards of care zigomba kuba zituruka muri buri profession bakazisharinga n'abandi kugira ngo bazumvikane. Nta profession ishobora guhagarara indi. Nubwo dufite aho duhurira ibibazo ntabwo ari muto. gusa dufite aho duhurira nk'aho umupadiri n'umunyapolitiki umwe mubwira ati ushaka kukivanga muri politiki undi atari ko mwebwe ko murwana n'ibitekerezo by'abantu ntimuzi ko ari twebwe tumenye aho bituruka dufite aho duhurira ni ku kintu cyitwa umurwayi kandi twese niwe dukorera mbere yo kwireba kureba inyungu z'umurwayi. What do you think about the time? Yes, the time. uretse gato ndashaka kubaza, with the due respect, do you allow some questions?
Yeah. Why not?
How many?
It's you who are moderating, so
Let's
you're the one to
take
decide
5 questions.
the time
Only
you have.
5. Time is up. Please formulate, pinning it to the point. Don't tell sorry. To make sure that we are using time efficient.
murakoze cyane. Nitwa Godfrey Ngabonziza, ngize umugisha ukomeye wo kuba mbonye ahantu hari principal. Nashatse no kumusanga muri office ze kuko ikibazo mfite nkimaranye igihe. Ndi umunyeshuri urangije muri bridging program. Mfite ndeka ntsa ku ntego kuko ngiye muri background byatinda. Mfite ikibazo kirebana na bridging program iri muri kahashi, I mean muri UR. Harimo ikibazo gikomeye kubera yuko kirajyanye n'iyi capacity building ariko in terms of service ariko no mu ishuri bitagenze gakeya. Ikibazo cya mbere kirimo ni ikibazo cy'abarimu. Kirimo gikomeye. Nshimye Professor Banguti kuko yemeye ko wenda bazajya batanga contribution, ariko harimo ikibazo gikomeye kidindiza iyo programme ku buryo mushobora no kumara igihe mutiga kubera ko mutari mwabona abarimu. Department kabirimo ishakisha ivuga ngo bategereje abarimu. Icyo ni ikibazo gikomeye. Ikindi kibazo kirimo gikomeye ni ikibazo cy'uburyo batekingwa care mu bitaro. Bano bantu iyo twebwe twiga batubwira yuko ubundi aba doctors anesthesiologists aribo bakagombye kudutekinga care turi mu mastage, ariko iyo ugezeyo aba anesthesiologists muhura muri evaluation. Ibyo niyo mbivuga, bambabarire wenda nabo barahari. Keretse iyo ugize imana ukabona umwanestesiologist w'inshuti yawe ukamubaza ibibazo cyangwa ukamubwira uti wamfashije kuri utu tuntu, aragufasha. Ariko ikindi gihe nabo bafite aba resident bataboroheye barimo kwitaho. Ikindi kibazo mfite ni ikijyanye na capacity building mu bijyanye na in terms of services. Biratangaje kandi birababaje kubona aba resident bahabwa scholarship kugira ngo bajye gukora resident muri anesthesia, hanyuma aba NPA bashatse gukora bridging bikaba ngombwa ko biyishyurira. Ubu ngubu tuvugana iyi program igeze kuri miliyoni 3. Zino miliyoni 3 umu NPA kugira ngo azishyure arasabwa nibura gusevinga 125 ku kwezi kugira ngo azishyure iyo program. Iyo urebye amafaranga hembwa ni 174 barahari hano abantu muri Minisante. Iyo PBF tabonetse reka wenda tuvuge roughly ko babona 200 cyangwa 220 cyangwa 190. Urambwira ko uyu muntu azafata 125 akajya kwiga agatungwa n'ibihumbi 70 ingahe bizasigara? Reka tuvuge yuko noneho wenda bizamutunga. Noneho ikintu gitangaje nuko aba NPA bakoze bridging batari regularize ahantu barimo gukorera. None murimo kumbwira ngo murimo gushaka abantu ba NPA. Ejo twabonye presentation ya head of department muri anesthesia. Abantu bamaze guta ikinya ni benshi. Ni benshi barajya muri 70 na bangahe n'umunani. Mu mibare twabonye hariya hari abandi 260 na batari bagaruka gukora iyo bridging. None se niba abantu bari aho ngaho bari muri izo quartier muri district z'ikinyatuzi akaba ariho in terms of services cyangwa capacity ya building muri services nta mafaranga abona, urambwira yuko yashishikariza ate umunyeshuri urangije PCB cyangwa MBC ngo najye kwiga anesthesia? Niba mushaka yuko ibintu bigenda neza mushyiremo ibintu bimwe bifacilitating abantu, mushyiraho scholarship z'abantu bakora wenda tuvuge bridging. ndabizi ko wenda yo ari tabikemura ariko minisante ahangaha kandi birababaje rwose njye ndabavugira kuko abenshi nk'ubu twatangiye porogaramu turi 20 na barindwi abantu bagombaga gutangira ariko twarangije turi 10 kubera iki abantu nta capacity bafite yo kwiyishyurira. Murakoze.
Arakoze cyane umuyobozi wa gahunda na principal. Ikibazo cyanjye kirakurikirana n'iki kuko birenda gusa mu mateka dufite ya anesthesia NPA ngira ngo programu yagiye yabanje ya advanced diploma yari ifite ahantu limiting abantu badafite barenga, haza kubaho initiative cyangwa se habaho gutekereza gushyiraho bridging kugira ngo abantu nibura babone niveau ya A0. Uyu munsi nako ejo tuganira twavugaga ko iyo program dukwiye nako kureba uburyo yaba revised noneho abantu bagatangira kwiga nursing donc bakarangiza ari aba nurse anesthetist, ariko nanone tutaremeza yuko bishobora kugera kuri level ya masters, kabo ngo bagarukira kuri niveau ya A0, then abashobora gukora niveau ya masters bakaba ari abantu bo kujya muri education kwigisha. Shema ejo bundi watubwiye ko mu bibazo mwagiye mujya cyangwa se byabayeho kera porogaramu zose gahunda zose zarebaga doctors uburyo bazevura bakazamuka mu bushorishoro ahantu hose hashoboka. Kuki twebwe tuba limited? Iyo porogaramu ya masters kuki muyirimita hano? Uyu muntu wize bridging akaba ari umu A0 nihe handi hantu afite ashobora gusohokera nka UR niki muteganya abo bantu bazasohokera cyangwa baraho bari kwense ku buryo badashobora kugira handi binyagamburira? Ntabwo twiga kugira ngo tuzakorere mu Rwanda gusa. Niba mu Rwanda mbuze umurimo cyangwa se badafite amafaranga wenda yo kuduhemba, umuntu ari open kujya handi hantu ariho hose, ariko mwiturimita mu buryo bwo kwiga. Ikindi cya kabiri, hari ikintu Dr. Paul avuze mu kanya ngo barifuza ko muri fellowship zitangwa hari ya ntuzi yavuze ngo ya police. Ibyo bintu byose birantunguye kubona nka RSA mwumva mushobora gushakira iyo career pathway abo ba anesthesiologists, byagira no kujya muri departement yaya baba NPA bigagamo mukumva nawe mukwiye kuyabsorba ikaza muri ntuza yanyu. Nizibe departement ziri parallele mutange y'umusada wanyu nkuko mugarura yabivuze. Niba dushobora nitubona hari hakenewe aba engineers baze bigishe, ariko uko anesthesiologist mufite inzira yo kuzamuka natwe ni mu inzira yo kuzamuka. Murakoze.
Thank you. Mfite ibibazo bibiri kugira ngo biraza kuza no koroha ku bibazo. Maze umwaka ndangije ariko nakoze uburyo ntekereza ku kibazo nsereko yavugaga nsubiye inyuma nahindura iki. Muri training nagize na bamayemo inshingano zo kuba academics in charge. So confrontation that I had n'aba consultants, hari abiyumva yuko ari clinicians abandi bakiyumva yuko ari academicians, yet teaching hospital yitwa ko ari ya kaminuza. So when I take grace ndumu academic hanyuma ninjoro kubera ko ndumu clinician, she will assume my responsibilities. Ndashaka yuko byitwa kaminuza, ikigo cya kaminuza abakoramo bose bakitwa academicians, and then quality end products ikaza iri high quality empowered, ukamenya n'ibintu bikwiriye yuko wabimenya. Cyo ni cyambere. Cya kabiri, I had an opportunity to get out of this country, more rotations outside of the country. Nabonye the examining board ibitandukanye n'uwigishije. Is there a way we can just make a very private board yo kugibaza ibyo twigishije? In that matter, kaminuza sehashika sehashibe bakajya bigisha bazi yuko atari bo bazabaza. And then at the end of the day, bya bindi bavugaga ngo ni product simbi ngo byaciye mu kayunguruzo n'ibitarakiyemo bigasigara. Wenda Prof Nkusarabizi yaciye aho babagira board zihariye, Foundation yarabibonye. They have different board babaza ibibazo biri on standard ku buryo arikadi uzagipasinga azajya gukora practice. Icya gatatu, nkitekereza kuri bya bindi bavuze ngo ngarutse nahindura iki, hari curriculum ucamo, at the end of the day you are the end of product, ariko wajya ku isoko hanze ugasanga ibyo ubazwa gukora ntibigeze kuri rwa rugero rukwiriye, atari uko abakwigishije batabyigishije ahubwo kubera curriculum. Hanyuma nifuzaga yuko if there is a way curriculums zaba revised zikaba adapted ku buryo NPA wabaye trained hano azajya gukora South Africa akaba competent, nawe bakamwishyura ibyo bifaranga byinshi akubaka umuryango n'igihugu. Murakoze.
Reka tugerageze gushyiramo ibibazo bye neza kugira ngo babone uko babone umuti. Hari abantu bari mu bitaro bigisha n'abatigisha.
They assume themselves we are clinicians.
Okay. Donc ibyo birahari.
Hanyuma academician yaza yaza. So they are run this.
Donc urashaka kuvuga ko abitwa clinician bigisha. No hanyuma urifuza yuko bose bahabwa inshingano zimwe bakigisha. Hanyuma ikindi wari wavuze ni uko curriculum zagezwa kuri standard. Tukirefere ku yihe?
In fact, they are
Okay. Twari twavuze bitanu. Kimwe, bibiri, bitatu dusigaje bibiri. Niba ntabyo
murakoze. Ndifuza ko tuhuza ibintu bya capacity building na za strategie ya retention ya staff, kubera ko turavuga kongera umubare ariko ari n'abenshi bagenda, tugomba kureba ukuntu tabihuza. Nashaka kuvuga ko tugomba kuhuza strategie ya capacity building yaba kuri quality yaba kuri number of staff na za strategie ya retention, kubera ko ari benshi bagenda.
So mbere yuko basubiza ndashaka ko clarify position ya RSA. We are not in the position to look for job. Iki kintu kibe clair, RSA ntabwo iri gushaka akazi ngo bayiye indi departement, kinzi niba departement academic niyo bari kuvuga, ariko na ngira ngo akazi dufite deja nka departement academic under the School of Medicine akazi kabaye kenshi, looking for a new job kutongera yindi workload, kuko deja iyo dufite ni nini cyane, hari igihe itunanira tukanabura gutanga amanota n'ibiki n'ibiki. It's a lot. Nako turi kushaka indi program under our department. We are just feeling like ari abantu dushobora kufasha kwigisha bari ku yindi school, kandi HRH iri gushaka abandi bantu bo hanze. Ejo nawe uriya munyakanada turaganiriye yes nawe arashaka gufasha school yacu n'iyindi, ashobora kuba hari n'abandi hanze bari gushaka akazi muri School of Health Sciences. So ndiyo ndababwira niba amafaranga ahari yo ku ayaringa abanya Ethiopia, abanya Kenya no kuza kwigisha under the school, yes and well, and it's very well. Niba amafaranga ahari yo gufata abanyarwanda bashoboye kubajyana muri Ethiopia kwiga, that is good. Ayo mafaranga bayakoreshe bagende. Ntabwo turi kubloka abantu ngo niba bajyane hanze twebwe turafata iyo mandate mu mafaranga. Oya, ntabwo ari cyo turi gusaba. Ntabwo turi gusaba amafaranga, ndisho gushaka akazi. Turi kuvuga gusa niba program itangiye kandi baratwemerera yuko we can give something to the program, we are well trained to do that. Arigiye mura n'umurezida w'umunyamerika waje na VNO volunteers ngo yaje n'umurezida w'umunyamerika yaje kwigisha. Ndamureba n'umurezida w'umunyamerika ngo yaje volunteer kwigisha muri School of Health Sciences. Kandi mbanzi ko Rudakimwa ariya Jackson ariya bashobora kwigisha ibi ari kwigisha. Ndavuga niba amafaranga hari mu Rwanda reka tuyaye abanyamahanga, ariko twebe ni mutukenera we are there. Niba batukenera we have a lot to do. Do icyo nicyo nashate clarify as RSA ntabwo turi gushaka akazi.
Kuri icyo ngicyo programu ntirabaho. Hanyuma nitangira tuzareba uzi ntabwo il n'y a pas de bonne réponse à une question mal formulée. Ushaka guformula question then tugashaka réponse. Ntabwo duhera kuri réponse ngo tujye guformula question. There is no right answer to the wrong question. The better is just to start with the asking good question, expect to get different type of answers. The best one will be niyo approach numva yafasha n'ubundi musanzwe mutwigishiriza rega n'abakunda dusharinga the same values gusa nuko twumva uwo mwana yabavutse atari sefarika ari siege bikaza kwangiza mama. Reka dukoreshe uburyo bwiza bwo guhera ku kibazo tukaza gushaka igisubizo. Hanyuma ibisubizo ibibazo mwabajije bagiye kubibaha bahera ibisubizo bya
reka ngerageze. Kibazo cya mbere ndi kumwe na Dean na HOD baramfasha. Ajya amazina yawe ntago Godfrey umuryango wanjye ukinguye buri gihe sinzi ko biri kutaje. Telefone yanjye iba on ntago rwose wamamagaye cyangwa kwa gashaka ko tubonana ukambura. Okay, nabivuze ko dufite ibibazo by'abarimu muri programme zombi NPS na PS ko muri kubyita dufite ibibazo by'abarimu. Ibyo ntabwo nabihakanye, ariko HOD na Dean bari hano. Umwarimu wose bashaka cyane cyane n'abaganga kubera abandi ntabwo dufite bahagije mu gihugu. Wese bashaka aho turuka hose kontra ntabwo imara umunsi umwe. HOD ndabesha, Dean ndabesha, ntabwo imara umunsi umwe muri ofisi yanjye ndayisinya kugira ngo mwige. Kandi nakosi mutize ndabesha amakosi zozo wenda mutubabarire arigiye wenda mutinda cyumweru kimwe cyangwa tushakisha, ariko byose biri muri curriculum mwarabyize, right? Good. So niki navuze mvuga ngo tuhe amashi turagerageza. Despite the challenges kuva dutangira programme rwose turagerageza, na nicyo gituma aho mukora neza. Sibyo? Nabo baba muri Amerika twasinyanye amasezerano baraza nyine tukomeza tushakisha strategies uburyo buhagije kugira ngo tukomeze utanga service nziza ku barwayi bacu dutangirira muri training. Okay, so scholarship yo na notinze urakoze. University y'u Rwanda ntabwo itanga scholarship gusa, dukora ubuvugizi, tugasaba heke uwecharechi nabo turafatanyije mu advocacy tugenda dukora hirya no hino. Ibyo nanotinze ntabwo nabonye ubusaba bwanyu ngo burashaka scholarship, ntabwo ndabona mwandika. Ari porogaramu imwe y'iwacu midwifery barasabye nayo ni bridging, twabagiriye ubuvugizi twegera heke, ari cohort ndagira y'umwaka ushize babonye scholarship. So namwe muri abana b'Abanyarwanda amashyi ndayakira, ariko ntabwo we nazayakira neza nyuma bikozwe. Gusa mumfashije school ikabafasha tukandika tukabisaba, numva batumva dufatanyije na HRH she muri hano uzadufashamo. Okay, ikintu cya regulations advocacy nabivuzeho, HRH rwose turi kumwe. Okay, noneho ikintu wavuze na Alex agikomozaho ni programme yaba NPS, wenda hajemo nursing. Alex, dutangira wenda Etienne yamfasha, dutangira twifuza yuko tugira skills za nursing muri programme, tushaka yuko dutangira bachelor degree ifite izo skills, twegereye council ya nursing ko twagomba ku making sure abarangiza baba registered muri council ya nursing, habayeho resistance. Okay, so niyo gituma twafashe turavuga ngo reka tukore programme tugire skills za nursing, mwaka w'imyaka 2 inyini imyaka 2 ibe complètement anesthesia. Okay, so ariko nizeye yuko biganiro bizakomeza, none muri programme masters nibikunda tukayikora neza, none tukasaba yuko baba registered muri council, ko mugomba kurangiza mubarizwa ahantu muri association, ariko council irakeneye cyane gukora ibintu bya regulations za profession, birakenewe. Ntabwo dushobora gutangira tukadesida twe twenyine, tuba dufite ibitekerezo, tuba dufite ibyo twifuza, ariko tugomba gufatanya n'abandi. Ndagira ngo nicyo navuga, gusa turi kumwe kandi ari byinshi tuzageraho na HRH na Minisante. Niyo career path wavuze nayo nicyo gituma turatekereza iyo masters nabyo turabitekereza. Nizeye ko nashubije ku kibazo cyane. Doctor, rwose ndagushima, ibyo wavuze nibyo na nibyo turatekereza na HRH, kureba ukuntu aba clinicians baba over turavuga ngo teaching hospital, gusa ibyo wavuze nibyo, kandi ndagushima cyane yuko ari igitekerezo cyiza. Ari byo HRH kirimo rakora ku buryo abantu bose bari mu bitaro, aba clinicians baba abacademicians tukaba umuntu umwe, gusa governance yabyo framework out ndabona pandego yarimo aragira yego governance yabyo framework uko tuzakora ibyo bigomba gusobanuka neza. Nanagushima yuko wowe warabyumvise yuko ari byo ugomba kwigisha abanyeshuri baza bakugana ko ni teaching hospital, iratandukanye n'izi hospitals. Ugomba kuba uri umwarimu ugatanga ibyo nabyo nawe ufite, ukaba na proud yuko wigishije abanyeshuri. Murakoze. Board of examination yego, ahandi nabyo ni ibintu tugomba gutekerezaho na associations na councils, yuko tugira board of examination itari gusa council irebera ikintu bita exams za professions igihe mugiye gukora umuganga, no igihe mugiye kugira license, ibyo birakenewe. Dr. Jules yavuze ikintu cyiza, turavuga capacity building. Nose kubera iki tukomeza tu building capacity? Abase babo twa buildinze kuva kera. Ni iki dukora? Retention, motivation yabo bantu irakenewe. HRH turi kumwe mu iki kibazo, ni ukureba ukuntu twakomeza tugira advocacy, tukomeza ko iyo wenda twe twenyine ko turi government entity, ntago twaba tudesida tugomba kuganira na ministries zacu ku buryo tukizamura ukuntu retention ega retention ntabwo ari gusa y'abantu y'aba healthcare provider abarimu ubu dufite icyo kibazo cy'abarimu muri universite no mu zindi domaine yuko abarimu bagenda baducika bakajya ahandi ko nta strategy ya retention dufite igize isobanutse akazamo motivation ntabwo ari amafaranga yonyine harimo ibintu byinshi muri motivation ifasha muri retention y'abantu dukeneye turanakeneye yuko nyine ntabwo twakomeza tuvuga ngo tuzazana aba experts turazana aba expatriates Paul yabikomejeho ariko usanga nta n'ikintu baturushije cyane dukeneye abantu bacu tubake healthcare yacu ari twe twenyine twishatsemo ibisubizo murakoze cyane.
Thank you for the audience. Thank you for our officials who, despite their heavy agenda, got time for us. Thank you. We appreciate. Yeah, it's time for lunch. If you have a time, you can stay with us.
Merci.
Okay.
Merci beaucoup.
You are excused. You are excused.
Thank you so much. Yeah, I'm feeling a guilt.
Okay. Arakoze Dr. Etienne. Turashimira panelist bemeye kubana natwe n'abagikomeje kubana natwe kandi turizera yuko ibyo tuganiriye n'ibyo batugejejeho hari icyo biza gucontributinga kuri safety of anesthesia in Rwanda. Hanyuma abari muri protocole badufasha ko ni time for lunch hari rujeto zo kujya muri restaurant down there bazitanga ku bantu kugira ngo tuze kujya tumerewe neza. Ariko nsubiza kanya profitable.
So please keep in mind there is another very important panel afternoon. Teamwork, task sharing. So task sharing ntabwo ari muri anesthesia gusa, anesthesiologists na NPS ndabizi ko no muri surgery ari giba babaza ibibazo ese agakazi muzakashobora mwenyine ko muri Tanzania turi kureba clinical officers ntabwo turi kuvuga ngo tugikwizana ni kumva gusa spirit ya surgeons mu Rwanda ko turi kumva clinical officers muri Tanzania ese mwebo murateganya gute aba surgeon 200 muzabageraho cyangwa muzashira mu yindi kada wenda muri gyneco the same ese aba obstetricians sinzi ni 1,000 by 2030 muzabageraho cyangwa muzifasha aba GP muzifasha medical officers. So your task sharing turashaka kwiganira mu buryo za privilege ziri kuza za credential wenda bishobora nabyo kwinjiramo gakeya turashaka twese tuyiganire open kugira ngo tuve hano tufite ideas tuna feeding a minister of health ideas for the next ministerial order iribuze for privilege and credentials. Then evening harimo cocktail. So please don't after this work we are doing, don't leave your cocktail behind. Please wait until evening with us for the cocktail.
Thank you very much. Ndumva session ya mu gitondo irarangiye nubwo twageze afternoon. Twagira ngo tujye kuri lunch. Turagaruka hano at 2 p.m. turaza guhita dukomeza n'indi wenda twarengeje minota 40 2:30 yes 2:30 we'll start at 2:30.
byari byoroshye aho bwari mikorofone igihe nakuyeho nibagirwa kubibabwira mpita izi ngizi ntabwo nigeze zikora bashaka kuvuga hari izo nari nakuyeho ebyiri
We continue the meeting. This afternoon we have the last, not the least panel, the third panel of today. But remember also we have very important social events, cocktail. We'll be enjoying, not talking about anesthesia. I think no one will be talking about medicine, but we enjoy. Muri residence twabitanga no kwistressura. No kwistressura. Okay, don't miss this event. The chair of the RSA is busy in administrative issues. Now we are going to discuss teamwork and task sharing between physician anesthetist or anesthesiologist and NPAs. Remember, we said that we have a target to have 1,000 staff, NPAs. We were thinking to have 150 physician and anesthesiologists. But how can we achieve this target? Until somehow, at least we can achieve like 60. What if we achieve 60? Shall we manage shall we need the population needs in terms of surgery or safe surgery? The answer may be no, but somehow we need to do a kind of task sharing. Something like privileges, things like that. Probably I think this is cross-cutting. Obviously, guy like a Fanningoga can do C-section, but he will need to delegate a GP in Chirehe to do it. When it gets complicated, please send to the Chibungo, like things like that. Bellwether surgery, hernia. Let the GP for instance, do it, have a privilege to do herniorrhaphy. But when it comes to do a complex laparotomy, send to the hub center. We were talking about hub and the spoke, things like that. Those are task sharing, so that we can deliver safe service to our population. I will invite George, will be facilitator of this panel. George is assistant lecturer in CMHS. He's in charge of critical care, I think. Yeah. He will lead the panel on teamwork, task sharing between PAs and NPAs. Okay. The time is we'll stop. It's about 1 hour and a half. But we are running out of time. Probably we can take 1 hour and discuss. Then we will go on resolutions of this meeting. Thank you. We'll be inviting the chair of Rwanda Society of Anesthesiologists, Professor Banguti. We'll be again inviting the Rwanda Society of Obs and Gyn, Dr. Kano Dr. Ngoga Eugene. We'll be inviting Professor Nkusi for Rwanda Surgical Society, and we'll be again inviting Mr. Alexi. I don't see him. Please call him on the side of NPAs. We are honored to have Dr. Major Christian Mukwesi. Is the vice chair of RSA. He will be there for RSA as a panelist, and Alexi. There is a place there. Okay. Good. And the team now is okay.
Good afternoon. It is a pleasure to have this nice topic this afternoon. I know that it's not easy after taking our lunch, but we'll manage so that we can have an active participation of all. You are welcome, Professor Nkusi, Dr. Kano Ngoga. Would like to have your expertise in teamwork, but also task sharing among PAs and NPAs. So also the chairperson also will be interacting. So, but before moving toward the topic itself, we would like also to get experience from our experts in their specific specialties. How are they working as a team, and if task sharing is being done would like to get your experience, but also would like to invite the audience so that you may ask questions, and then we'll end up with a conclusion. So I'm going straight to Professor Nkosi so that he may share the experience in neurosurgeon.
Thank you very much, and good afternoon. The question before us is task sharing. I hope it is not task shifting. I think usually the problem that many people want to impose on developing countries is task shifting. And when you ask the people that are proponents of task shifting why they don't practice them in their own countries, they tell you that they have enough. So if they have enough, yes, we don't have enough, but we don't have to shift our tasks. We can share our tasks. So I think that's the discussion today. In neurosurgery, I am sharing with the team of nurses, the scrub nurses, and the anesthesiologists that put patients to sleep. And if you're lucky you have a resident, then the sharing of work mainly in terms of surgery is done with the resident. But sharing tasks, as we said earlier on, was you don't leave, for example, monitoring of patients to the anesthesiologist. I always ask them, tell them, I see blood is getting darker. In other words, I'm telling them about the oxygenation of blood. They understand what I'm asking about the monitor. So, what's going on? But in terms of anesthesiology, I've clearly part of neurosurgery don't have many people to share with. If you want my experience in other places, before we started the neurosurgery in Rwanda, there was a time when general surgeons were doing boreholes, I was told. Now you can imagine where the problem with task shifting is. When I'm talking about what was happening when people are talking about task shifting. If a general surgeon, the only thing he thinks about when something is in the head is the borehole. But if you have acute blood, it cannot be drained by borehole. So even if you made a hole in an epidural, a clot is not going to come out. But if we can manage to suck a bit, it is good. Now what we encourage like now, because all general surgery residents pass through neurosurgery, we teach them how they can make, let's say, a big, but that means you remove bone, so there is loss of bone, but you can save a patient by removing the clot. Don't target to remove the hole, because then bleeding is going to come and you'll fail. So what we've encouraged people to do, that's sharing. The general surgeons can evacuate hematoma and then evacuate the patient to right place. So you remove hematoma, close in one layer, send the patient to have definitive surgery. There are studies done previously in South Africa. There are some provinces that never had, I think I've only read about 3 countries where they tried it. So the Eastern Cape, I think, not Eastern Cape, Port Elizabeth. There was and then Pumalanga. So what they had done, general surgeons had learned how to do boreholes, like they do Nini, and then they evacuate, they suck Matoma bit, then close, and they think they have done the treatment. When they looked at the outcome, they did a study, they went and searched for 2 years, and then they compared these patients that were evacuated without surgery. The outcome was far, far apart. The outcome on evacuating patients was so good to the extent that they said, okay, they put, they started evacuating patients, all patients, and then they started looking for neurosurgeons to take there. So that's the experience I can give you about studies that were done on shifting the tasks. So for sharing, in terms of when I'm doing surgery and then I have an MP and an anesthesiologist, that's the routine work they do. Dr. Magari compared a plane, the takeoff, they are together. Most times we're going to be with an MPA. If there is any rough riding, then times during the course, they'll be called in or they come spontaneously to see, then towards exhibition again. So that again, they'll be sharing. Whether putting a neurosurgical patient to sleep can be left to MPs only, I think for Rwanda for now, I think unless the spine, I don't know, that one I've never followed up the terrace, whether they put patients for spine, but I know that for brain and aneurysms, all of us are tense, and we need to be together as a complete team. So for now, I can stop there and proceed from there. Thank you.
Thank you so much. This is part of your experience, and which is very good. And we should learn from experience so that we can move forward. We know that we have to move toward a safe anesthesia for each in Rwanda, and we still have few number of physician anesthetics, and yet the population need a safe care, but also with quality, safe care, but with equality. So I would like to ask for the Rwanda Society of Anesthesiologists, Dr. Christian. Do you think that task sharing is possible? If yes, how do we communicate in terms of sharing the task as a team?
Thank you, our facilitator. First of all, I want to tell you that apart from being a panelist today as a chair or vice chair of Rwanda Society of Anesthesia, I head anesthesia and critical care at Rwanda Military Hospital, and I have a strong team, and my team is made by now 3 anesthesiologists and around 28 non-physician anesthetists. We do share many tasks as anesthesia providers. And as you can notice, in a year, we can do like 5,000 anesthesia or surgeries. The 3 anesthesiologists cannot do all these surgery, or cannot give anesthesia for these surgeries. So they need to work with non-physician anesthetists who are well skilled, because at the end of the day, we do the same things. We intubate, we fix lines, we monitor patients, we do the same tasks. The only difference is that one is a doctor, one is a physician, another is a non-physician. So, as Professor just said, that most of the time we are at the takeoff or at the landing. Muko afande abivuze ya nakunziria comparison between anesthesia and airplane pilots. So task sharing is possible. It's possible because it's what we do every day. It's what we do every day, and we team together, we communicate. Of course, there are some cases which are somehow complex, and sometimes this task will not be shared, but the task will be done in team. For example, if I have to, we have to put asleep a kid or a baby of 2 days or 3 days or less than 1 month. This is heavy, even for the doctor. But he's the one assigned that patient to give anesthesia, and he will not do this case alone in Rwanda. He will do this case with a non-physician anesthetist in team. Okay, so I don't know how I can explain, or I can make this very, very clear, but you have to understand that we team together everywhere, and I'm here to tell you that I cannot do anesthesia without non-physician anesthetist, and I like this the way things are organized in Rwanda. So task sharing is possible, and it's yeah. And I don't know in Kanombe. In Kanombe, I like it. I don't know in other hospitals how it's. I know that some hospital don't have physician anesthetist, but in Kanombe we have a good team. We have a good team, and I'm happy. I'm happy doing or giving anesthesia with non-physician anesthetists, and so it's possible. And if there is something to improve it, I'll be happy to get some input to continue increasing it. Thank you.
Thank you, Dr. Christian. I may say a message, or I may summarize a message from Christian. He said, it's not possible to work alone, meaning we should value the teamwork. And he said it is possible to share or to do a task sharing, since if we cannot, or physician cannot work alone, is the same also for other health professionals. We work as a team. A multidisciplinary team is very needed to work for the safety of the patient. So I would like also to get the experience from Rwanda Society of Gynecologists, from Kano, Dr. Ngoga, so that it's a pleasure to share your experience with the audience. How do you value the teamwork, and how, as a gynecologist, in your area of expertise, do you think it's important to share do you think that it's important to do a task sharing?
Yes, thank you very much. First of all, I think we are now used to the sentence where they say, if you want to go quicker, go alone. If you want to go far, you have to go with other people. So teamwork is, without no doubt, something which we all need. It's not only in medicine, it's everywhere. So we don't have to take too much time there. Now, the concept of task shifting or sharing, when I hear that, my first question is, what task should I give and to whom? So it means that we need a definition of saying that if you are two people, we need to know this person is able to do this, and this one is able to do that. So once you define all the tasks this person is supposed to do, and the other one, and that's why you can say, okay, is it possible to take some of these tasks and give to that person? And how can I do it? When we say that C-section can be done by GPs, that's not task shifting. That's already defined in the curriculum. So it means from the beginning, people, they decide that a GP should be able to do a C-section. And from the beginning, you start teaching him how to do it. So I'm not sharing the task or shifting to him, but it's been taught in the curriculum that he's responsible of that. But if we say that now we are not enough gynecologists, we cannot go into the health center, let us see if a midwife can do a C-section. So that's becoming something else, because she has never learned that. And we need to decide, because there are too many, how can we manage to teach them? Of course, it will never remove me my responsibility of doing C-section. So I'm not shifting the task completely. It's just a way of solving issues, because we are not many to cater for our patients. So then will come the issue of saying that how can someone qualify to do this other task? So you have to teach, you have to validate, you have to follow up, And once you are satisfied that this person can do that, then there's a lot of process. So those are the privileging they are talking about. So sharing the task, we do it every day. It means that when we consider that a patient is, we need to consider a patient as, how do you call it? Not just look at your specialty. So if I'm going to do an operations, I need help from the anesthesiologist. And we all have to look at that. If I need to deliver a woman, so I need help from the midwife. She knows what she's supposed to do. She'll monitor the patients until maybe this stage and will come in to help. So there's still some confusion about task shifting, task sharing, so which must be, to me, must be clarified. If you want to shift your task or some of the task to another group, so that means that they need a proper training, they need a validation, they need to be recognized as such, so that when they get a problem, these things were there before. If you look at the history, before these councils they came in, so some of the doctors were training midwives or even nurses how to do hysterectomies. And some were doing very well. Then you remove it. He'll do the first one, the second one, the third one, you are successful, and then ni mechanic urabyiga nyine ukabimenya gutyo. When ihuye n'ibibazo, then you know where to call. But now we have regulations, so we follow regulations. You'll never go to do something you've never learned to do at school. So you need a permission, a special permission. The council must accept that. But I think this concept came for poor countries because we don't have enough staff. So people, they are trying to say, okay, you know, you guys, you must try to think where you have so many people, try to see if you can teach them some stuff. Like us, you can teach someone to put an IUD, which maybe was initially for the doctors. So small things. In our society, we even go even further to teach midwives how to do ultrasound. Not all ultrasound are risky. At least if you do ultrasound properly, you recognize this is a pregnancy, it's in a correct position, so it helps a lot. Instead of having a pregnant mother who's there, you don't know what's going on. So sometimes, but you need a validation process, you need proper teaching and supervision. So there's a lot of process for that. I'm happy to hear that anesthesiologist, non-physician, physician, the knowledge is more or less the same. So that's very good. So if you can reach that level, we'll be also okay, because we want patients to get the better. We are not going to cater for all the patients because we're still only like 90 or 95 people. So if we get at that stage, it will be fantastic. But it's sometimes a long process because you need to be sure that this person is capable of knowing where you're going, especially when it comes to operations. Thank you.
Thank you, Colonel Dr. Ngoga, for this good experience. But here he emphasized on if you want to go quick, go alone. But if you want to go far, it's better that you go as a team. So a team can make impossible things be possible because we work as a team. But when you work alone, you may go far, or you may go quickly, but you will be stuck somewhere. And then you will look behind and see, I'm alone. You will recognize that you are alone. But when you go as a team, you will realize you will do better things, but also patients will benefit from the teamwork. So this is a good experience from our experts that we should also learn from you and do have or give the best for our population. And here we all work for the population, for our community to get good service, but also to get safe care. I'm turning to to Rwanda Association of NPs. So I would like also to, we're talking, I don't want to go to task shifting, because task shifting is another issue. But here we wanted to do task sharing. We wanted to share tasks so that we can get we can give better services to the population. And yet we know that we still have a few anesthetics physicians. I don't want to say that we have many NPs, because we still also have a few. If we go to district hospitals, some will find only one alone there with emergency cases, and he have to give anesthesia. That's one. And you will find that most of anesthetics physicians are here in Kigali. I would like to, what is your expectation on this task sharing? Do you find it possible? Would like to get your point of view.
Thank you so much. Good afternoon. At the beginning, I had some confusion about the two terms, teamwork and task sharing. When we say teamwork, we know that the center of every person in theater is our patient. For me, when you say teamwork, I start by the cleaner who clean the theater, the nurse who receive the patient, the anesthetist who will give anesthesia, the surgeon and assistant who will operate, all of us, the pharmacist, all of us, we work as a team. That is what I call teamwork. But when it comes to task sharing, I don't think that I share the task with the surgeon. He does his work of operating, I do mine of giving anesthesia, the nurse does his or her duties also. So my task on the patient is to administer anesthesia. So here I want to say we have two groups. We have non-physician anesthetists who work with anesthesiologists in the same setting. If I work with anesthesiologists, we have to share the information about our patient. The surgeon schedules the patient to operate and gives us information. We do our anesthetic review or consultation. In the morning, we sit, we share the information with our anesthesiologists. We share the information within the team. In that case, we see what are the complications that you can get on that patient. What are the challenges that you may face on that patient? What about the type of surgery? The NPA is able to do that anesthesia, to administer anesthesia alone, or he will need or should need a supervisor, an anesthesiologist. Because we have our scope of practice. we can't go beyond our scope of practice. We know that if you are a diploma holder, you have your scope of practice, you can't go beyond that. But we also have the cases that we can do ourselves without the supervision directly of the anesthesiologist. But there's other cases we can't do alone. For example, in our scope of practice, we are not allowed to do neurosurgery alone. If I say to do neurosurgery, not operating, to give anesthesia. We can't give anesthesia to cardiothoracic surgery alone. We need to be with our anesthesiologists as specialists. But what I say, it is in the area, in the hospital, that have anesthesiologists. The second group is the group of non-physician anesthetists who work in the area where there is no anesthesiologists. What does it mean? They're alone there. They do what they know. If they're not capable, or if the patient, the case, is beyond their scope of practice, they transfer, or they ask for, ntabwo babatransfera, basaba muganga yuko iyo case ashobora kuyitransfera. But sometimes they don't get the consensus with medical doctors. You can find that the case that the medical doctor is going to do is maybe a simple case. But on the side of anesthesia, the NPA find that the comorbidities, the complication, the outcome may be the patient will need maybe to gukenera ibindi bizami bishobora kurengaho. In that case, birongera bigasaba ko ba bantu bicara bakumvikana bakaganira ku murwayi. Ariko ubundi ba bandi bo muri district, they do the cases alone. What we do as a association of non-physician anesthetists, we have our groups WhatsApp. Sometimes they get cases that are complicated because they were not complicated, but the outcome of the surgery. For example, Dr. Kanaka koze cesarean. Then hagati habayemo bleeding, PPH. Ntabwo umuntu ari bumutransfere, ntabwo ari bumugire gute, umuntu hagize complication runaka. So we have a group WhatsApp, we can share. Umuntu akatwandikira ati ngize case imeze gutya, this and this and this and this, and everyone can give his contribution or her contribution. But the problem is, if that NPA has a case like that, he or she will not get the time to go on WhatsApp and write this and this and this because he's dealing with that case. That is the main challenge of a non-physician anesthetist who work in a rural area and work alone. Sometimes there's at night, no one to call. That's a big challenge. But what we know, or what we can suggest, reka mbivuga uko twigeze kubivugaho. Hari ikintu cyari cyarakozwe cyitwaga, Dr. Pare wanyibutsa, sinibuka izina uko twarakize, kuba amajyaruguru hari umuganga runaka umuntu sorry? Yes. Hari ukuntu twari dufite abantu ba focal points ku buryo umuntu uri mu majyaruguru abazi ngo if I have a complication I can call Dr. Arkad, sharing ibyo mfite akampa ideas. But it failed. It failed. Sinzi icyabiteye kugira ngo bifailing. So kugira ngo ntaza gutwara umwanya munini cyane, task sharing, aho turi kumwe dushobora kuba dukorana n'anesthesiologists, it is very easy. Dushobora gucommunicatinga tukabwira complications tubona, ariko babandi bari muri batashobora kubabona ntibafite uwo basharinga nawe, uretse kuba dushobora gucommunicatinga hagati yacu, umuntu akatubwira case agize, complications zayo, then tugasharinga. Ariko nababwiye challenge irimo nuko ntawari udiringa na case nk'iyo, sometimes wenda ari na urgence umuntu abona umwanya wo kwandika. Thank you.
Thank you, Alexi. We are coming to the point, and it's where I wanted to tackle. You just pointed the problem. How can we now overcome the challenges? Suppose you are in a rural area, you are alone, and let's say that someone can have skills and experience to do so. But the problem here is, in his scope of practice, he's not allowed to do. And yet he's in an emergency case. It's an emergency. And you want to save the patient. This is a dilemma. We here present in this,
there is a small point we are missing. There is a small point. I would not like to miss it. The SDGs. It is question should go toward SDG. I know if we keep discussing about task shifting, sharing, we may go for long. But the point put there about the SDGs was to say the bottom line was 20 SAO. We made our plan as Rwanda national plan for surgery, anesthesia, and obstetrics. And that's why we have surgery and obstetrics, because it was toward the NSOP. And the number is very high. We've done the exercise for anesthesia, and we found we are required, from the articles published everywhere, to train 600 anesthesiologists. Because in the 20 SAO, they say 5 should be anesthesiologists. And when we have, from our vision, we say, no, that can't be done in Rwanda. 600 anesthesiologists, we can't make it. That should not be an indicator for our health system. We already say we will share our task as we are doing it. So it means 160 anesthesiologists and 1,000 of anesthesia non-physician will be equivalent to the 5 SAO. So when the WHO will come to measure in Rwanda in 2030, and they found we've trained NPAs and anesthesiologists on those numbers we are benching, then they will say you've met the indicators. Now coming to the surgeon, the idea was to ask you, when you look at, because in the 20, I think 10 is surgery, 5 will be anesthesia, and 5 obstetrics. It means we're expecting 600 or 800 obstetricians by 2030. Shall we achieve it? Or for surgery, if it is to achieve 1,500 surgeons by 2030, will you achieve the number? Or are you planning a way out by task sharing method? I think that was the main idea on this question. So sorry for maybe I didn't spend much to the facilitator, but that's what we would like to hear about surgeons, if they have a plan, or if they will train until 1,500 surgeons in Rwanda by 2030. Shall we have obstetrician trained up to even 1,000 obstetricians only for Rwanda? Or will you empower GPs to share the task with you? That's I don't know if the question now is becoming quite clear.
So maybe I start with Dr. Ngoga.
So thank you very much for clarifying that. It's not an easy task, but we need to find strategies. And I heard this morning you were telling Shema that they are against the Canexa. So now I'm asking myself, what else can we do? Because in anesthesia, maybe it's easy because the non-physician, they do most of the things. As Dr. Christian was saying, they do a lot of things. It's very difficult to maybe to make a clear cut between what they are doing and. But when it comes to surgery, either you know how to do this or you don't do. And the reason why I was just putting up this, what you said this morning, is because we found that with the way we are doing things today, it will be difficult to get those numbers. So we need to think another way around. So, and these colleges, they came to try to sort out this issue or to complement what the university is doing. I was discussing with someone this morning and said that the issue we're having when 10 gynecologists, they complete their studies, maybe UR will be able to take only 2 of them. Because that's the way it is. So they'll take 2 of them because of the budget, all of this. And I'm not saying these 2, that there's an exam they pass or there's some criteria they are using to say, okay, this one will be the academician. Someone was telling about academicians there. 8 of them, they will go and disappear in the air. So they'll go in the district hospital or provincial hospital or those teaching hospitals, we say that they're under Ministry of Health. The university doesn't have any autonomy on that. So you understand the confusions there. So those 2 will go to university. They are called academicians and teachers. The 8 going to the other hospitals, they are called clinicians. And on the road, the input of those 8 will be very difficult to see in terms of production of those numbers you are talking about. So the idea of bringing other system to complement what we're having, that's what it means. So if you create and say that we don't have to lose these 8, we need to capture them and say that this is somewhere we can also make a contribution of training other people. Maybe we can approach that number you're talking about. Of course, in our area, we are a bit lucky because most of the C-sections can be done by GPs. So if you have good number of GPs, the number of surgery will increase in obs and gyne because cesarean section also it's part of the target. The reason why they're talking about the figures is to see that in 2030 we can do the required surgery as the per standard. So we still have that chance of having the GPs. We need to train more and more and more in because already in the academic, in the curriculum, they are allowed to do C-sections, but they must do it well. But we need to get also a big number of specialists, and I'm not sure that if we just use one system, it's going to give us those figures. So I'm just again giving the message to Shema. Don't fight those ideas. Actually, I don't know if we have people here who 3 years ago we had a very good workshop in Rubavu, and we all discussed all of the things. And it seems that the idea, because we had everybody, all stakeholders were there. So we wanted to complement each other to see if we can reach. Actually, I think PS Nyamazi, at that time it was still PS. So they project something. They say, we as Minister of Health, we want to get there in 2030. But you are told us that no, we can only offer you maybe here 20%, here 30%, there 40%. And you cannot negotiate with the state. That's our plan. That's what we are able to do with our staff, with what we have. So that's why people, they start thinking that, okay, maybe this regional body can help and then increase the number of specialists. So I think it's not to fight what UR is doing, it's just to complement. And if you want to reach the target, as he's saying, the SDGs, we need really to train people. And I think we have people who want to be trained. So as long as we leave them aside, as again, lawyers, we need to attract them and use all the means. I think it's feasible, but where it's not feasible, we need to start thinking about how to get other people around, as we are doing with non-physician and anesthetists. We are lucky that we can, I don't know if neurosurgery they can do that, but we are lucky to use GPs, so we can push also to get good GPs, and then we can reach the SDGs. Thank you.
Studies can always guide someone to where you want to go. That's why when we do journal club, we tell people, careful with the article, careful with the conflict of interest. If I want to run a study to prove that whatever Mutangana is doing is unsafe, I will publish it. Because I want to make him out of the job, so I take all the job and I get all the money, and I'll publish a good article, but the bias usually will accompany. So I'm not challenging what neurosurgeons are doing, but I heard you saying the study showed that general surgeon doing hematoma evacuation was proven to be not very safe unless there is a neurosurgeon. That's what becomes safe. I've seen another trend in Rwanda where even the hernia is going to the urologist. The circumcision is going to the specialist surgeon. The PDA, no, there was this, the surgery you do, how do you call it? So it used to be done by the surgeon, the general surgeon. In Congo, there is even general surgeon doing it endoscopically. I think VP Shunt, the general surgeon, used to do, and they are doing it endoscopically in other countries. But some surgeons are proving that if it is done by a general surgeon, it will be unsafe. It must be a neurosurgeon. We have 4 to 5 neurosurgeons in Rwanda. Shall we advocate for transferring all the neuro issues to King Faisal and Kanombe? Can we start considering general surgeon to do some of those surgeries? Not for neuro only, even for urologists, orthopedists. They are pushing general surgeon away from everything. Are we not missing something in our training and trying to specialize everything? Can't we share with among surgeons? That's just a small challenge. And the GP, can he do some surgery so that if we don't achieve the number, he can come to rescue and do something? That is, it's a long question, but you understand where I'm going.
Thank you very much. I think it's very nice because the way we started in the morning, it should guide you the question you're asking. But when we're doing task shifting, we don't sometimes protect the people that we are shifting the tasks to. So you tell this chap to do the, say for example, evacuate hematoma, and the patient doesn't do well. What is going to happen next? I'm starting a worst case scenario. You know what's going to happen? There is a neurosurgeon that they would have gone to. So this guy is going to be in trouble because this patient has died and was not done by a neurosurgeon. Do we have a role to protect this person? The answer is no. Yeah? Because you have neurosurgeons. After all, this person was going to die anyway. But because it was done by a person who was not specialized in that, you're going to be sued. You understand? Now, going now on, as I told you as I was going to the worst case scenario, there has been a devil's advocate, but based on what we are seeing, they'll sue you if you do it. Okay? Now the problem is, we talk about assessment, the skill to assess. Sometimes we see a hematoma, but the patient is still stable. Now this patient can be transported and is worked on by a skilled person, a competent person that is going to save the life. So now, because we are not sure that we can train enough people that we are giving that job to do, but what that study was done by general surgeons, was not done by neurosurgeons. the South African one. I think maybe they were being sued or something, so they did it just to stop provinces from forcing people to do this. Maybe there was a bias from the surgeons who didn't want to do it. However, that's not the point. The point in Rwanda, I think we should go back to our capacity to train people. Now you mentioned that now Sheba is going to have more problems. The university, we know there are rules that the university follows to train a number, this number. But these colleges, we know that they can accredit institution. Dr. Ngoga talked about capturing the 8 out of 10. You use them where they are in their environment, and then they become trainers. That's one of the ways, which is very helpful. For example, today we are talking about, I think it was Chibogora, Jackson. Yeah, so Chibogora, Chibagaraga, I think Ruhengeri, they have been accredited as training institutions for COSEXA. There are things we look for. So most of us belong to different colleges. So I think what we would advocate for is to, now again, the colleges to come together and form again a team that can monitor and control the trainings. But I think thinking that you alone can train the number that we want in neurosurgery, in gynecology, orthopedic surgery, and I think may be a problem. And I had some people advocating also for trainers being a different board from the board of examiners. So if you're going to do all those things, university the body examining itandukanye n'abarimu siko bimeze ngira ngo mu mategeko ya university ntabwo ibyo ngibyo ntabwo birimo. Izo boards zibaho kubera iyo universities zigiye hamwe zigaformina nazo something like board of examiners bagakora bakazaga examining abantu hamwe. So to me, in terms of how are we going to achieve it in surgery, fortunately that is sinzi ngo gani option gani n'ubwo byafatiye hagati twebwe byari byaratangiye kera. So twebwe COSEXA mu Rwanda is considered as a high running institution. N'ubu mukangira ngo I'm supposed to go for a meeting with them. So twebwe ariko gani kubyari registerinze kera. So I think the HRH should look into what heck followed to look at the training facilitation ya COSEXA. Hanyuma manje si yari irimo turi ejo mu Muzari Grand Legacy. I think it was gonna, yeah. Whatever mention the benefit of COSEXA in terms, even how it's helping the medical school in the training of surgeons. Physicians bari badusaba kujoiniwe kugira ngo, so iyo tuzifite ari nyinshi blood facilitating mu training that the bigger number that we intend to get. Sinzi ko natwazikoresha some countries what they've done with the NSOPs, like Zambia wazireba what they've done, they formed their own college bagasinya MOUs na different institutions bakareba nk'iya obs and gyne, iya pathologists, iya surgeons, CONEXA, izo zose zikaba part zikabafasha muri training. So igingira ngo natandikire simbizi ariko niyo nagiye muri how we can achieve the numbers using the resources that we have. The resources that we don't even need to put too much resources to to use them, like the colleges, kuko ziri abaganga bacu bazirimo, they can easily come and they can start training. Ngira ngo ndetse mwari hari n'amavuriro accredited already that they are ready to set off. So the numbers using different training modalities zashoboka kuba twagera bugufi yazo, nubwo wenda tutazijyaho nka za zindi, ariko we can achieve a bigger number than using just the university. Byombi tubirimo, so we know the difficulties dukoresheje kimwe niyo dukoresheje byombi. So ngira ngo in terms of numbers, I think we can achieve a lot. Kuko nk'uyu mwaka there are so many general surgeons that are going to qualify, be it in COSEXA, be it TR. Orthopedics the same. Mu Rwanda ariko usanga tugira double qualifications, so the numbers don't get too much because of double qualification, but for the people qualifying, they are benefiting from them. Since the question yari ambajije ngira ngo yarebaga, but that's, to me, I would encourage to have different sources. The task shifting, kuvuga ngo twagira n'abandi bantu tukabaha privilege kuzo gukora ibyo urumva nanone ujya guforminga kandi ka group kajya kwigisha abantu, kajya ibi ngibyo kubikora washyize effort mu train the right people for the ukabi encouraging. Nanone tugumye ko tumaze baza bavuga abagenda retention. I think Dr. Jeremy yagize kuvuga ku bintu bya retention, education retention. If we train, yes, we can train many, but we should look at holistic approach to the people we are training. No training, ariko no facilitating kuhaguma. Uga training 10 babana 8 bavuga bagiye mu district, bazaje kujya kubashaka aho bari. Ariko nibaza amazi bajyaho bacu. Tuvuga mu training benshi. Bajya kubashaka kujya mu training bakakubura. Baba baragiye ukumanga baje mu bihugu binini, abandi baje mu public health. So we need to, as we look at targeting the number, we should look at incentivizing the people that we train to stay around. And I don't think we have the capacity to task shift. Thank you. Ikindi ntabwo turyamye general surgery. General surgery yigize kuvuga ngo barabikuramo byose. That's the problem is specialization. It's not a problem, it's a good problem. To me, I take that as a good problem. General surgery ntabwo wibuke ko mu Rwanda general surgery yacu ntabwo developed the way we want it. Dukeneye hepatobiliary surgeons, dukeneye colorectal surgeons, dukeneye, so look at it in that context that we should develop the general surgery, bakora bya bintu bya general surgery aho kujya gukora bya neurosurgery. General surgery bwayo turacyabibuze, barajya gukora bya neurosurgery, bashaka kujya gukora ibya orthopedics, barajya gukora ibiki. You understand? So mureke abantu b'ibyo ahubwo dushyire effort mu kuyigisha, to incentivizing no kwiga ibyo ngibyo twabuze nka za hepatobiliary surgery. Uziko tutagira vascular surgeon, we don't have a hepatobiliary surgeon, we don't have a colorectal surgeon. You understand? Sawa rero surgery ni nini cyane, nicyo gituma rero nanze kuvuga ibya neurosurgery gusa. I'm representing surgery. Murakoze.
Thank you, Prof. Kosi, for your intervention. And we are rushing with time. We still have a lot to do, and we are sending again the message to our key partner, who is the Ministry of Health. So we need to maintain those people at working place, because most of them are moving for others, and yet we still need them. It will not be possible with 2030 to have 150 physician anesthetists and to have 1,000 non-physician anesthetics. And yet there is dropout. We are training, but part of the trained people are dropping the career. So we need a sustainability so that we can maintain them at their working place. Also to the university to be supported so that to get sufficient lecturers, not sufficient only in quantity but also qualified teachers to maintain the programs for both PS and both non-physician and anesthetists, so that we can meet the development goal strategy. We can't end the session without getting questions from the audience. Audience, you are welcome to address questions either to panelists, or if any suggestion to the Ministry of Health, you are welcome.
Thank you very much. I have a small question. It's probably about understanding. You're talking about, I'm addressing this to Professor Nkusi. You're talking about the board of examiners to support the University of Rwanda. Of course, I'm looking at the numbers, the SDG numbers. For example, we are talking about having 1,000 NPAs in 2030. That's 9 years from now, and if my calculations are correct, we are requested to train more than 100 non-physician anesthetists per year to graduate them, that number. And I think it's impossible with the means that we have currently, talking about the human resources, but also the hospital capacity for training them. So how are you proposing this board of examiners to support the University of Rwanda in achieving those numbers that we are targeting for the 2030? Thank you.
I didn't mention, I didn't say, no, there was a question previous from the different earlier on, before noon, where I think it was a resident or a person who's qualified, who was asking, who was suggesting that the people that train at the university shouldn't be the ones that examine them. I remember, I think the question came from Jackson. So I was giving that example that actually when you are in the colleges, you do not examine your student directly, the one that you are the one supervising. So I was talking about having if, for example, we had a college where all universities, if you have many, that are involved in training. But if it is one, unless you get the people from outside, but you cannot have a board of examiners if you have only 3-4 people training, that are training students. But if you have different institutions that are involved in training to standardize the qualification, then you have board of examiners that are involved, at least per specialty you can have one person that represents like a senate that's going to stand where the people are being examined to assess the fairness. That's the context the board of examiners came in. Not to increase the number. The increasing the number for me, I'm suggesting that we embrace different training institutions but standardize their exit exams. I don't know if I answered your question.
So I would like to add something to those. I think, Prof, we can make a difference between two levels. the awarding certificate and the licensing. The university have a project which so-called curriculum. And when you exit the curriculum, which is a project, they give you an award of having completed their curriculum, which is a project they made for you. You finish it, they give you an exam, and they take even the ability to call an external examiner to see. They give you their award. But they don't impose the government to give you the job. That's why we accept our students to go to the board, to the licensing board of the medical council, the nursing council, because we know that our certification of award that should not impose every employer to give you a job. Then you have to take the other council exam, which become like an external board out of the university to give you a licensing exam. Then those council give exam to URA, to Mount Kenya, to whatever. All the nurses from Congo, from wherever, take that exam to like harmonize, to say whoever passed this exam, from wherever he comes, we will give him a job. So I think that board, for now, is playing a good role, and it is like an external board to the universities. Then it puts pressure to the university to train them better, because we used to have a big number of failure. And then the university had to raise up the level to make their students passing the exam of the board, which is a good board for Rwanda. And I think for if East Africa can make another one, or if we can make others for at a level where all the qualification, nurses, doctors can pass it, that will be something to encourage for the country. Don't know if I...
For example, on next Friday, we'll be examining, for example, neurosurgeons. So there are standards for exams. For example, you're going to go through 6 stations of having different cases, and then 2 courses. Now, this has 2 examiners per station, so you're having 12, irrespective of the number, even if you have 2. For example, we're going this year, the whole of COSEX are starting 14 countries, plus 18 countries. We're going to have 2 neurosurgeons who are going to be doing exams. So it's a loss. 2, but you have to look for 12 examiners. So we're in a matter of breaking each advantages and disadvantages. Yes, you have standardized, you have put set a program, every person must come through this thing, irrespective of the numbers. So they have to go through that. So it's standardized. When a person whoever passes through it, you know, is meeting the standard. So for the COSEXA region, for the surgeons, that is there. CAMEXA, you the same. So what we were suggesting was, if you meet all these plus university, also becomes a high-running institution. So we have, say for example, 6 high-running institutions. They form their own collegiate body. Then they have some, the one for quality, another one for exam, teaching. You have different bodies under that in Rwanda. It will meet that what you're suggesting now. Instead of making it the council is supposed to be a regulatory body. Now it's doing exams. That's wrong. You know? So it's supposed to have something else, a body that meets all this, makes people meet standards, but then the other people see, oh, you insist. I'm practicing well. You understand? So it's good because they are doing it, but I think we should not think it is the standard way of doing it. Thank you. Want to add something?
Maybe just to add a little bit on this. I think all depends on the system people they are using, because sometimes it looks like difficult to conceive. You are finishing in the university which is well known in the country. You have your degree. You've went through all the exams which are needed, and then you go back. You go for another exam with the council, and you fail. So something is wrong there in the system. So we need to trust our learning institutions, and when it's necessary, have a combined board for exam, which makes more trust. So meaning that you don't only have maybe the people in the same university. You can have, if you have so many universities, you can have different people from different university. You can have maybe other professionals coming, and that's exit exam is automatically recognized by the councils. So there's no need of repeating other exams for those students. We should reach that point. Otherwise, we'll have always conflict between who's providing the teaching and who's going to employ and to regulate. So
I thought it was only in Rwanda. Last week we had open heart surgery. The chief surgeon told us she finished cardiac surgery in 2018 in the university. But she waited until 2 months ago to take the board exam. In the institution where she was working, she was practicing as a surgeon, but the board couldn't certify her until she take the full exam of the Board of America. So it is not only Rwanda. Even if she failed that exam, she will continue practicing in her university, in that hospital, but she will not be certified on the American board. So I think Rwanda is not really doing wrong thing. I think we are on the page. I don't know in South Africa, maybe if you finished the MMEds, to practice, must you take the fellow, or you can practice independently without the fellow exam? I don't know. Is there an exam in South Africa from the board?
No, in South Africa, like maybe now it's one system, but when we are there, there's like 2 systems, and maybe one going to the other one. So people, they have so many universities, and when you finish when you are close to qualified, so there's other college exam, which is you have different teachers coming. Some of them you don't know, even you've never met with them. So maybe one from university will be there, and the rest, like 8, will be from other university. And then they'll ask you questions like everybody who's there, and then the way you reply, so they have the way of looking at it. So when you finish, if you pass those exams, automatically the Health Profession Council will register you as a specialist, and you can start working. So things you're talking about America is they have that system. It doesn't stop only there. They'll continue, I think, every 5 years to pass exams, which is a very good thing, which you should bring here one day. Eh? So it means once you've passed, don't think now you are the king forever. So we need to look at 5 years later. Who are you? Are you still the same person of brilliant? Are you still the same doctor who were really intelligent that time? Or now you've, because of so many activities, you don't remember how to do. So that American system is very good. Every 5 years you go through an exam, and the board will approve again. If you don't have issues, then they'll maybe help you the other way. But we still have to see what system to take.
They have 2 systems in America. It's so-called board eligible. If you're board eligible, you can practice, but you cannot go into private practice. You can practice. If you want to now go and get registered, they have national boards where all universities have made a congregation. It's not board like not council. It's a board of universities, board of exams. So if you are eligible, they write. Your university will say, this guy qualifies to do exams, but has opted not to do exams. So you keep practicing, you practice, but you're not qualified. Now, the day you decide you want maybe to go to travel internationally, so now you can choose this time to sit your exams, and then you become board qualified. Some people used to confuse. For example, the ACS, American College of Surgeons. That does not give qualification. No, that's just a recognition. So they induct you, something like that. Like now, if I'm registered there, I can become a fellow of the College of Surgeons of America. But I've not really done exams. You understand? So the same thing with the American Association of Neurological Surgeons. I become a fellow, but I have not taken exams. But the board of exams is the one of joint universities. So they sit, you qualify. You can practice for life without writing that exam, except you do the exams of the councils for you to continue practicing every 5 years. Yeah.
Thank you. I know that it was very interesting to have our seniors talking about their experience. I think we can't end up. So maybe, unless if there is a pending question to which we did not respond, if not, maybe I can call the chair to close the session. But we would like to thank all the participants, the panelists, and you audience for your active participation. But also remember that we have to do something. Either you cannot meet the development goal, but we can still do something since we have few physician anesthetics. We did not also meet the number for NPs, but we can always share knowledge, but also share the task, so that we can give the best to our population. Thank you very much.
Okay, thank you, panelists, and thank you, George, to lead the panel. We are at the end of this meeting, as we are celebrating Anesthesia Day in the world. Now it's time for resolutions of the meeting. We've been talking various issues, your interventions, your ideas, but we want to do a kind of a summary and do resolutions. Professor Banguti will help us to issue resolution of this 2 days meeting, and closing remarks. Then we'll go for cocktail, social. I like it. Okay.
Okay, thank you very much. Please allow me to say thank you very much to the whole team, starting by the Minister of Health, who sponsored and encouraged this activity to be. I think 1 month ago, I shared the letter of endorsement of this activity from the Minister of Health. So the Minister of Health fully endorsed on an official letter this activity, because he supported Anesthesia team in Rwanda to meet and discuss and share their problem, their issues, and come up with resolution. This morning, I had a note from the Minister of State, who also, before this activity, wrote, called for a meeting with all the anesthesia stakeholders. It was an online meeting chaired by the MOST himself, and the principal was there, the deans. Alexi was invited, but I think you were, did you attend that meeting? Did you delegate someone? But all of us were invited. We had the meeting with the college, and the dean of the health sciences was there. She delegated the vice dean. So we had a meeting, and the minutes were shared again in the community to know about what the Minister of State think about anesthesia in Rwanda. And you could see in the minute, which was public and shared, that they are expecting a lot from our resolution, from our ideas to guide the way forward. We can't say much about even the principal from the College of Medicine who was here, and you could see that from one question she took her time to express her need and wish to work alongside with us to come up with a strong program and strong cadres who will not be only professional but also academic leaders for anesthesia in the university. And she's very receptive to all partners to work with her. So we can say that this meeting is not only an RSA meeting, it is a teamwork meeting. And it falls into this theme of the year. The main theme of the celebration was teamwork for good collaboration and safe anesthesia. And we celebrated really in a teamwork spirit. And we really say thank you to all of you. Special thank to Shema, Joseph Shema. I was telling him, I say, my friend, I want to call you Joseph. And he said, no, if you want to call me Joseph, unless you become also an American, because only American call me Joseph. All Rwandan call me Shema. So I told him, yes, I want to also become American, so I will call you Joseph. He said, even my father, they call me Jeff. And you, if you want to become American and call me Joseph, you have to stop eating ugali, because I know you like it as an African. So those are some jokes. So Shema, we call you again Shema. Thank you very much for standing throughout 2 days, sitting there, inspiring us, taking us through the strategy, because that book called Strategy is essential for all development. And so it took us through that book, and I'm sure from this meeting, many of you will get immersed into that strategy, and we can do together the M&E of that project, monitoring it. Every time we meet him and say, but you plan in 2024 to reach this number, but we are not yet there. So that will be reminding him about the promise. And it is signed by the Prime Minister. So feel free to remind them about the commitment which is in the strategy. Special thank to the School of Health Sciences. Your team really organized this meeting. Dean, I thank you very much. The head of department, Thomas, organized some meetings to organize this conference. And a special thank to Aline. I don't know where she is. So if I'm proud now to give resolution, it's because there is a strong lady behind. So you see her on her computer. She's putting together all the resolutions, or everything we are discussing here will be documented and submitted to the Minister of Health. So she's doing the whole work. That's why you can see me with my phone, very confident to go through the resolution. It's because a strong lady is working behind, and we are thankful about that. And we know together we can do a lot. That's part of task sharing. We can do a lot together. So few resolution before we call upon HOD Shema for closing the meeting. Few resolution starting from yesterday. First resolution was about the background of anesthesia in Rwanda. So we agree that we need to restructure the program, especially the NPA program, by reconsidering the entry profile, considering the content, considering the delivery method, evaluation methods, and the duration of the program. And we were requested to come up with a reasonable entry profile. If we think nurses should be the entry profile for doing anesthesia,
it is up to us to define, shall we combine, shall we phase out the existing and only look at nursing only. For that, the Council of Nurses is there. We will have for sure meetings to agree on what we are the resolution and what will be the requirement from this nursing council. Another resolution was about gap in current education and practice of physician. We agreed to revise the program of anesthesiology in the College of Medicine and Health Sciences, School of Medicine, from anesthesiology to back to anesthesia and critical care. Because there is a lot of complaints. We finish as anesthesiologist. There is no way writing critical care. Why do we have to take critical care in our practice, yet we are not certified for it? Why don't we reconsider the curriculum and become anesthesia and critical care? Even the teaching should change, everything. So when we finish, in our name, critical care appears. It is done in Uganda, it is done in Kenya, it is done in Tanzania. Why not in Rwanda? And we discussed about that when where the name was wrongly changed by the visitor Canadian who took the name from their practice to Rwanda. It was sound Canadian and very good at that time, but now we are not happy with it. We want to go back to anesthesia and critical care. So it has been a resolution for the School of Medicine to consider, but the head of department who was here will take it through the whole channel and all the requirements will be submitted. Another resolution was about how can we address current gap challenges through education and the policy makers. So the college, the CMHS in collaboration with HRH should help the increase the number of teaching staff by recruiting qualified international and local permanent and visiting lecturer. So I think that resolution was well illustrated by the principal who came here and showed us the wish she had, but she can't move because of the limitation in the budget. That's why the HRH in his mandate has to reinforce the college how to have good staff and faculty for anesthesia training. So if the masters in nursing anesthetists, which pathway for the existing NPAs? So the resolution, there is many, we've said a lot, but what we take as the main point was we want to have one identity for Rwanda. That is the wish. People should not be changing names from one name to another one, depending on what and who is leading. And one time it will be someone else coming and say, no, NPA is bad. We go back to this. And another one comes and say, no, now we'll be speaking another language, you change. So you say, we want to be called nurse anesthetist. Please show us the requirement and we will be ready to fulfill. And if we can't fulfill, then we apply the existing scope of practice. The clinical officers, anesthetists will stay clinical officers, and the nurse anesthetists will be called nurse anesthetists. But the wish of the team which worked with Dr. Nsereko was, if possible, people should be shifted from NPA is not bad because it's being used many places, but recommendation to make all the anesthesia practitioners who are not doctors to be nurse anesthetists, if possible, if the nursing council can facilitate that. That is a recommendation, the resolution, we will work on it and see what is feasible. So the sixth was, the last was the remark, and the DTLE give us some recommendation how to come up with a good curriculum. Because many of the time, we teach differently from what we wrote in the curriculum. We do a copy-paste of curriculum, but we are applying another method of teaching and assessment which doesn't align to the curriculum we wrote. At the end, we are very good in a project which was not written. And we failed on the project we wrote because we don't apply what we write and we assess what we didn't write. So it become wrong. That's why when heck comes, people start cooking. Because they know heck will check what is written, what is done. And heck may close some programs. So it say, if you want to start a program, please, you have all the time to consider the end products and write it into your project. So you'll work toward what you want to be. So those were the decisions for yesterday. From today, it was mostly discussion around, the first panel was about brainstorming around scope of practice, standard of practice, and liability insurance. We all agree that it's not easy to talk about liability insurance, but at least we did a lot just by brainstorming and giving idea. We are sure those stones thrown today entered in the goods agenda from the HOD. He wrote a lot on the liability. I'm sure in the coming days there will be another high-level meeting. We try to tease a little bit. Say, hey, we are thinking about it. Can you tell us something? And there will be a high-level meeting to discuss about these liabilities, making people talking. By the way, next week there is a TV show. Yeah, RSOG, RSS, and RSA. We are invited in the square, so we need to go and discuss. We need to have time to discuss, to just brainstorm about what we will discuss, but we will communicate to you about that TV show. We will discuss again about anesthesia, risk, surgery, risk obstetrics. Another point we discussed today was about capacity building through education, and and we had a lot of points we discussed around. They are being put in place, but we'll share the ideas with the leaders. The last but not the least was task sharing toward SDGs. This was put just, I know the NSOP, the leaders on the NSOP are RSS, Rwanda Society of Surgeons, Rwanda Society of Gynecologists, and RSA. We are all together on that. So I throw it there just to make our partners in that NSOP to brainstorm again about 2030. We have indicators to meet. Rwanda met the MDGs, and we're proud, one of the countries in Africa who met the MDGs. The SDGs is there. Now it is 9 years to go, or 8 years to go. There is indicators, among them, NSOP. Shall we meet those numbers, those dictated number, or can we come up with our indicators to defend, so at the end we can achieve them? So with those recommendations and resolution, I will call upon the delegate of the Ministry of Health, Shema Joseph, who is the head of faculty recruitment and academic partnership, to give us the closing ceremony, the closing remarks, before we go for the cocktail. Joseph.
Which is not
Felicien. So we talked about it during answering question from Felicien from Kanome. We told him that when we think about that, it was about to discuss about scope of practice and standard. That's why we invited Tadeu Vuguziga. You will see was the one planned for the session, the panel number 1. If you can see here, panel number 1 was supposed to be discussed by Tadeu Vuguziga, who is leading the exercise of the practice for medicine. I also called the other councils, but it seems like they've received the mandate to work on the scope of practice for different practitioners, and when they finish, they will have different meetings before taking the whole document to the ministry. From there, when the scope is signed, there will be a ministry order. So the councils are not ready to release or to take us through. So we couldn't talk about something which the councils are still working on. That's why we said let the councils, let us leave the council, will be the one to communicate to us about the scope. About the standards, again, I called Dr. Prof. Ramasirabo. He told me that the volume, the book has 15 volumes. We've put together, but it's not yet compiled and make the minister to sign it. So we can't produce the last document here while it is still in the Ministry of Health. So I couldn't proceed with that exercise. Okay, sorry for that.
Thank you so much, Prof. Paulin. I can just say all protocol observed. We thank you to have that idea to convene all health professionals, if I can say it, doctors, obs and gyn, neurosurgeons, NPAs, doctors, anesthesists, specialists. I would like to thank you for that initiative, and Professor Paulin is always teasing me to have you really have the vibrant discussions. Otherwise, we are not against any colleges. As you can remember, on the big discussions we had 2 years ago in Gisenyi, while we were preparing for the National Strategy for Health Professional Development, if you read well the National Strategy for Health Professional Development, there is a paragraph talking about colleges. And you have good examples of the College of Ophthalmologists and the outcome that it's giving to the country. So what we are advocating for is just to be ready and well prepared so that we can't embrace a new initiative while we still have big challenges into organizing and sustaining the existing programs. As you can see even in the discussions or even all the resolutions is talking about task sharing. That's what I noted, filling the gaps, sustainability, harmonization, leveraging, regulation, capacity building, scope of practice, which is still challenges, and all of this need really to be regulated, and this will bring to the, not only to the Ministry of Health, but specifically to the HRH through the implementation of the National Strategy for Health Professional Development to mobilize support to have this done. So this is a good initiative, and I know that this is an introduction of a big discussion that will follow. As you see, there is still some pendings that we need to discuss more, some documents that need to still review, but you have all the support from the Ministry of Health, and especially the Human Resource for Health Secretariat, whom we thank Dr. Patrick, who was here for the opening ceremony. And we have all the apologies from both ministers who couldn't come to be with us to open or to close this big meeting, because today they have a cabinet meeting, so they couldn't come. So, but this is to ensure you that you are in the priority of the ministry, you are in the priority of the National Strategy for Health Professional Development. That's why we suggested to have at least one person to spend the 2 days here, to be with you, to look at the recommendation, and even before officialize those recommendations, at least to have some notes to be discussed before that, so that we can take a move and a step forward addressing all those challenges. We are here to support, we are here to align, we are here to help regulating all health professions in Rwanda so that we can achieve the SDGs and toward the quality of health care provided to the population of Rwanda. So without taking much of your time, I thank you so much and would like to invite to the cocktail that is prepared outside. Thank you so much. May God bless you. And happy 175 World Anesthesia Day. Thank you.
Thank you, Thank you all. I think we can take a photo, group photo. Remember, take group photo. I don't know if we can be observing COVID and have a group photo here. Yes, we are negative. Good. And vaccinated. Fine.
We are all negative and vaccinated.
Please, you are invited all. Come here and have a group photo, then we have our cocktail.